Check.
To introduce Dr. Diola, Rio Diola. She is a physician and a registered respiratory therapist. Dr. Diola has an advanced training in ECMO, chest ultrasound, and respiratory care, critical care, and she's currently serving as a head of intensive care unit at St. Lucas Medical Center. She's a founding member in the Philippine Society for ECMO and an international fellow in American Association of Respiratory Care. Please join me in welcoming Dr. Diola for her presentation on oxygen therapy.
Good morning. Thank you, Dr. Taha, for the kind introduction. So I'd also like to thank Mr. Hassan Al-Uraini for having me here. And also I'd like to acknowledge the presence of course, Dana Evans, the president of the AARC. So I am, again, Rio, so you can call me Rio. So my topic for today would be the oxygen therapy, the fundamentals. So we will be describing the process of the systemic delivery of oxygen, the methods to how to determine the adequacy of the systemic oxygenation, the signs and symptoms, and the cause of low blood oxygen levels, therapeutic interventions, define the potential adverse effects of oxygen therapy, and we will describe the steps to minimize the patient harm during oxygen therapy and discuss the various devices used for the oxygen therapy and the steps for safe use, handling, and storage of oxygen cylinders, and to determine how long oxygen cylinders will last until empty, and of course, options to provide home oxygen therapy. So we will start with the terms and abbreviations. So first of all, we have to define the hypoxemia. It is a lower than normal oxygen blood level. So there is a term called hypoxia, which only means that the oxygen is lower than the normal. So hyperoxia is higher than the normal arterial oxygen level, wherein oxygen therapy is the administration of supplemental oxygen. FiO2 is the oxygen concentration expressed as a fraction. So we will be expressing it as 0.21 and among others. So we will also have the barometric pressure or the atmospheric pressure, which is PB. Okay, so the partial pressure of inhaled oxygen is PiO2. So P with the big letter A and O2 is expressed as the partial pressure of oxygen in the alveolar gas. So you have to define that it is a big letter A. So the P, small letter A, O2 is the partial pressure of oxygen in the arterial blood. We can get this through the ABG, of course. So the PaO2, the small letter A, over the FiO2 is the ratio of the PaO2 to the FiO2, which is the PF ratio. So the AA gradient, the P, A minus A, O2, is the difference between the PaO2, the big letter A, and the P, small letter A, O2. So we have the oxyhemoglobin, the HbO2, which is the oxygen-enriched hemoglobin, and the CO2 Hb, or the carbon monoxide or the carbodioxy hemoglobin, is expressed as COHb. Okay, So you will be tackling this in the next few slides. So I think I should be here so that I will not be covering that part. Okay? So ABG is the arterial blood gas analysis. So the SaO2, oxyhemoglobin saturation, measured in the ABG. So if we get the oxygen in the arterial blood gas, the oxygen saturation is termed as SaO2. But if we use the pulse oximeter, so the probe that we will be discussing later, it will be termed as SpO2. So oxyhemoglobin saturation measured with the pulse oximeter. So the CaO2, which is the oxygen content, total oxygen content, which is dissolved and as oxyhemoglobin. So the oxygen content in the blood. So the the VQ, V over Q, is the ratio of the alveolar gas to the pulmonary perfusion. So we will also be discussing that, the VQ. Okay, so other terms, O2 delivery devices like the cannulas, the masks, are used for the O2 therapy. So there's a term called a low-flow delivery device. So the majority of these patients comes from the atmosphere. So it means that if the patient is being given by a low-2 oxygen delivery device, some of the oxygen were diluted by the atmosphere. As compared to the high-flow oxygen delivery device, all of the patient's inhalation comes from the delivery device. So it will provide a precise oxygen concentration. So there's also a term like HALI, or the hyperoxic acute lung injury. It means that we are giving so many or more oxygen concentration to the blood. So it is caused by a FiO2 of more than 0.06, or if we give FiO2 of 0.06. That's why when we give oxygen therapy, we need to decrease it below 0.06 of FiO2. So oxygen concentrator, it is an electrical device that extracts nitric oxide from the air. So how do we enable aerobic metabolism? So the normal adult requires approximately 250 mL of O2 per minute. So when you inhale, you needed 250 mL of O2. So to O2 delivery to the cells, okay, sorry. Okay. So O2 delivery to the cells must remain uninterrupted. So if we deprive the oxygen of 3 to 5 minutes, it will result to a serious harm. So what harms are those? It may cause a stroke, it might cause a heart attack, so among the others. So majority of the O2 transported as oxyhemoglobin depends on the normal quality and quantity of hemoglobin. So if the patient has anemia, the oxygen saturation will also decrease, and also the oxygen concentration in the blood will also decrease. So sometimes if we're giving enough oxygen to the patient and then the oxygen saturation still not increasing, probably we just check on the CBC so that we will know if we have the adequate hemoglobin to deliver that oxygen that we are delivering. So a normal oxyhemoglobin saturation is 97% when breathing an FiO2 of 0.25. So it depends on the VQ also. So the normal VQ is 0.8. So if there are changes in the VQ or there's VQ mismatch, it will also impair the oxygen delivery. So how do we determine the adequacy of the oxygen that we are giving to the patient? So increase in FiO2 elevates the blood oxygen. So we titrate to attain the desired PaO2 of the saturation level. So for example, if we give increased O2, we can check the saturation of the patient, the oxygen saturation, or we can get the arterial blood gas. Arterial blood gas is a direct measure of the PaO2, or the partial pressure of the partial pressure of oxygen in the arterial gas, and the SaO2, the saturation of oxygen in the arterial gas. So this is an invasive procedure, the most accurate, and it allows the calculation of the ratio of the PF ratio, the PaO2 to FiO2. So this is the most or the best method to give the adequate assessment of oxygen delivery, the calculation of the ratio of the PaO2 to FiO2, or the PF ratio. So you have to remember that. So pulse oximetry measures the SpO2. So meaning, you just check on the probes. So because it's pulse oximeter, so it says it's SpO2. It is a non-invasive but best method for continuous monitoring. Of course, we don't want to check ABG every hour, so because it's too painful. So we need the pulse oximeter. So it is subject to artifacts, meaning if the patient is very agitated with motion, so it might go down, the SpO2, the perfusion. If we give so many inotropes or vasopressors, there will be decreased peripheral perfusion. So probably our SpO2 will go down, and if we check the SaO2 on the arterial gas, it is normal. So sometimes it has subjects to artifacts. And also skin pigmentation. So if the patient has, sometimes nail polish will also decrease the SpO2. So in my hospital, sometimes we remove the nail polish because some of the girls have gels, so we also remove that. So that's one of the artifacts that we don't want to have. Okay. So again, monitoring O2 delivery. So we have this one-time spot check using a finger probe. So we have to bear in mind that we need some, the manufacturers should be, meaning we have to get this one-time spot check finger probe to a reliable source, because sometimes the oxygen saturation is not really calculated, or it's down as compared to the usual. Okay. So continuous monitoring probe using a finger probe, the middle one. So I think most of the hospitals also have this. So for me, I think this is most reliable as compared to the one-time spot check, but because sometimes it's really manufacturer dependent. So of course, we have this continuous hospital monitoring using finger or other site of the probe. So you can see it in on the monitors beside the patient, or there are also monitors, hospital monitors that are used during transport. So pulse oximeter is a non-invasive alternative to ABG. It detects changes in or via the light absorption. So oxygenated blood, bright crimson red, and the oxygenated blood is bluish. So it also measures the pulse rate. You can see there are two numbers there. One is the pulse oximeter, or the O2 saturation, and the other one is the pulse rate. So hospital units have alarm systems. So also in the probe, or the continuous monitoring probe, they also have this alarm system. You can set it if you want the pulse oximeter or the SpO2. You want the alarm to be as low as 88. It will go alarm, or it will have this blinking, or sometimes it has sound. So you will be updated if the FiO2 or the oxygen saturation goes down. So we have this, next is the hypoxemia. So we have the acute versus the chronic hypoxemia. So for the acute, it is a sudden onset, of course. The tissue oxygenation is immediately disrupted. It can result from a serious trauma or exacerbation of the chronic lung disease. So sometimes COPDs, if they have exacerbation, we can also call it as acute hypoxemia. We need to provide oxygen therapy while treating the underlying cause. So, you have to, of course, get know what is the underlying cause, why the patient has an acute hypoxemia. Could it be like pneumonia, or could it be like the patient has a heart problem, like an MI? So we need to know what causes the acute hypoxemia. So for the chronic hypoxemia, it is a prolonged onset over time. Sometimes, or most of the time, if the patient has a chronic lunger, you can hear chronic lunger, or the patient has a chronic lung disease, physiologic adaptation occurs. So they don't need a very normal oxygenation or PaO2 for them to survive. Sometimes just PaO2 of 60 or 55 is okay with them. So results in irreparable damage to gas exchange, like in patients who have COPD and interstitial lung disease. So this have irreparable damage to the lungs, and it can cause changes in lung exchange. So we need to give them long-term home therapy if needed to minimize further tissue or organ damage. So we will know when to give this long-term oxygen therapy. Okay. So for the acute hypoxemia, the signs and symptoms include, so for the mild to moderate hypoxemia, so the PaO2 will be 40 to 59 millimeter mercury. The patient is restless, anxious, agitated, or disoriented. You will see that the patient has increased respiratory rate. So you can see that the RR will be 30, and dyspneic with use of accessory muscles. The heart rate would also increase, and the patient will have an elevated blood pressure. So for the severe hypoxemia, that the PaO2 will be less than 40 millimeter mercury, the signs will be more onerous. So major life-threatening emergencies, like the patient will be lethargic, possibly comatose, pale, bluish in color. So the respiratory rate will be low. So there will be an agonal breathing, hypotension, and we can see on cardiac arrhythmia, you can see on the monitor some cardiac arrhythmias, okay, like the AFib or atrial fibrillation. So you can see some of the PVCs, for patients with severe hypoxemia. So what are some of the causes of the acute hypoxemia? So if the patient has a low FiO2, which is also associated with high altitude, so of course at sea level, the barometric pressure is normal, and then when the patient or when we go on a higher level, when we go hiking, the barometric pressure will go down, as well as the oxygen on the atmosphere. So if patient will go up or go hiking, they need to acclimatize first. So if they ascend very fast, they might have this hypoxemia. So even though you are very much active, you will tell yourself, oh, I can just climb up that fast. I can climb it like one day. You need to acclimatize first, because you will have this acute hypoxemia. So, of course, we have this anemia or compromised hemoglobin. So if we have anemia, of course, the auto-delivery will be low. And then one of the things, compromised hemoglobin, like the carboxyhemoglobin. So the carbon monoxide has more affinity to the hemoglobin, which is 250 times more affinity. That's why we need to give more oxygen to drive off this carbon monoxide to the hemoglobin. So that's why it can cause also acute hypoxemia. So we also, one of the causes could also be an alveolar hypoventilation. For example, like chest trauma, the patient will not inhale deeply, so there will be alveolar hypoventilation. And of course, in opioid overdose, so for opioid overdose, the respiratory rate will be decreased, so there will be also hypoventilation. For the VQ mismatch, so for patients who have COPD, exacerbations of COPD, the ventilation will be compromised because of the airway constriction. So there will be less ventilation. So we also have the right to left intrapulmonary shunt in patients who have congenital heart diseases. So there will be a VQ mismatch. And also the physiologic shunt, wherein we can see in the acute lung injury and the atelectasis. So how do we treat this acute hypoxemia? We need to administer supplemental oxygen therapy. We can give 100% medical grade oxygen delivered via liters per minute in flow meter, via the flow meter. So we will be discussing that. A typical dose of 3 to 10 liters per minute, depending on the degree of the hypoxemia. So we will be measuring also the oxygen and the arterial blood gas. So we will titrate the O2 delivery to achieve the target blood oxygen level. Our goal for the acute hypoxemia is SpO2 of more than 95%. But you also have to bear in mind if the patient is a chronic lunger or if the patient is a COPD. And also one of our targets for the acute hypoxemia is a PaO2 of more than 90 millimeter mercury. So we need to avoid prolonged administration of an FiO2 of more than 0.60. So because we can induce more harm, the hyperoxic acute lung injury, there is a possibility of possible depression of the hypoxic drive in COPD patient. Remember, if we give more oxygen to COPD patients, the drive of the respiratory drive will go down. That's why we don't want to have a prolonged FiO2 of more than 0.60. For neonates, they might have this retinopathy of prematurity. So as much as possible, we need to decrease the oxygen, the FiO2, to as low as 0.60, okay? So again, we can also use a low flow or high flow delivery system. We seek to give an FiO2 of 0.25 to 0.50. So the FiO2 delivered to the alveoli is a function of what type of device are we going to give, the O2 flow rate, the flow rate that we're going to give, it is 1, 2, 3, like that. The RR of the patient, the respiratory rate of the patient, the peak inspiratory flow, and of course, the ambient air entrapment. So these devices, sometimes the devices that we're going to give can also, the ambient air can also be inhaled. So we will be discussing that. So importantly, it is important to periodically monitor blood oxygen levels. So again, the need of the SpO2 or the need for blood gas. So for the chronic hypoxemia, the signs and symptoms would include, if there is a long-term physiologic effect, dyspnea will be more pronounced on exertion. There will be an elevated hemoglobin count because it will adapt to the oxygen demand of the patient, or the because if they will have more hemoglobin, the oxygen will be delivered more. So that's the body of the patient will produce more hemoglobin. So to help with the oxygen delivery, okay. So there will be a pulmonary vasoconstriction because it will go to the oxygen will go to a more the more important organs like the brain, the heart. That's why they will have pulmonary vasoconstriction. So the patient will have pulmonary hypertension, and then it can lead to the cor pulmonale. So cor pulmonale is a right-sided heart failure. The right ventricle will be dilated if the patient has a chronic hypoxemia. So exacerbations becomes life-threatening on these patients. For our COPD patients, there is a greater risk for lung injury, trauma, and pulmonary infections. So how do you manage the chronic hypoxemia? So we need to provide the long-term home therapy or the LTOT. So our target blood O2 levels is a PO2 of more than 60 millimeter mercury or an SpO2 of more than 90%. Again, we need to avoid over-oxygenation because we don't want to depress the hypoxic drive. So our goals is to reduce further systemic damage from the untreated hypoxemia, reduce dyspnea, enhance ambulation, facilitate pulmonary rehab, improve quality of life, and of course, we need to reduce likelihood of further exacerbations. So these are the examples of the oxygen supply options. So the first one is the wall panel. You can see it at the head of the hospital bed. O2 is supplied by the external reservoir, central piping systems, and we can access a flow meter. That's the flow meter, the green one. And then suctioning will also be available. So we have the M250 cylinder, formerly called as the H or K cylinder. It is used for continuous bedside therapy for those who don't have the panels. So capacity is 250 cubic feet or 7,075 liters. The duration for fully loaded or cylinder that is full is 23 hours at 5 liters per minute. So we have this portable cylinder, the M24 cylinder, which is formerly termed as the E cylinder. So this is used for emergency transport and for the duration of for a full 2,200 psi. For it can deliver 3 hours at 3 liters per minute. So important is you have to know how to do safe handling and secure that the cart is on safe place and will not fall down, okay? Especially the cylinders. Empty cylinders must be replaced and they should be segregated to the full cylinder. You have to segregate full cylinders and empty cylinders. We might give the empty cylinders to a patient, so it's traumatic, okay? So we have these dispensing devices, regulators for the M250. So this one is a threaded wing nut attached with a wrench. So this is the regulator. So for the regulators for M24, yoke with washer hand tightened, flow adjusted only with Bourdon pressure gauge. So we want the Bourdon pressure gauge because M24 is a transport cylinder. So if we put it on a supine position, the flow will not matter. As compared to the TWRP, flow tubes, flow meters, if you use it on the small cylinders and if you make it on a supine, the gauge will also be different. You cannot really adjust the flow meter. So oxygen analyzers, we have these oxygen analyzers and the air oxygen blenders. Oxygen analyzers are monitors to verify or deliver the FiO2 and also monitor ventilator or concentrator performance. It is also used to verify the contents of the cylinder. So for the air oxygen blenders, it delivers the precise FiO2 and high peak flows by controlled mixing of air oxygen used for high flow nasal cannula and also for mechanical ventilator. So low flow oxygen administration. So we have this standard nasal cannula and the simple face mask and the run rebreathing. So we have to bear in mind that these are all low flow oxygen administrators. We can give, for the standard nasal cannula, you can give us 1 to 2 liters per minute low flow. And then if we give more than 5 liters per minute, it might cause dryness, and we need to require humidifier, or we require humidification. For the simple face mask, we need a minimum flow of 5 liters to 12 liters flow rate, 5 to 12 liters flow rate, and we need to give more than 5 liters per minute to prevent oxygen buildup in the mask. So also for the non-rebreathing, we need to give 6 to 15 liters per minute flow rate. So we also need to make sure that the bag is not collapsed during inhalation. So precise oxygen delivery is not possible for low-flow systems because during inhalation, entrained ambient air dilutes the oxygen, the supplemental oxygen flow. So if we inhale, there are ambient air that will be delivered also to the patient. As compared to the high-flow oxygen administration, we can deliver a precise FiO2, an O2 flow rate selected in the nozzle size of the desired FiO2. So, okay.
Thank you very much.
I think it's the last slide.
Last slide? Sure, okay,
Yeah.
no problem.
Oh, sorry, it's not.
We can continue the workshop though.
Okay.
Yeah. Thank
For
you
the
very
long
much,
time.
Dr.
Thank you very
Diola,
much.
for your presentation.
Okay.
Our next presentation titled Humidity Therapy. It's an honor to introduce Ms. Dammam Evans. Ms. Evans, she's a Respiratory Regional Director for Adequacy Health in Illinois, USA. She currently serves as a President of the American Association of Respiratory Care and widely recognized for her leadership in respiratory care advocacy, workforce development, and health administrations. Please welcome Ms. Dammam Evans for her presentation in humidity therapy.
Thank you. Good morning, everyone. Thank you for that kind introduction. I'm very excited to be here this morning. We're going to talk a little bit for the next half an hour about humidity therapy, very basic foundational knowledge that we need to care for our most critically ill patients. There are quite a few objectives associated with this talk in your textbook. I promise I won't read them to you, but I think there are 17. I'll hit upon the high points of each of these, although I won't go in depth on most of them, given the time frame. So just to start from the very beginning, I think we all know that water makes up the bulk of our bodies, right? It's found in blood, saliva, and mucus, and exists in 3 states, although we typically only think about it in terms of our medical gases in the liquid and the gaseous form. And in gaseous form, we talk about it in terms of water vapor and water vapor pressure and or content in milligrams per liter. So it's important to remember that the volume of liquid that can be held in a gas is proportional to its temperature. So higher temperature gases can hold more water than lower temperature gases can. So you want to make sure that as we're caring for our patients, we're being thoughtful about the temperature of the gas delivered, because that influences dramatically the amount of humidity that we can provide to our patients. This plays out in real time when we look at patients. If you think about mechanical ventilators, when you see very warm, very moist gas exiting the humidifier and then making its way to the patient or making its way back from the patient back to the ventilator, when you see those temperature changes happen, because then you start to see rain out in the circuit, right? As the temperature drops, it can hold less water. The water has to go somewhere, and it rains out in that circuit. It's a good indicator that you're achieving 100% relative humidity when you see that rain out, so it's important to watch that. And when we think about humidity, we're often thinking about body temperature pressure standard. Body temperature pressure standard really is 37 degrees Celsius for that temperature, and the pressure standard at 100% relative humidity at 37% is 44 milligrams per liter, exerting about 47 millimeters per mercury of water vapor pressure. So that's BTPS. The way humidity works in a normal, healthy adult patient with a natural airway is that we serve as our own heater and our own humidifier, right? So when you inhale room air gas, usually around 22 degrees Celsius, your nasal mucosa and your conducting airway mucosa heat the gas as it moves through your airway. Ooh, goodness. I'll try not to do that again, whatever I did. Heats the gas as it moves down your airway, and also as it comes in contact with the moist mucosa, humidifies that gas as well. And then as we exhale, that warm, moist gas again serves to heat and humidify our own mucosa so that as we continue to inhale and exhale, that cycle can continue. A humidity deficit is important to think about with our patients, although we're always experiencing a humidity deficit. That simply means the amount of water vapor in the gas that we're inhaling is not at body temperature pressure standard. In most cases, our natural airways can account for that through that heating and humidification process that I just mentioned. The point at which the gas reaches body temperature pressure standard, 37 degrees Celsius, 44 milligrams per liter of water, or 47 millimeters of mercury of water vapor pressure, is called the isothermic saturation boundary. The isothermic saturation boundary in a normal, healthy adult patient with a functioning upper airway is about 5 centimeters above the carina. This is typical. When you have a patient that has a significant or more marked humidity deficit, what functionally ends up happening is that isothermic saturation boundary goes further and further down the airway because it takes longer to achieve that level of temperature and longer to achieve that level of humidification. This is when we start to see impact associated with humidity deficit and the negative things associated with that. So you really want to see the isothermic saturation boundary at 5 centimeters above the carina. When it is not, and we see those effects of humidity deficit, you start to see ciliary destruction. You'll see swelling and inflammation. The airway cilia don't beat in the way that they're expected to, so they either stop beating or they beat more slowly. That in combination with less moisture cause thickened secretions and retained secretions, which can result in increases in airway resistance, as well as, in significant cases, reduction in airway compliance and ultimately atelectasis. So these are things we want to make sure we're avoiding in our patients, and definitely something we have to think about when we bypass that upper airway with an advanced airway like an endotracheal tube or trach. We all know that the gas that comes out of the wall or the tank is cold and dry. So that's what causes that humidity deficit in most of our patients. In patients with just regular low flow oxygen therapy, sometimes that can play out as nasal drying or just being uncomfortable. You might see a nosebleed. Sometimes they'll report difficulty clearing secretions. And when you use that artificial airway, as I mentioned, you have to be very, very thoughtful about making sure that we, as respiratory care providers, are heating and humidifying that gas so that their isothermic saturation boundary isn't very, very low. There are generally 2 types of humidifiers that you'll see on the market and commercially available, typically bubbler humidifiers, which we see in low-flow oxygen therapy devices, and then more commonly in our patients on mechanical ventilation, non-invasive ventilation, high-flow nasal cannula therapy, you'll see pass-over humidifiers. There are other mechanisms to provide humidity, but these typically are the most common you'll see. So a bubbler, very basic. I think we've all seen bubblers, right? It's a container of water. with a tube that passes the gas down below the surface of the water with a diffuser that breaks the gas up into small bubbles. Small bubble is important because you want to increase the surface area that comes in contact with the water as it literally bubbles back up to the surface and then moves along with that carrier gas to the patient. These are not really thought to be very effective humidifiers, however, and one would argue that in some cases they're not necessary anyway at low flows, and then at higher flows because the gas is moving so quickly and bubbling up through that water so quickly because the rate is so fast, there's an argument to be made that it doesn't pick up a very efficient amount of humidification anyway. These can be heated, but are most commonly cool. Passover humidifiers, again, this is going to be the most common thing you see on a mechanical ventilator. Fisher & Paykel, Hamilton, others, these are what their heaters look like. Literally what happens is the gas passes over a body of water, and as it does that, evaporation causes that water vapor molecule to enter the gas. This is more significant when the gas is heated because evaporation speeds. You'll also see Passover wick humidifiers. These are definitely more efficient than a traditional Passover humidifier, but pretty uncommon to see in practice. It increases the amount of time that the gas comes in contact with the moist water because there's a wicking material within the device itself. So you can see on the left-hand side for you a traditional Passover humidifier, and on the right-hand side here a wicking humidifier where you can see the wick on either side, again giving more time for the gas to pass by that moist surface. There are other ways to administer humidification, although pretty uncommon. You can use a standard handheld nebulizer, jet nebulizer, when you're using it with an isotonic fluid to administer supplemental aerosol level humidification. Not very common, not very efficient. We typically use this for medications, but you could do this. It's been many, many years since I've done this. I think the last time I did it was a patient who was a full surface burn patient with radiant warmers above the bed to keep him warm, and it tricked the heater. So the heater wasn't functioning as effectively as it should have, and so we administered actually jet nebulizer therapy to supplement that humidification in addition to the Passover heater. Heaters have gotten much smarter since then, so we don't do that very often, but it is possible to do it that way. I'm going to mention some of the devices that really truly need that high efficiency humidification process, high flow nasal cannulas being one of them. So as Rio just mentioned, conventional nasal cannulas are considered low flow. You can see some of the wider bore nasal cannulas that go up to 15 liters per minute. That's still considered low flow. High flow is when the gas entering the patient's airway exceeds their inspiratory demand, and we can see that as much as 60 or 70 liters per minute depending upon the device, with very, very high levels of oxygen as well. So we know that high flow nasal cannula therapy is very, very important for our patients. It reduces work of breathing, it improves respiratory rate, etc., often preventing the need for intubation in some of our patients. However, you must heat and humidify that gas to avoid all the detrimental effects of humidity deficit. Same with mechanical ventilation, right? We've bypassed that upper airway heater and humidifier for our patients. So you want to make sure that when you've done that, you achieve at least 75% absolute humidity at BTPS for those patients. So that would be 33 to 44 milligrams per liter of water vapor, of water content with a temperature of at least 30 degrees Celsius. Right? And you can see both passive or active humidification for our patients on mechanical ventilation. Both are acceptable, but each have their own specific need. So passive humidification really is the use of an HME, often referred to as an artificial nose. So this sits at the end of the endotracheal tube or the tracheostomy tube and has a piece of material in it that collects the heat and it collects the humidity of exhaled gases. So when the patient inhales, That material ideally is warm and moist, heats and humidifies the inhaled gas as it enters the patient's airway, and when the patient exhales, their own gases heat and humidify that material as well, very similar to the way it does its own natural mucosa when you have a natural airway. That's why sometimes this is called an artificial nose. An effective HME must be able to provide a humidity level of at least 30 milligrams per liter of water. Oh, and I turned it off. Now, most organizations I'm aware of that use HMEs do it because they are less expensive. So they're a pretty cost-effective mechanism for providing humidity for short-term patients. So post-operative cardiac patients who won't be on the ventilator very long are usually pretty good candidates for this. And then you can avoid the purchase of a heated wire circuit. However, there are very good reasons you should not use this device. So if you have a patient that already has thick, copious, or bloody secretions, you probably know that if their secretions are already thick, their mucosa probably isn't moist enough to heat and humidify that material. So if you add an HME to that type of patient, what you'll actually do is worsen the thick secretions and make it more difficult for them to mobilize that. If a patient has a significant leak around their airway, so a leak around the endotracheal cuff, or they have an ET tube without a cuff at all, or they're leaking into the chest tube, for example, then the exhaled gas, the warm, moist gas, just is simply not moving through the HME, so it cannot heat and humidify it if it's moving out into the room instead of through that HME. So in those cases, you could not use that because the HME would be cold and dry, making the gas they're inhaling again cold and dry. Patients that are hypothermic, right? You have to be warm to warm something. And then patients that have very, very high spontaneous minute volumes, greater than 10 liters per minute, shouldn't be doing this because the gas is exiting too quickly to heat and humidify the HME material and coming in too quickly to pick up the heat and the moisture needed. So in those cases, the AARC clinical practice guidelines suggest those are contraindications and you should not use an HME in this case. You want to move to active humidification for those patients. An active humidifier is what we see on our mechanical ventilators. It's those heated pass-over humidifiers with heated wire circuits and temperature probes. Lots of different manufacturers create these days. As I mentioned earlier, at the beginning of this talk, you want to make sure when you're mechanically ventilating a patient, you see condensate or rain out in the circuit. A humidifier measures the temperature that it's providing at the heat plate, but it can't measure relative humidity and it doesn't measure absolute humidity. So the only way to absolutely know that your patient is getting 100% relative humidity is to see that as it traverses through the circuit when it's cooling, that there's rain out, right? So the temperature drops, it rains out. So you know it started at a very, very high relative humidity. If you have a patient and you are assessing them and you're looking at the circuit and it is very, very dry, it's time to troubleshoot the humidifier. Your patient is not getting enough relative or absolute humidity in that case, and you want to address that. So as I mentioned before, the AARC clinical practice guidelines require that in cases like this, that the absolute humidity is at least 75% of body temperature pressure standard. So that would be 33 milligrams of water per liter, or up to as much as 44. And the temperature must be at least 30 degrees Celsius, ideally approaching 37 for these patients. There are instances where the heater may not be as effective as we would like it to be, and that's typically things that would trick or confuse the temperature probe. So high temperatures in the room, for example. So I gave the example of the burn patient with the large radiant warmers over the space. If you work in a burn unit, you know those rooms are very, very hot. So you want to be very, very cautious to make sure in those patients the heater is doing what it's supposed to do. The other place you may see this is in the neonatal intensive care unit when the ventilator circuit is inside of an isolette, a heated isolette, or on a baby that's in a radiant warmer. We often see a lot of rain out in these patients, particularly if a portion of the circuit in that bed space is not heated, right? So that can cause a lot of challenges and can actually lavage our patients if we're not careful. So it's nice to have a heated circuit all the way through that warm space. So when you're at the bedside trying to decide, can I use passive humidification for my patient, or do I need to use active humidification? You can ask yourself a few questions. First and foremost, is this patient going to be on the ventilator for a long period of time? That might lead you to use active humidification. And if you're considering an HME, do they have any of those contraindications, right? Thick secretions, high minute volume, large leak, things like that. So a lot of the things that we do with our patients can be affected by the humidity therapy. They must have it, particularly when they're ventilated. When we're administering inhaled medications, however, we very much know that the high humidity level in the circuit does impact particle deposition. It's because it causes those aerosol particles to swell when they pick up moisture themselves, which just means that they don't have the ideal particle deposition space in the airway. We know this to be true, and yet you can't turn off the humidifier because that causes other issues. So there's good studies out there that talk about the best place to put an aerosol device in the circuit to try to mitigate some of those reductions in particle deposition. So for example, the dry side of the humidifier on an invasive ventilator. On a non-invasive ventilator, you'd probably want to put it past the exhalation port so it's not just pouring out into the room, things like that. And in some cases, you could consider increasing the dose. Because we know we can see up to 50% reductions in particle deposition for these patients, and even more significant in our pediatric patients, so something to monitor. During non-invasive ventilation, while we're not bypassing the upper airway, right, we're using a mask or pillows or something to administer positive pressure ventilation non-invasively, they still have the benefit of their upper airway to heat and humidify. However, we all know that the speed, the flow rate of the gas coming through a non-invasive ventilator is very, very fast, right? So it's difficult for the upper airway to keep up with that much dry, cold gas coming out at that speed. So it's important for us to assist and supplement the humidification for those patients. Some patients do just fine without it. These are often our OSA patients who wear low levels of CPAP at home and are accustomed to that. But our critically ill or acutely ill patients probably will need a little assistance. It could be just dry pass-over humidification or active heated humidification like we see on traditional invasive ventilation. Because they do have access to their upper airway, we don't have to heat it as much as we do for a patient with an endotracheal tube. You can shoot for a temperature of between 20 and 22 degrees Celsius with a relative humidity of about 50% as opposed to 100%. Again, they still have their upper airway intact with an absolute humidity of at least 10 milligrams of water per liter. All right, I'm going to finish early, Hassan. So there are lots of things to think about in this chapter. Many, many key concepts. So as I mentioned, humidification is really foundational to the work that we do every single day. And as respiratory care providers, we must be thoughtful about ensuring that our patients do not have high humidity deficits to avoid the potential associated complications with that. Medical gas is cold and dry, so we have to heat and humidify it. I think it's mean not to do that, personally. Particularly when we're bypassing our natural upper airway heat and humidifying ability. We have to be thoughtful about the impact of humidification on other care that we provide, including nebulization. But again, you can't turn the heater off to administer albuterol to those patients. We just need to think about other ways that we can support that. Most importantly, remember that the isothermic saturation boundary in an adult patient with a natural airway should be 5 centimeters above the carina. Anything lower than that is significant in terms of ciliary destruction, mucosal damage, etc. You want to shoot For 75% of absolute humidity at BTPS, for 33 to 44 milligrams per liter of water with a relative humidity of 100% in these patients. HME should not be used as a prevention strategy for ventilator-associated pneumonia. I didn't mention that here, but it is important. It's not a strategy for that. And passive humidification is not recommended for our patients, really, in non-invasive ventilation, because it just doesn't work as well. And that's what I have for you this morning. Thank you so much.
Thank you very much, Doctor.
Thank you, Dr. Taha. Assalamu alaikum. Good morning, everyone. And I would like to thank our guest for having or for coming here today. And hopefully you'll enjoy stay here in the Kingdom, in Dammam. So the next talk will be with it's about the aerosol therapy. It's going to be presented by Dr. Douglas Gardenhire. Dr. Douglas, he is a chair and clinical professor in the Department of Respiratory Therapy at Georgia State University and governance teaching fellow. Dr. Gardenhire is internationally recognized for his contribution to respiratory therapy education, clinical practice, and professional development. Dr. Douglas interviewed me twice, maybe 5-6 years ago. I forgot, but now times to meet again here. And please welcome with me Dr. Douglas.
Thank you, and good morning to everyone. It's a pleasure to be here. Pleasure to speak in front of you this morning. So we'll talk a little bit about aerosol therapy. We had a great introduction to some of those things in our previous talk. Here's our objectives that we'll look to cover. I'll just give you a few seconds to take a look at those. I don't want to necessarily read those to you, but making sure that we understand the information that we need as therapists to optimize the best outcome in aerosol therapy for our patients. So ultimately, when we look at the characteristics of aerosol particles, size is important, and don't let anybody ever tell you otherwise. Size makes the difference in terms of where those aerosol particles are going. So as you can see, the larger those particle sizes are, they're going to deposit in the higher airways, more of the upper airways. The ideal particle size that you're going to be looking for is between 1 to 5 microns. That 1 to 5 microns will allow us to make the move to the lower airway, in which we are usually giving our aerosol medication. So 1 to 5 microns is where we're looking to be. In terms of how we're going to provide those aerosol particles, you can see here we have a laundry list of different devices, and they all provide similar, but not always exact, amounts of particle size that we want. So it really depends on what it is that we're looking for and making sure that we're going to figure out the best device for our patient. Ultimately, with figuring out what is going to be the best device, we may think a device is going to be best, but it's also helpful for our patient to make sure what is it they're most comfortable in using. Ultimately, too, what type of disease state are they in? Are they, again, in an acute process? Are they in a longer-term process where we're trying to manage them? And that may be where we're going to select different devices. So all of these things are going to come into play about how we would select the best device and making sure that we're going to provide the best education for these devices. So in terms of our nebulizers, jet, mesh, ultrasonic, and smart, those are, again, devices that we're pretty common knowledge with, probably the jet nebulizer being the most common, as it's the least expensive in terms of delivering an aerosol in a liquid form. We have our pressurized meter-dosed inhalers. Those, again, are very specific, potentially to certain drug combinations or single drugs or proprietary medications and how those are. Dry powdered inhalers. That's, again, very similar to our meter-dosed pressurized inhalers, except in the form is different. The drug is dry, and we have a carrier of the lactose. And then we have our soft mist inhalers. So those are some of the newer ones that have made their way to market and are proprietary and delivering specific amounts, types of medication. So in terms of the delivery, The techniques in which we're going to deliver those are really very similar to all of what I consider the smart, jet, mesh, more of the liquid medication types, and how we're going to deliver them. Ultimately, we're going to look at the most common one here, which is on your left of the jet nebulizer, understanding that we're going to assemble the device as it is. We're going to attach it to a power source, and somewhere between 6 to 8 liters is going to be the optimal liter flow. You will know that optimal liter flow by using your ear, because you'll be able to see how that device will work. All of these jet nebulizers, manufactured by different manufacturers, are going to maybe work just a little bit differently. So that's why I like to say using your ear to be able to hear exactly how that is, along with seeing that mist come out, that aerosol mist come out, will again key for you in how that device is working for your patient. Ultimately, we can see both of those. We're going to keep them vertical and making sure that we continue to make the treatment continuous. In terms of the cleaning probably is not as big, as a lot of these devices may be disposable, but ultimately I think the take home from there is that if we're rinsing the cup, we should rinse it with sterile or distilled water, not tap water. Probably the worst thing that can happen with these devices is that we would allow them to set with the medication in them or with tap water in them, and it's just a breeding ground for microbes. So if we're going to clean them and reuse them, we should use distilled or sterile water. On the ultrasonic mesh and smart, I think the big take home there is understanding not to touch any of the internal components. That is the biggest key, as these are a little bit more finicky in how they, again, are used, and so a little bit more delicate. In terms of our MDIs, one of the great things about them and why we like to use them is because we are able to move them. Before, with our other devices that we just spoke of, we need a power source, some type of a power source, unless we have a mesh nebulizer that might be powered by battery. This, again, needs no type of power other than the power in which the device is made. This, again, is very common, and there's ultimately 2 types. A conventional one, in which we're going to direct the patient how to breathe, and when we're going to direct them to make the inhalation, and those that are breath actuated. So the breath actuated is a little bit more easier, I think, for the patient, as they do not have to have that timing right. The education might go a little bit different in how we're looking to utilize those. But ultimately, we know how those are put together from the metering device as it makes its way to form the aerosol. In terms of the technique in which we're going to deliver these devices, a lot of the times these can be delivered with spacers or valve holding chambers. And ultimately, what we're looking to do is provide the most clear and consistent education we can for these patients. The key is education. The device will take care of itself. The education is your part, along with what the patient is doing and understanding and making sure that they can replicate to do that treatment. If they cannot, then we're going to have variability in that treatment, variability in the particle size in which is going to be deposited into the airway, which ultimately changes the outcome for the patient. These are great devices if we are able to use them correctly, but there's so much variability because it's our education, their understanding, and their continual use. In terms of the spacers or the valve holding chamber, remember a spacer is simply just a tube. There is no one-way valve. That is just going to add volume, which usually equals time for us. A lot of these newer, the newer HFAs that are on the market, they don't need to really ultimately have this spacer, as they have been slowed down in how the mechanism of the reaction that's created within the pressurized MDI works. However, this can be a great piece for, again, timing for our patients. So it just gives them that extra time to making sure that they're doing what we're asking them to do in terms of exhaling and then starting to breathe. The valve holding chamber is a little bit better in that it will kind of take away any of that parts that they might seem to get confused on. So they can depress the MDI, and it's going to give them a little bit of time because it's going to hold within that valve holding chamber before that inhalation is taken. So the timing process is a little bit different, and maybe not as critical as what it would be with the spacer. And you can see here up on your screen, there are lots of different types of spacers and or valve holding chambers. So any type of tube can be considered a spacer, and then we have all of our valve holding chambers which are on the market. If you're looking to use a valve holding chamber, make note, the important thing there is to choose a non-electrostatic valve holding chamber. What that is doing is taking all of the static electricity that would be in that device because of the plastic and taking that away so that we can actually increase the amount of dose of the drug that's going to be able to make its way to the patient. I think you're going to see close to 80% more, or fourfold of the lung dose from that MDI. The inhalation valve for those, we need to make sure that they're working properly, because if they're not, we're going to have a change in how that's going to work and be able to deposit for our patient. So in these valve holding chambers, we need to, again, listen. Listening is important to making sure that we're not hearing that high-pitched tone when they, again, are breathing in too fast. So the take-home with these MDIs that we'll talk about here in a minute is that we're going to go low and slow for these. We do not want to be deep and fast. If you're using a valve holding chamber with smaller individuals, such as pediatric patients, understand that a pediatric patient may not be able to have the volume that's contained within that valve holding chamber. Whereas you may need to take 2, maybe even 3 breaths from that child, depending upon the size. If it's a smaller adult, but maybe a smaller tidal volume, that may be the same as well. So we need to, again, take a look at how large that valve holding chamber is versus how large of a volume or the size of the individual is in terms of their capacity. If we're cleaning and maintaining our MDI alone with all of our different accessory devices, there's really not a lot that needs to be done in terms of the cleaning and the maintenance. I think the big thing that we need to take a look at is ultimately looking at where we're going to inhale from that device, so the mouthpiece. Look inside of that mouthpiece. Because these items are portable, we, again, often as humans, will put them in bags, in purses, and maybe not have the lid. We may have lost the cap for that device, and things may get into the mouthpiece. Then the patient puts that into their mouth, not knowing that something has made its way there, and now that patient has potentially inhaled some type of foreign body. So that, I think, is the biggest take-home that we're going to have there. Of course, again, rinsing, cleaning the device, if there's any type of residue, is easily done, and we can air dry all of our parts. Specifically, we want to air dry any of our valve holding chambers. We do not want to run towels through them because that, again, is what's taking off the layer or the barrier that provides that barrier for the static electricity. Dry powdered inhalers, these are potentially very good if used in the right patient. There are 3 different types. There are unit dose and multi-dose devices. And so it depends on whether it's a single dose that we're putting a pill and crushing that capsule in, or whether it is a individual blister packet that comes with large amounts of blisters. So you'll see those varying devices. In terms of delivery technique, much different than what we just spoke on in terms of going low and slow. Here we want to go deep and fast, and that's probably the most difficult for our patients who have pulmonary disease. That's why these devices are probably the least likely of our devices that we would choose to treat someone with pulmonary disease, simply because of the inspiratory flow that the patient needs to generate for this device to achieve the most of that dose of drug. Soft mist inhalers. These are the newest inhalers that we have. They are propellant free, so there's no drive for them, such as we have from our pressurized meter dose inhalers. They, again, use a spring valve to generate mechanical energy that's going to deliver the dose. And that dose is going to be placed through that soft mist inhaler, providing a very soft, delicate highly dense mist in which our patient is going to be able to inhale. The technique very similar to that of a pressurized meter dose inhaler. We're back to going low and slow for these patients. And so ultimately, pretty straightforward in terms of any type of cleaning that we're going to do is just wiping it down, making sure there's nothing inside the mouthpiece and making sure that it seems to be relatively clean. When we're looking at efficiency of devices, I mentioned this a little bit earlier in terms of there's going to be devices in which we're going to select based upon the patient in which we're treating and how and what type of disease they may have, whether that's acute, maintenance, and ultimately looking at age appropriation. That may be, again, some of the biggest ones that we have. We're going to, again, do a lot of different things with our education for pediatric patients that maybe we would not necessarily do with adults. But ultimately, with our patients, depending upon their age and their ability to take instruction and to be able to replicate that instruction, this is going to, again, tell us how efficient that device may be. So ultimately, we are responsible for the patient and the device, because without us, we would not be able to have the most efficient device that we can provide them. And without your education to them and their ability to replicate that, is going to be very difficult for them to be able to continue to use that medication correctly and be able to have the best outcome. So here is a figure that shows what we're going to do in terms of the device in terms of selection. Ultimately, what it's going to come down to is usually patient preference along with what their disease process is. So we might, again, utilize a jet nebulizer or a mesh nebulizer or a pressurized meter-dosed inhaler, which is pretty common that we would use in the hospital and outside of the hospital for those individuals with pulmonary disease, depending on how severe that pulmonary disease is. The DPI, maybe not as much. Again, there are, some changes that may, occur to the patient and their disease process, which that may not be the best selection. Another consideration is cost. Cost is very key, specifically in places around the world where the cost can, again, be much different, and the earning potential of individuals utilizing that may be much different. So I think that, again, is one of the biggest keys that we sometimes forget, is how much this device is going to cost when they leave the hospital. Ultimately, it's going to be up to us to train that patient to do the same thing over and over again. In terms of patient education, of course, again, facts, making sure they understand their disease process is going to be key. How the medication in which they're utilizing is going to help their disease. To me, that is key. The patient will not utilize that drug if they know that maybe it's not as beneficial to them. So you have to make sure that they understand that the medication in which they're receiving from this device is critical in the care and for their continual health, that they do this on the prescribed time, the prescribed days, and continuing for how long that may need to be. The skills needed for those aerosol devices, we again get them confused as patients. Patients will confuse them. We said for a jet nebulizer, we're going to just kind of breathe slowly. We might again have some instruction on holding your breath. For a pressurized MDI, we need to go low and slow. Whereas a DPI, we're going to go deep and fast. Well, this gets confused in the patient's mind. Where, what am I doing with what device? Specifically, if you have all three devices in front of them. So in terms of when they are, again, being taught how to use this device, if we can push down the number of devices in which they are utilizing at home, may increase their adherence and be able to provide better outcome for the patients. When we're looking at, for some of our own knowledge, I think, in using these devices, if we're using some of these devices, I think, best for training, but will also, again, let us know here in the bottom right, one of my favorite devices is letting us know what the actual flow is for the patient, that inspiratory flow. This device will let us know, hey, this person is going to be really, really good. They can generate enough flow for a DPI, or they may not need that DPI because their inspiratory flow is not high enough. Because if it's not high enough, then that device is not effective. So to me, that's one of my most favorite ones that I use. We don't have to have anything other than the device itself and the patient. And one that I use a lot around the world when we're training individuals, specifically in rural areas of developing countries. Ultimately, if we look at patient adherence and how we can improve that, ultimately looking to the patient, and again, just going over those directions over and over again, making sure that they're following through, making sure that we can simplify that as much as possible. Today, a lot of our medications can come as once a day. So instead of taking it 4 times a day or 6 times a day, we can take it once. So that, again, is another positive piece in which we're looking to help educate our patients in terms of their adherence. If we're looking at delivery for children, as we mentioned before, a lot different than maybe for our adult patient. So that selection of device is going to be much different depending on how old that patient is. So before we were looking at how much the inspiratory flow is. These patients may not have a very big inspiratory flow as well. So leaning more towards the PMDIs, leaning towards the jet nebulizers are probably going to be much better for use. When we're looking at the use, no matter whether it's for an adult or for a pediatric patient, we'll see in terms of the interfaces, utilizing the different interfaces, and we see face mask. The face mask is the worst thing that we can use for a patient other than a respiratory therapist. Patients do not need masks unless ultimately they cannot use the mouthpiece. Patients need you, the respiratory therapist, to be able to educate, guide, and direct them. So with all of these devices, I would say utilizing these interfaces other than a mouthpiece with caution, making sure that we're using the appropriate one that must be used, must be needed at that time. The nebulizer and the pressurized meter dose inhaler is going to be best for our selection in non-invasive ventilation. This is not appropriate for the use of a DPI of these, of course, because of the need for an inspiratory flow. The mesh nebulizer and jet nebulizer are both good, the mesh nebulizer being much more efficient, and ultimately where we're going to, again, place those in the circuit, which we heard about just in our previous talk. And ultimately, looking at whether we're using a full face mask or not, understanding how that works, simply because where the aerosol may go in terms of the eyes and how some of our medication may affect the eyes in some cases for individuals. When we're looking at the use of our MDIs and nebulizers in terms of our ventilator-dependent patients, we heard this just previously, where we again are using our HMI. These are great. We can have these in use, but of course we want to make sure that they're going to be bypassed in terms of giving the aerosol. And you can see there's some ways in which we can do that with the devices here that are shown in these figures. So we're looking to bypass those. In terms of the technique with the jet nebulizers, again, where the placement is going to be. The biggest take home from that part is going to be where it's going to be placed, usually 6 inches from the Y adapter, at least 6 inches back. So we're looking to make it move that back. And then the other important part is never, ever, 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 ever are we going to take away the humidity from the patient. So if they do have a humidifier, we will never turn it off. Same is going to go for a mesh nebulizer in terms of we do not ever want to turn off our humidity, but in terms of placement, the placement's going to be different. We want to put it as close to the ventilator as possible, and potentially at times, depending on manufacturer's suggestion, is that it's going to go all the way to the ventilator, and then it's going to make its way through the passover humidifier. In terms of the pressurized meter dose inhalers, in terms of the technique, again, when we're using any of these different devices, very similar to what we had before, we're going to bypass those, or we're going to move that to the back away from the Y to provide the best device of that aerosol that we can. Ultimately, the take-home message here is that we need to understand our patients' needs, as well as making sure they understand the need of the device in which is going to be selected for them. They may have a say in that selection, which is okay, because we want the adherence to be at the highest that we can. Because without the adherence, the patient will not be able to get better. The patient cannot have any adherence and making sure that they do not have the correct education if it's not for you. You, the respiratory therapist, needs to make sure that you have the best, the greatest understanding of each and every one of these devices so that you can carry that forward to the patient. And making sure that they can replicate that over and over and over again so that we can get the particle size that we're looking for, approximately 1 to 5 microns, making sure in that piece that we are looking to never ever turn off any humidity that the patient may have. The humidity is important, specifically those that are on mechanical ventilation, and making sure that we stay away from any perceived VAP issues that could occur there. If you're looking at trying to make the selection for the device for the patient, it all has to do with what their inspiratory flow is. Do not, never ever choose a DPI over any of the other devices if they cannot generate the inspiratory flow that is needed for that device. And every one of them are different. That is probably the biggest myth, is that we think maybe again, if we just think it's over 60. Well, over 60 is great, but some of these devices require 110 liters to be able to get 100% of that medication out. So using these devices to find out what their inspiratory flow is going to be critical, and ultimately educating them and selecting what is best for them. And unfortunately, the DPI may be some of the easiest ones that we have in the portability, but may not necessarily be the best if we cannot generate the flow that is there. Thank you so much.
Thank you, Dr. Douglas. And it seems that the RT is a key factor to success for any aerosol therapy administration. So from the art of aerosol therapy, we'll be moving to the science of airway clearance and lung expansion therapy with Mr. Carl Hinkson. It's my pleasure to introduce Mr. Carl. He's the Senior Director of Ancillary Services at Providence Health and Services in Washington. He is also chair of the American Association Care Foundation. Mr. Hinkson is nationally respected leader in respiratory care practice, research, advocacy, and healthcare leadership. Please join me in welcoming Mr. Carl.
Welcome, welcome. I am very excited to be here. This is my second time in Saudi Arabia, and I am as impressed with the respiratory therapy on my second trip as I was on my first. It was quite interesting to me to meet so many great leaders in respiratory therapy, including Mr. Hassan, and I'm just really thrilled to be here. If I can, how many of here in attendance are current respiratory therapy students? Okay, how many of you are currently practicing? So it's kind of a mix. So some of what I have to say, maybe a lot of it sounds very basic. I will try to make it as real-world experience as possible. And I'm also very excited as we are doing the best of AARC here this time around. So we brought some of the Congress to Saudi Arabia, to Dammam, so you can experience what the AARC has to offer here locally. I am a respiratory therapist. I've been practicing for nearly 30 years. I just turned 54, and somebody told me that after you turn 50, your warranty is expired. Everything else is an addition. So I'm happy I made it here. We have a long list of objectives for this particular presentation. We are going to be talking about mucus and airway clearance therapies. We're going to talk about some factors that affect mucociliary clearance. We're going to explain how various respiratory disorders will impact mucus hypersecretion and sputum retention. Compare common airway clearance therapies. Some of them you may have used, some of them you may not have used. List some advantages and disadvantages of various airway clearance devices. Compare some drugs, and discuss some procedures to reduce the risks of airway suctioning. We're going to talk about open and closed airway suctioning. When I started in respiratory therapy, all suctioning was opening, and now it all seems to be closed. So what is mucus, phlegm or sputum? The definition of mucus is a heterogeneous, adhesive, viscoelastic gel produced by goblet cells and submucosal glands. It is mostly water, and highly molecular weight mucin, which is the protein in it, contains glycoproteins. So basically it is water with some sticky stuff that's made by your cells. And it is very important as a cleaning mechanism for the cells. The word phlegm, I did a little bit of research on this for entertainment purposes, comes from the Greek word. So the followers of Hippocrates, who started to make medicine more science-based rather than magic-based or what's the word I'm looking for? Superstition-based. Phlegm was one of the main humors that they came up with. Like, our body wellness was made up of humors. We had 4 humors. Phlegm was one of the humors that they created. If you had more phlegm, then your humors were considered to be out of order. It was associated with coldness and wetness. So if you were phlegmy, then maybe you needed to be warm. You needed some warm tea. So that's where the word phlegm came from. Nowadays, it denotes when we see mucus that's reached a disease state where you're producing too much of it because your body's trying to fix something that it doesn't like. So sputum is expirated phlegm. It's what we deal with day in and day out. Am I getting this right? There we go. So why is phlegm important? Well, phlegm is critical for the defense of your airway system. It is your body's mechanism for cleaning its lungs out. Your lungs is one of those organs that interfaces with the atmosphere. You breathe good in air, you exhale bad air out, and phlegm is that process where we clean that system out so that it keeps working. Phlegm is important in defense airway dehydration. You listen to Dana talk about the importance of airway moisture, and it's a barrier to invasion and traps bacteria and other items that we don't want in the lungs. Now, I think about this as it's like the flypaper of the body system, right? You inhale a particle, it gets stuck on your phlegm, and then you have this natural cough mechanism that expirates it out, right? So we breathe in particles. I wake up in the morning, what's the first thing I do? I take a deep breath, I cough, and most of the time we don't notice it because it's so natural to us. But we start to notice it when we get into those disease states. If I catch a cold or if I have asthma and inflammation starts to increase, then I notice I may have increased phlegm production. Certain diseases like cystic fibrosis, increased phlegm production is a key characteristic of those diseases. So how the normal mechanism works for phlegm is cleared by the mucociliary system of the body. All the airways are lined with cilia, which are small hair-like projections that stem from the cells, and they all beat like this, and from the bottom towards the top of the airway. And they beat with a particular motion, and they're covered by a layer of mucus or phlegm, whatever we want to call it. And there's 2 layers to that mucus. There's the sole layer, which is the bottom layer, which is more water-like, and that's where most of the I would say, the water part of the proteins are, or the water part is, and then the gel layer is the top part where that has most of the proteins. Now, the difference between the gel and the sole layer is the gel part is the sticky part of your phlegm. That's where if you have a particle you inhale, that's where it sticks to it, and the cilia beats it towards the part of your trachea, and when you cough, and then you clear it out. So what happens when mucociliary dysfunction happens? It can be a primary problem, like mucociliary dyskinesia. There are certain genetic components that have mucociliary dyskinesia where they don't beat in a unified fashion. You can, for those of you who smoke, I had a mentor in respiratory therapy always talked about this. You take a big drag off a cigarette, and all that nicotine stuns all your cilia, and you can feel all that phlegm slide back down. So there are certain drugs you can take, and you can have primary disease state, you can take drugs, or you can be in a disease state, such as inflammation, that will cause the fluid to build up, it to thicken, and that will cause the difficulty for the cilia to beat in a unified fashion. So this is a microscopic image of what that looks like. So you can see the cilia as they're trying to beat the airway, and then we have, I don't know if this is laser printer there. Oh, it's a very tiny dot. Well, I'm pointing to the top there, and that's where the sole and the geral layer of your phlegm beat along and moves the airway forward. So when mucociliary clearance is overwhelmed, we have to rely on other mechanisms to expirate our phlegm. So high velocity airflow. So we try to get our cough to create shearing forces. So we want a high-powered cough that will shear the phlegm off the airways. And cough clearance, those are the secondary mechanisms. So in order to get a nice shearing force for expirating phlegm, you need a big volume to stretch all your airways and then generate a high force to create shearing forces to get that phlegm to move from the bottom to the upper airways. And that depends upon a couple of different factors depending upon the characteristics of your phlegm. So good cough clearance depends upon improved mucus cohesion, so that's when your mucus will stick together, and then lack of adhesion. So mucus cohesion is where the mucus sticks together, and adhesion talks about how it sticks to the cellular walls or the walls of the trachea and the bronchi. We want good mucus cohesion, low adhesion, so when that shearing force comes, that deep breath and shearing force comes, it will move it up the trachea and to eventually to the back of the throat where the patient can clear it, or you can suction it out. And then you want low sputum tenacity. So this graph here represents the cough clearability and the tenacity as is measured in a research study. So you can see as the tenacity, as the mucus is thickened, as measured by the tenacity, our ability to clear it reduces. So how we often do this is you want your patients to be well hydrated. If you have any medications that we want to deliver to kind of reduce that tenacity, that's what we may take of that. But most of the time what we focus on is making sure our patients are well hydrated and that factors like what Dana talked about, the airway humidity is well controlled so that we have the tenacity of the mucus as reduced as possible. Because if we have increased tenacity, we're going to have difficulty expirating helping our patient cough. So there are several medications that will help us assist with this if we have challenges with our patients. I usually put these patients into two buckets. They can't cough or they won't cough. And if I'm at the bedside, I'm trying to assess a patient, okay, this patient has increased secretions and I need to help them out. Is it because they can't cough, meaning there's an impairment to their system, or they won't cough because they're not willing to? We've got answers for either of those. So we were looking at mucoactive medications. There are a list of several types of agents. We have mucoactive expectorants. So this is hypertonic saline. Sometimes people have delivered dry powder mannitol. And what is the purpose of delivering hypertonic saline? Hypertonic saline has high osmotic pressure and pulls the fluid from the intracellular space into the mucus space. How many of you here have ever had to deliver hypertonic saline? And do you do it for mucociliary clearance or do you do it for a diagnostic procedure? Just shout it out. Diagnostic? How many of you have ever done it for mucociliary clearance? A handful of you? So I'm going to, go off script a little bit and editorialize. Doing this for airway clearance has its pluses and its minuses. It's very nauseating for the patient, and it also depends a lot on the percentage of hypertonic saline you use. I personally have used 3% hypersonic saline. I've heard somebody try and use as much as 9% hypertonic saline, and that's like really salty stuff to deliver to somebody to try and clear. Now, in my practice, I'm going back a ways because I'm in leadership, but when I used hypertonic saline for diagnostic purposes, we actually had a metric that we were trying to hit. I was expected to get 30 milliliters of phlegm from the patient as I was trying to diagnose, we call it now PJP, but pneumocystis carotidae pneumonia, which we often found in our HIV positive patient population. In order to get a clear diagnosis, we would deliver 3% hypertonic saline, and then I would try and get 30 mLs of secretions from them. And if I was successful in that, I'd get this gray solution from the patient. But oftentimes, if I was be happy if I could get as much as 10 to 15 mLs of the solution. And then the lab would actually look at this and say, well, we're counting the number of alveolar macrophages, and if we hit a certain threshold, we're going to say this is a good sample. If it's not, then we're not going to say it's a good sample. So hypertonic saline does work if you're trying to get secretions out. The problem is, does this actually help our patient in the long run? Because there's a couple of times, like I said, it's very nauseating to the patients, where they wind up vomiting while you're trying to do the procedure, and it takes a long time with a lot of volume of hypertonic saline. Then we have our classical mutalytics, sort of like acetylcholine and edrostein. It severs the sulfide bonds linking the mucins together. So again, we thought about that graph that had tenacity, where if we can lower the tenacity of the secretions, then we can aid the patient's ability to cough. And that's where these classical mutalytics kind of go into, is I'm trying to sever enough of those bonds so that part of that tenacity of the secretions is less sticky or less willing to adhere to the walls. And when I can help my patient generate that shearing force, it can get those out. We're using these in conjunction with our therapy, our skills as a respiratory therapist to help those patients expirate those secretions out. Then we have peptide mucolytics. This is Dorfa alpha geloside, non-destructive mutalytics, dexatran, low-weight molecular heparin. How many have ever delivered low-weight molecular heparin? I have in a burn patient population. And it's specific around heparin because there's a lot of clots are there. And, again, these break down the bonds and increase secretion. Hydrogen may break both hydrogen bonds and ionic bonds. Again, this is about how can I deliver an agent to make that secretions more easy for those patients to expectorate. Then we have mucoregulatory agents, anticholinergic agents, glucocorticoids, and indomethacin, macrolide antibiotics. And these decrease the volume of stimulated secretions, decreases airway inflammation, and mucin secretions decrease the volume of secretions. So there have been times I've had patients who are maybe very fluid up, and they're producing a lot of secretions. And this feels like you can go into the room, suction them, leave, come back 10 minutes later, and suction them again. How many of you had that experience? So in those patient populations, this is where like the glucoid, indomethacin, or the anticholinergic agents might be useful in kind of thickening out those secretions a little bit. I've heard anesthesiologists like to give this stuff before a case so they don't have the issues of secretions during the case. I would say I wouldn't use this as much as often. And then we have our clearance promoters, our bronchodilators, and surfactants. So again, a bronchodilator is not going to directly impact the ability to expirate. It's not going to impact the secretions themselves. What it does do is it increases the ability to take a deep breath and cough and create those shearing forces to get those off. Right? Remember, the cough is a mechanism. So I'm going at a couple of different angles. What can I change about the secretions, and what can I change about my patient's ability to take a deep breath and cough? So for mucoactive medications, mucolytics are divided into two classes, classic or thiol mucolytics that contain free sulfur digroups. N-acetylcysteine is the prototype. NAC and other classic mucolytics have not been shown to be effective in treatment of airways disease. So kind of want to emphasize that. These mucolytics have not been shown to be effective in the treatment of any airway disease. We're going to have an exception for peptomucolytes. A classic example being dorfalnase, for Dornase alpha pulmazine. That has been shown to be functional in CF patients. So when you think about our CF patients, they produce very thick, tenacious secretions as part of their genetic features. Alpha dornase has been shown to be effective in that patient population. Otherwise, there's been no scientific evidence to show that any of these mucolytic agents, mucoactive agents, actually improve outcomes. They may improve symptoms. They may improve short-term solutions, but for long-term outcomes, they're not that effective. And I think this is a slide that speaks to this and how dorfalnase is not effective except for diseases other than cystic fibrosis. And again, this goes back to, for most of these medications, they may reduce some symptomology, they may make your suctioning a little bit easier, but for the most part, there's little evidence to support changing in outcomes. And this is kind of research from a study that looks at the use of over-the-counter medications. Now, I personally use over-the-counter cough medications because it helps me sleep. Again, that reduces my symptomology, but it never makes my cold any shorter. Can I go back? There we go. So from this particular study, the WRSS-21 score is a 9-point symptom score that looks at people's symptoms while they have a cold, and they self-report, and this looked at Mucinex and a placebo. Mucinex is a very popular over-the-counter medication in the United States, and we see over the course of day 0 to day 8, there was no difference in the self-reported scores, symptom scores, between the placebo versus Mucinex. Again, it may reduce some of the symptomology, but over the course of time, there's really no difference in outcomes. So we still are looking for medications that can really help with expectorating or making this easier for ourselves. So in our bag of toolkit that we have the airway clearance devices. These are meant to augment our mucociliary and cough clearance by using breath techniques and promote the clearance of retained secretions. So these are devices that we can get off the shelf that we can take and have the patient blow on, or we turn them on the patient, and they will hopefully help us out. There are many different types of devices out there and many brands of manufacture, from chest wall oscillatory compression, and that's where you put the vest on and you turn it on and it vibrates externally on the patient. We have the positive expiratory and oscillatory devices. So these are the devices like the acapella and the aerobica that we blow on and they'll percuss on the patient. So when we think about traditional airway clearance devices, like let's take chest physiotherapy, for example. I'm going to drop the patient's head down. I'm going to put them in a particular position that the lung drains, and then I'm going to apply kinetic energy to that, the clapping procedure, or if you have a device, use the device. The point of all that is I'm using kinetic energy to force the secretions to move from point A to point B. And eventually, if I can make it move enough, then I can have the patient take a deep breath and cough, and we can get those retained secretions out. The problem with therapies like chest physiotherapy is very located to one lobe, right? So if I've got a right lower lobe, I'm going to place that into position. I'm going to do CPT on that. Hopefully, I can clear that right lobe. Some of these therapies, the advantages of is they do all the therapies, or all the lobes at a single time. So instead of targeting one particular lobe, you can get all the lobes at once. The other challenge with traditional therapies like chest physiotherapy is the distance between the skin and the lung. Now, this is probably not a secret. Americans have an obesity problem. So imagine you're trying to do chest physiotherapy to your standard American patient, and the distance between the chest wall where their skin is, where their side is, and where the actual lung is gets longer and longer, and that decreases its efficiency. And that's where some of these airway clearance devices come in helpful, because they're doing intrapulmonary. So you don't have to worry about, am I delivering enough kinetic energy? If I blow on this, all the lobes are affected at the same time, provides this percussive pressure. The act of the percussion helps the retained secretions move from point A to point B, which is the purpose of most of these devices. Unfortunately, the evidence for most of these ACT devices are limited, and we will discuss these at some length at our station tomorrow. Postural drainage, which I touched on, is the act of using gravity to help with this. Now, what I was taught with this postural drainage is you do not drop it for 5 minutes, you got to drop it for 15 minutes. You got to give it enough time for those secretions to kind of travel from point A to point B down the airway, and then we'll add a little kinetic energy so that when we have the patient cough, they can actually cough it out. One important to note, postural drainage carries an increased risk of gastroesophageal reflux and increased intracranial pressure. Now, if you've not been unfortunate enough to work in the ICU, forget to tell the nurse and forget the fact that the patient has, a ventriculostomy in, and you're starting to put them in a position to do chest physiotherapy or postural drainage. They'll come running at you and say, "What are you doing?" So I've seen that ICP monitor go up if we don't clamp it, and gastroesophageal reflux is kind of painful for the patients. But if you put the head down, there are going to be consequences. The blood flows down the other way, and if you have a patient with high ICPs, the blood's going to flow towards the top of their head, and those pressures are going to go up. The cough assist is a device that I have quite a bit of experience with. I worked in a trauma center, and we cared for a lot of trauma patients, spinal cord injury patients. We used to say, C345, keep the diaphragm alive. And we would come in with patients with a varied myriad of different spinal cord injuries levels, ages type 1 through 4, and difference of abilities to cough. And what we found is when we used the cough assist is that if they had a peak cough flow of less than 210, if we routinely use the cough assist, we could help that patient keep their lungs clear and stay out of the ICU. No more ICU bounce backs. No more. We really dropped the amount of acute respiratory failures due to retained secretions in this patient population. I'm really thinking about spinal cord injuries, but you also have neuromuscular disease patients. And when I talk about that, when I walk into a room, is the patient can't cough or won't cough? These are patients who can't cough. They cannot take a deep enough breath and generate a shearing enough pressure to make those secretions move up the airway. And so what a cough assist does is it gives a maximum breath so you can reach total lung capacity, you can stretch all those alveolar units, and then it switches to the exsufflation part where it applies suction, and then it helps shear those secretions off for the patient. And then you have your Yankauer there, and then you suction these patient populations out. These devices really work if you keep the patients on a schedule. They wake up, you give them their treatment, and you have them on a treatment of every 4 times a day or 8 times a day, whatever the regimen in for that patient population works for them. If you try to do it PRN for those patients, then I don't think it works, because what happens is some of these patients really can't tell when they're starting to fill up, and so it's easy for them to get behind. And how I personally found how it worked when we did the cough assist is we would give 3 successive inhalations, and then we would go to the really kind of a 2 to 3 second exhalation while the patient really coughed. We also often did this in conjunction with directed coughing. So directed coughing is when you have a patient who, like a spinal cord injury, is unable to generate a big cough because their muscular doesn't work as well anymore. And so I would ask my patient to count with me. So like we'll count on 3, 1, 2, 3, and I'm giving a big shove. That's very helpful. And it's awkward for people who've never seen it before because you think you're hurting the person, but they really don't feel that anymore. And you can give a big hard shove. The therapist who taught me how to do it, kind of in a crude manner, said you want to push them so hard that their head bounces off the head of the patient bed. I will caveat with the directed coughing technique. You must master your body mechanics. I've seen many respiratory therapists throw their backs out by not being careful with this. There are techniques where you can actually have if you have a big patient, lighter therapist, straddle the bed and use both hands to push. But you can combine directed coughing with a cough assist device to really help these spinal cord injury patients or these patients with neuromuscular disease like MS who can no longer generate those cough flows to help them cough. In some cases, you can save them from having a tracheostomy. So if you're really kind of committed to the technique. And what I really like about this type of therapy and subject is this really relies on your skills as a respiratory therapist to keep the patient well. This is you and the patient working together to keep them better. The physician's not going to come in and write a different order that's going to make them better, that their colleague following you isn't going to suddenly magically make it better. This is you working with the patient, using your skill set and your knowledge to help keep these patients well and out of the hospital sometimes. Now on to one of our favorite subjects is the subject of suctioning. Suctioning is a routine therapy in our field, and some people consider this as one of the most invasive therapies that we provide. So suctioning the airway is to facilitate removal of secretions in a patient who is unable to do so either because of weakness, they can't cough, or because of the presence of an artificial airway, as an endotracheal tube. So we all know that once you put the tube through the vocal cords, the normal mechanisms for cough are no longer there. They can't close their valsalva and they can't generate enough pressure on their own. So we have to suction the airway out to keep the tube clear so that they can breathe easy. Modern philosophy says whenever possible we want to use a closed suction catheter. So on this photo here, you can see the endotracheal tubes connected to the suction ports with, and whether your device is it's either locking or not locking, or you can turn it. Then we have, this is a bloody one. So, and then we have our suction tubing to our control port, and then to our suction line that goes to our canister. So there should be a port to instill saline solutions, and then you have your endotracheal tube here. Like I was saying at the start of the presentation, when I began respiratory therapy nearly 30 years ago, really dating myself, I worked in a trauma center and we almost did exclusive open suctioning. And it was almost seen as kind of being lazy by trying to go to the inline suction catheter. And we learned over time, as through science, is that the act of taking the patient off and do open suctioning every 4 hours, we were substantially increasing that risk of that patient developing a ventilator-associated pneumonia. So what the clothesline suction catheter really provides is the ability to suction patients without opening the ventilator circuit. So every time we disconnect that ventilator circuit, we are increasing the risk of the patient developing a ventilator-associated pneumonia. So the value of the inline suction catheters, we're not doing that. There is some skills related to this and some dangers if you're unaware of. One of the dangers is if you, on that port, that suction port, when you're not using it, you must keep it in the closed position. There have been case reports of it being left in the open position. It gets stuck between the bed and the bed rail, and then you have continuous suction on, and then you have massive atelectasis from that. So you want to be careful with that. So whenever it's not being used, it's in the closed position. Whenever we instill saline, we use the minimal amount possible. Again, when I'm dating myself, we use large amounts of saline. We now know better. We use as small amounts as possible. Part of the reason for this is that along the endotracheal tube, once a patient has been intubated for a couple of days, what starts to form is a biofilm on the inside of the endotracheal tube. So a biofilm is sort of like an agar-like material starts to form from the expelled breath condensate, any of the material that's in there, and it starts to become a almost, when I say agar-like, it's like we're doing a disc for infection, and it almost becomes like that. And if you are overly aggressive with your suction technique, you can start to break those pieces off, and they'll fall back down into the airway, or into the patient's airway, and they can develop an infection from that. There were devices developed, I would say, about 10 years ago that were looking at scraping that biofilm off, but I don't think any of them really panned out for any positive results. So we're going to advance the suction catheter down. We never want to go down to where we bounce it off the carina. We want to advance it just past the endotracheal tube and suction there. The reason that we don't want to advance it much further past that is once you start hitting the carina is the most sensitive part of the lungs. It generates the biggest cough, but you also cause a lot of trauma in there. And I would crudely joke with people, you're suctioning a patient, you're not doing a crude lung biopsy. So you want to be very cautious with that. And then you always want to, and this is why this photo annoys me so much, is that you want to rinse the tube. You want to, when you're done suctioning, you want to make sure that the suction line and the suction port is all cleaned out afterwards. If we suction routinely, and as necessary, we will reduce the risk of infection. We also make sure that the airway is clear. And with the airway clear, and when I say clear, if you start to have a buildup of phlegm around the endotracheal tube, and then sometimes there have been case reports where you try to do your spontaneous breathing trial, if you've not had adequate hydration, if you've not managed the airway correctly, then they're going to fail because if it got some mucus plug sitting at the end of their tracheal tube. Like I said, it should never be advanced beyond the tip of the airway, and this includes trach patients as well. There is no evidence to support the use of deep suctioning as it carries risk of airway damage and laryngospasm, and I said we should only use small amounts of salines due to the risk of disrupting the biofilm. So lung recruitment or lung expansion therapy is used to increase inspiratory capacity. Again, we look at the cough mechanism as a mechanism. We take a deep breath, and then we cough. When we cough with a high pressure, we get those shearing forces. Lung recruitment is part of that process where we want to expand and stretch the lungs and the alveolar units as much as possible. So when that cough mechanism comes, we can generate that shearing pressure to make the secretions move from point A to point B. Incentive spirometry is the most common, but the data is limited, except to patient with etiologies such as sickle cell. I joke that the incentive spirometer, you'll find it on most patients' bedsides, but it's the least used device. And I think the research is really supportive right now is if your patient's mobile, it's better to get your patient up and walk around than the incentive spirometer is useful. But if your patient is not able to do that, then they really should be focusing on their incentive spirometry. Stacked breath is helpful in neuromuscular patients in illness. So what a stacked breath is, I don't allow my patient to exhale fully before we cough. So we're going to take a successive breath until we reach total lung capacity, and then we'll have that patient cough. There's a couple ways you can do that. You can have them breathe in. But there's also setups that I've seen work where we'll fit a ambu bag with a mouthpiece and we'll assist them
3 minutes
until they get. I'm almost done. Yeah. Where we'll assist them, and then when we get to total lung capacity, we'll have them expirate and cough. So key concepts here, we have quite a few. I'm not going to really go into detail on these. My expectation is that they're in the textbook that you've received. We'll go over them again at the Airway station again. And so I think I am done. Are there any, do I have time for a question or are we good?
Later on, we're going to make it.
We'll make,
Yeah. Thank you, Mr. Hinkson. As this session started by my colleague, Dr. Taha, so we are gladly conclude this session number 1, and I'm going to pass to Mr. Hassan.
بسم الله الرحمن نبدأ يا لطيف حليم بسم الله الرحمن نبدأ يا لطيف حليم يا
my slides. السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم بكل خير، وأهلا ومرحبا بكم جميعا لحضوركم وتشجيعكم، فهذا المؤتمر منكم وإليكم، فأهلا ومرحبا، ونرحب بالزملاء جميعا من حيث أتوا. The first thing, I would like to welcome you all for this conference here in Al-Mana College. For that, we thank them so much. And I would like to call upon my colleague and friend, Professor Jerome Sullivan, to make an introduction about the course.
Thank you, Hassan.
You can walk.
Yeah. Okay, good. It's nice to say hello and welcoming you to this portion of the program, which is to spread around some friendly, welcoming words to people that are responsible for putting on a program like this, and a publication that we have very good news about, the Fundamental Respiratory Care Support course, and I will proceed to do that over the next few minutes. In this teaching situation, over the next 3 days, we will actually be pulling material from 20 different chapters, 20 different authors from the fundamental course, and move forward. I did want to comment on the fact that this effort is a tremendous effort that has been going on for the better part of a decade. And it is finally coming to fruition and being recognized. This particular course, not just today's and tomorrow's, but The program itself has 36 chapters with authors from 29 countries and a total of 31 different authors. And as you recognize, this is like leading cats. And we wanted to recognize our editor, Dean Hess, who did a tremendous job, the yeoman's task of going through and working with all this material. And of course, Hassan Al-Araini. He and I spent a tremendous amount of time over the last few years to develop these chapters and the skills stations and so on, and to raise funds to pay the authors and to pay for the material to keep it up to date. And we raised in excess of $85,000. So that's what brings the course alive and brings it forward. I want to recognize Hassan Baba in the fact that he is the first RRT in the kingdom back in the 80s. And he's largely responsible for bringing respiratory care forward throughout the Middle East and certainly beyond the Middle East around to countries in other areas of the world. He is recognized as a fellow of the American Association for Respiratory Care, and even further, just recently at the annual meeting of the AARC in Phoenix, he was designated as a legend of respiratory care, both internationally and through the AARC. So Hassan has done a tremendous amount of work, and I wouldn't want to go forward without doing that. However, his soldiers, I'd like you to recognize them. In the audience, we have a number of authors from the fundamental course. I would like you to stand, any of the authors, I'd like you to stand and be recognized so people can know who you are. We're not going to introduce people, but it'll give you an idea how many people have been involved in this project. Yeah, you can stand. If you haven't done it, please do. These are our soldiers. They carried this forward, and we're very proud of them and their efforts, and we'll continue to do so as we move forward. This is really Hassan's moment in that we could never have done this. It was his unwavering force that made this come to fruition. So he is a legend, as we had recognized at the AARC. Really good news that has come in the last couple of months. Finally, the manuscript has been recognized by the United States Office, and it has been copyrighted, which we are very proud of, and it has established an international book number, which is also a great thing. So for the authors, if you haven't done it, you can now begin to write your citations for what has been going on. So I would like to pass this along to my colleague, Dana Evans. If you'll come to the microphone. She is experienced in adult, peds, critical care, even in transport medicine. She's the regional director for Midwest Advocate Health. She received her degree from University of Missouri. She's a fellow of the College of Healthcare Executives, and I would like to pass along that to Dana.
Thank you. Thank you so much. Good morning. Thank you so much for having us and welcoming us so openly to Dammam. I am have the great privilege and honor to welcome all of you here to this incredible event on behalf of the American Association for Respiratory Care. It is my great honor and the highest honor of my professional career to serve as the president of our association and to be present at events like this and meeting so many incredible respiratory therapists, respiratory therapy educators, and respiratory care students. This is our second offering of the Fundamentals of Respiratory Care course, the first of which was offered, as many of you know, in 2024 in Riyadh, but it's our first offering of the Best of AARC. This is a really unique opportunity to get sort of a sneak preview of the type of programmatic and educational content you would see at the AARC International Congress, which will be held later this year in New Orleans, Louisiana in November. So I'm excited for that. I also hope that over the next few days you have an opportunity to meet with each other, to grow and to connect, and to really be inspired by the incredible education that you'll see here, but also by each other. You have a great opportunity to meet with local faculty members as well as esteemed international faculty from across the globe, really recognizing the reality that respiratory care is a strong and international community. I hope that you will leave here inspired and excited for the state of our profession as well as the future of what's to come for each other, for our profession, and for our community of patients that we serve each and every single day. As I said, it is my distinct honor to be here, but I also want to say thank you to a few people. So I'd like to acknowledge and thank the College Alma Mater for allowing us to be here in this beautiful space for this educational content. I want to thank our vendors and industry partners without whom this event would not be possible, so please be sure to visit with them in the vendor hall and say thank you. And I, of course, want to thank Mr. Hassan Al-Araini, without whose tireless and dedicated efforts we would not be here today, as well as the incredible Jerome Sullivan for their work on this event. So again, on behalf of the AARC, thank you so much for being here. I hope that you enjoy the next few days. And are inspired, as I am inspired by each and every single one of you and the incredible caliber of respiratory therapists here in the Kingdom of Saudi, as well as the amazing respiratory care programs that you have the privilege of connecting and working with every single day. Thank you. Thank you to all of you. Next, I'd like to invite my colleague, Dan Garrett, to the stage as well. Dan is the Executive Director of the Executive Office of the American Association for Respiratory Care. He leads a team of incredible professionals who work tirelessly each and every day to support respiratory therapists in the United States and around the globe. Without our executive office and our paid staff members, much of what you see coming out of the AARC simply would not be possible. So thank you, Dan, and thank you to all of the staff members that do that work. And I'll turn it over to you. Thank you, sir.
Thank you very much. I'll be very brief. The thank yous have been made, but I want to especially thank Hassan for all of his hard work to put this on. He cares so much about respiratory care and is so passionate, and I think that's evident in all of his work that he has done along with Jerome. So on behalf of the staff of the Office of the American Association for Respiratory Care, I want to say thank you, and it is such a great privilege to be here with all of you and to be in your company. And I look forward to facilitating a session, I believe in a couple of days. On the last day, Jerome and I will be facilitating a session, so looking forward to engaging with all of you then as well. But I encourage all of you to really network, connect with each other, share information, share ideas. That's really the power of having people together like this. So I hope you all have a very good conference. And again, thank you so much. It's a privilege to be here.
Thank you, Sullivan. Thank you, President Dana. And thank you, Dan. And thank you all for coming. I have a few items to talk about, then we will have in the end a few thank you items. This is our committee, basically, who sit together and basically plan for this. Those are our faculty, elite, the best you can go with respiratory care anywhere in the world. And here is our local task force who helped me with a few items. Those are local participants. I'm so happy and so delighted to have all those professionals in my side, supporting, guiding with advices, and so happy to see all of those people. The list goes on. Now, this is basically the next few slides about our program today. Full day is open for anybody who registered for Best of AARC. It's also for the people who registered for neonates. That's today. So everybody here should be. How many people here who are registered in neonatal and pediatric course? Good. Ask the others to come. You know, you are all therapists anyway. Now, and how many registered in Best of AARC? That's good group. You continue today, tomorrow, and afternoon, and Saturday. And how many people in adult? They should be all here because you have workshops tomorrow, and this is your course. So this is it. We are done with this session. This afternoon, three lectures. Then we have lunch break. And then we continue after lunch, as you can see. All this program is in your book, and also you can go to the mobile. Then tomorrow in the morning, we will have 3 workshops: aerosol therapy, airway clearance, and airway management. State of the art, best equipment, and everything. Tomorrow morning, this is for the adult. In the afternoon, also continues with leaders of the profession, workshops in the afternoon for the adult registries. And then please do not attempt to change your name, do not attempt to change your group. We divide them by group A and B and C, and it's not just selected any group. We selected based on the grades that you made, what hospital you are at, and your level of expertise. So this is how we grouped it. For adult, there is 3 groups. Each group is about 26, something like this, because it keeps increasing until this morning. Neonates, same thing, because we have only 2 workshops, we divided by 2 groups. Now, this is Friday. We have the morning. The next few, tomorrow and after tomorrow, we start at 8. So this is good. So Friday morning, you will have the neonatal lectures. Then after the break, there are 2 lectures. Then comes the lunch. Notice the neonatal lectures are longer. They are 45 minutes. They are not 30 minutes like the adult. Now, and then in the afternoon, we have 2 workshops. And just basically 2 groups. They flip in the middle of the day. And then in the afternoon, starting at 1, we have very important session. I don't think this is working. We have important session. This is very important for educators about possibilities of collaboration between schools and things like this. We have the leaders of the profession and also the leaders of educators in the United States. Also in the afternoon, we have the leaders of management. So any manager in this department will tackle those issues. And then continues to pulmonary function, 3 lectures. 1 is a company. And then meet the industry session, a 10 minutes presentation for those companies. And then we, toward the end of the day, we have 5 minutes. We have the abstract, 5 minutes each. Those are the top 5. And then we have the post-test. Remember, tomorrow, at the end of the day, there will be 5 workshops going on at the same time. When you are done at 5, around 5:30, you need to come back here. Then you will get your test, whether you are an adult or neonate. You come back here after you are done. And then people who take this test, if they pass, they will get this certificate. And it's notarized and approved by the AARC. And then Saturday, we will have from 8 state-of-the-art lecture, and this is where the best of AARC came from. Because when we have that course in Riyadh, we were asked why you have all those professionals not give us a chance to listen to them with higher degree of lectures. So here we go, we will have very state-of-the-art lectures. Please note that in your book, we printed it early, so there was a little problem with the timing, but there's already an insert, and also outside it's changed to the right timing. Okay, so we conclude Saturday. Coffee break is upstairs in the middle of the exhibition, and I will stay with this. And the lunch is down the hallway to the end. Someone will guide you. Now, I would like to continue with this. A few thanks for our American Association for Respiratory, our collaborator, basically, American Association, Johns Hopkins, AIEU, Saudi Society, and Prince Sultan Military College. I would like to thank the companies. Without them, we cannot proceed, basically. You have all the expertise, but you don't have the people to pay for the faculty and things like that, okay? Thank you to everyone, of course, and special thank you to Muhammad Al-Mani College of Sciences, of Medical Sciences. We thank them so much, so they really deserve a big applause. It's a beautiful facility. It cannot be better than this, to be honest. Thank you for your support, Al-Mana. I would like also to thank Al-Faisal, who hosted the first course, and they're still working with us on CMEs and other issues. Now, I would like also to thank our faculty members who left their home and came all the way here, and some of them are local. I would like to thank you for taking the time to register and to come and learn and be exposed. Okay, just to let you know, there are some CMEs, Saudi Commission 26 CMEs, and 25, almost the same, 0.97 from the AARC. Okay, there is a Saudi Commission. You must, on Saturday, if you need CMEs local, you must fill that sheet on Saturday. Without this, you cannot go nowhere. So 26 and 25.97, there will be an evaluation, certificate of attendance. Evaluation online, you fill it, and then in the end, it will print the certificate to you, and we'll send it also to your email. This is the certificate of attendance. And then this is extremely important. It's a booth visitor stamp. Every booth up there have a small stamp. So when you go on tour, make sure you get it stamped. And it has 16, I think. You need just to stamp it. And when this is full, you need also to circle the one you think the best booth in your opinion. And then there is a box at the reception. You drop it there. At the last day, we'll make a draw, and there will be a grand prize for the person who fills all of those. And there is also a spirometry challenge, per se, for male and female. You go to NDD, because they have a booth up there, and you just give it your best blow. And then they will give us the best results. And then we'll see who will get the prize for this. The pre-test, now I will do some statistic for you. We did 150 pre-tests. And here are some, and I will go over the statistic after. Just to let you know, we are live streaming now as we speak in all those forms. So if you know a colleague who cannot make it, you can just send him the link for this. Okay. Yeah, this is the registration breakout, basically. Best of AARC conference, okay. Pre-test, those are the result of the pre-test, okay. As you can see, we have the top who gets the top grade from Prince Salman, King Salman Armed Forces Hospital in Tabuk. They got 88. This is the highest grade. And from the Neoped, Princess Noura, and this is the name, not to hide. And as you can see, they are from different schools. This is King Saud ibn Abdulaziz University, Riyadh, King Abdulaziz University, Jeddah, they're almost the same degree. And down here in the neonate, almost also different, from different places within the kingdom. So I'm happy to see this diversity. Now, this is the count. We have 24, 24, 24, 72. I think now we are 78 or maybe more because they keep registering every day. We have 26 and 26 for Neoped groups. And this is the textbook. It was sent to everybody who took the pretest. And this is the specialty count. We have respiratory therapists 181, respiratory interns 51, 52, student 30, maybe more. I think there's an issue there. Intern, fellow, and training 15. We have 12 intensivists. We have acute care nursing 5. We have a total of 298. I think it's way more than. This is only the pre-registered. And here is by city, registration by city. In Dammam, obviously, 126. From Riyadh, 80. And from Jeddah, we have 41. From Medina, 11. And it goes down the list. And here is sorted by, this is the top institution registration. The top is Almana, and there is a reason. You should know why. Number 2, Princess Noura from Riyadh University. From Riyadh, Princess Noura University. And that we have 51. From Imam Abdurrahman, obviously from Dammam, 38. And we have Prince Sultan Medical College. We have 29. And the list goes down. And this is the number. We have had 68 research abstract, and really high quality. And you will see it up there. There will be also, the top 5 and the top 10 and all of that later. But we received from Imam Abdurrahman 20, from King Saud bin Abdulaziz University, Jeddah 9, King Saud Riyadh 7, and then Prince Sultan Military College 7, Almana College 5, and the list goes down. Princess Noura 4. And this is how it goes. From Dammam, 37 abstract. Of course, this is really the hub of respiratory care in Saudi Arabia. It's Dammam more than anywhere else, though it's growing everywhere. Now, this one, I think we will talk about it later. Now, I would like to call upon President Dana Evans and Dr. Sullivan to come to the stage. We have a few presentations before we break.
Thank you, sir.
I would like to call Mr. Othman to come and receive a plaque of the company that first ignited the support to this meeting, and they paid the highest, and they have been truly supportive from day one. Can I have it, please? Picture.
Stay for photo.
Picture.
I'm gonna get a photo.
Yeah. That's
We're
why
gonna
it's
put him
black.
in the middle.
That's why it's dark.
In the middle. Tall guys on the end.
Thank you. Thank you. Thank you. Next is Princess Noura from Riyadh. Where is the head of the department? She's not here. Okay, we can leave it in the side. Princess Noura, because of the number of registration, despite of being from Riyadh, they have the highest registration from anywhere outside the Eastern Province. Not only this, but also they have the top grade in the neonates. So Al-Mana, Muhammad Al-Mana College, we cannot thank them enough for that. And I have this plaque. Where is Sukaina, please? Sukaina, you have also a certificate of appreciation, but we can give it to you after. But Sukaina have been instrumental from day one in orchestrating all the activities within the college. And also, Mustafa, where is Mustafa here? Come, please come. Mustafa is in charge of the lab, and he was able to acquire all equipment that we need. Most of it is from Al-Mana, but there are many that are brought from outside as well. So Mustafa is the dynamic. He put a very nice listing to all the faculty from all over the world, and we are very delighted to have him. Thank you, Mustafa. Wait. Okay. My work cannot go, period, without the support of two individuals. My designer, maybe he's seeing me on YouTube or on Edward Garcia, he lives in the Philippines. So every day he and I on team or Zoom, working on every artwork you can see, he have done it. So for that, I thank him so much and I appreciate him. Maybe he's hearing me now. The second person, who else? Noura. Noura, many of you are talking to her in Arabic, but she is from India, and she has been with me for many, many, many years, and she is so dynamic. You know me, I get hyped and things, but she calmed me down. So for that, I appreciate her. Okay, also I must not forget three individuals also. They are also in the team. Nasser, he works for me in the office. He's doing all the printing you see. He goes to the printer and makes sure that everything is done right. I have also Mitu. Is Mitu here? He's outside, of course. He has done all the online exams. Also, Rashid, he is the guy who's making changes the name, and he's helping in everything. He's also her husband. He's the lucky husband. Now, I want to tell you, this is the final slide. I want to tell you that this work you have seen done is not easy. It's not easy. You can see how many files that this side is the designer here. And there are 52,000 files and 9,588 folders. All of that is done within, just started with one, then keep increasing. Now 51,000 files. And this is Noura Hanai folder, which contains 2,480 files and 300 and 41 folders. This is all the letters that came to you, the invitation and so on. With that, we thank you very much. The break is intentionally made to be in the middle of the exhibit hall, so you can also visit with the company. We encourage everyone to visit and see. Is this Dr. Frial? She is the dean of this college, and she is the essence behind our success. We have a word for you, but thank you very much. Okay, we can now go for our break.
Go to break.
And please be back 10:30 sharp. We will start. Thank you. Good.
Mike.
خلاص ابدا انا بس طفي اللي عندك شو اسمه طفي هذا الميكروفون. Good morning again, everybody, for our second session. And it's our pleasure to introduce Dr. Rachel Sullivan, a trauma and emergency general surgeon and a surgical intensivist in Toledo, Ohio, USA. Dr. Sullivan, she is a fellow in the American College of Surgeons, and she has a practice at leading institutions, including Cleveland Clinic. Her clinical interests including operative trauma, emergency general surgery, and resuscitative critical care. And we are honored to have her here today. Please join me in welcoming Dr. Rachel Sullivan.
Okay, everybody can hear me? Okay. Thank you very much for welcoming me back to Saudi Arabia. I am very excited to be here. How do we push this slide? Okay. So, are we able to project the screen here? Excellent. Okay, thank you. My timer starts. So you can see here we have plenty of objectives. You can read that in your book. But what we're going to talk about today is airway management. There's a number of goals with airway management: oxygenation, ventilation. Remember, those are two separate processes. Ensuring patency of the airway, preventing aspiration as much as possible, and all while promoting cardiovascular stability. So I'm going to discuss some points of anatomy here. It's a relatively busy slide. However, when I was an early learner, it was difficult for me to imagine what the airway anatomy truly was, because you can't really see it very well. So I'm going to attempt to use this laser pointer. Okay, we have our nasopharynx, our oropharynx, larynx, trachea, okay? Important structures to talk about are this large muscular tongue. What we see on the outside is just the tip of the iceberg, and this is, I'm gonna refer to this multiple times, and essentially, how do we manage that, keep that out of the airway to allow for patency? The next important structure I'm gonna point out is this groove right here. It's called the vallecula, okay? Behind this is the epiglottis. We've got our esophagus and we've got our trachea anteriorly. So the vallecula is going to be very important. If you look over on the other side of the screen, this is as if you're looking down the airway, base of the tongue, epiglottis, which usually flaps over the vocal cords to protect your airway. And this is another part of the management of obtaining an airway. Last anatomical points to show: thyroid cartilage. That's the Adam's apple, but men and women have it. Then we go down farther, our cricoid cartilage. I'll refer to that later. And then below that are our tracheal rings. So as with any clinical situation, you have to assess your patient. Look, listen, feel. Within 0.3 seconds of walking into a room, you can do 2/3 of this slide. Look at the patient. Are they conscious? Are they breathing? Are they breathing shallow? I'm a trauma surgeon, so I'm looking for injuries in the face, neck, chest. Look at the mechanics of the chest wall and how they're breathing. Are they tripoding? Do they have an open wound in their chest? You can see all of this before you even touch the patient. You can often hear, are they having muffled breath sounds? Are they gurgling, wheezing, stridor? This is all before you've even put your stethoscope on or laid your hands on that patient. When you listen, you may hear rhonchi, crackles, wheezing, etc. When you examine the patient, you may feel crepitus. That indicates some sort of damage in the tracheobronchial tree, and that air is escaping into the sub-Q. Look at chest wall deformities, flail chest, open wounds, etc. So this can be done within seconds of walking in a room. And the farther you get on in your career, the quicker you're going to make that assessment. So there's a number of basic maneuvers that you can do. And essentially, it's to get that soft tissue, that big tongue, off the back of the neck to get airway patency. That's what some of these maneuvers achieve. So we have the head tilt chin lift. You simply place your hand on their forehead, grab their chin, and push up. Now, I'm a trauma surgeon, and every one of my patients comes in a C-collar, or they should. If they don't have one, they get one. And you can't extend their neck. So for patients like mine, or patients that have had previous cervical spinal fusion, bad arthritis, old folks with the bad kyphosis, they can't extend their neck like this. So a really nice technique is the jaw thrust. You put your fingers on the angle of the mandible bilaterally and push forward. And that also helps try to get that soft tissue off the back of the neck and open that airway. These devices help us as well with patency of the airway. On the green screen here, that's our oropharyngeal airway, and then we also have our nasopharyngeal airways. Some things to note, oropharyngeal airways can only be used in patients that are unconscious. As you can see here, it goes down, almost tickles the epiglottis. This is incredibly aggravating to folks, so you can't use it on somebody that's conscious. The nasopharyngeal airway is much more friendly for a conscious patient. It's a small, squishy silicone tube, and that is much better tolerated, and as you can see, doesn't go as far down the oropharynx and isn't quite as agitating. For both of these devices, you want to measure from the corner of the lips to the pinna of the ear, or nose to pinna of the ear. That's the length you want for that patient. And then in terms of the nasopharyngeal airway, you want to use something that's the diameter of the patient's pinky. So those are just rough guidelines. The next maneuver that can be used in conjunction with the previous two slides we've discussed is bag mask ventilation. I'm sure many of you are already familiar with it, but key concepts to remember are you can't bag an airway that's not patent, so you want to make sure you're opening up their airway as good as you can. You need to get a good seal between the mask and the face, and I'll talk a little bit how to do that. And then you want to deliver your breaths at an appropriate frequency and tidal volume. Frequency, 10 to 12 times a minute, and tidal volume that you're achieving is just enough to see the patient's chest rise. So generally in all these exciting emergency airways, people are bagging like crazy and giving too much and giving too fast of breaths. You don't want to do that. Take your pulse first, slow down, bag appropriately. Overventilation causes a number of issues, not only barotrauma, but you can overdistend the stomach, so then you cause emesis and aspiration. So those are concepts you really want to be paying attention to. You have both one-handed and two-handed bag mask techniques. Most folks teach the C shape, the CE shape. Your thumb is at the apex of the mask, which is on the bony bridge of your nose, and your pointer finger is on the bottom of the mask. The bottom three fingers, you're grasping the bony edge of that mandible. And I make that note because don't grab the soft tissue that's inside of it. You'll cause bruising, and you won't effectively lift that mandible to help open the airway and maintain that good seal. If you are lucky enough to have another person, you can do two-handed techniques, and then the second person can bag. So the next thing we'll talk about are supraglottic airway devices, so above the epiglottis, right? The most common is a laryngeal mask airway. As with all of our other tubes, we have a cuff and then a pilot balloon that's connected through tubing, a rigid airway tube to prevent it from kinking, and a bite block at the end. These are inserted through the mouth and down through the oropharynx until you hit a hard stop. What that hard stop is essentially the apex of this hitting the esophagus right behind the vocal cords. So the aperture in this puts air through the vocal cords and in theory prevents some aspiration from the esophagus, in theory. So the next thing we'll discuss is endotracheal intubation itself. So a definitive airway is defined as one that goes through the vocal cords. So the previous maneuvers and devices we talked about are not definitive airways. Endotracheal intubation is. Again, it helps maintain patency. Again, you're oxygenating and ventilating for the patient. It has the added advantage of bypassing any upper airway obstruction, and you can suction deeper. All those tracheal bronchial secretions you can get to. I make a note that it limits aspiration. Despite the cuff being blown up, you still can have micro aspirations around the cuff, so it's not a foolproof method, but it helps. Also, it reduces your anatomic dead space, so the breaths that you're giving are actually getting to the lungs. So again, you're going to assess your patient prior to endotracheal intubation. What are we looking at? How big can they open their mouth? Some folks, you've got like a centimeter. That's going to be a difficult airway. Prognosticism of the mandible. Does your chin protrude, or even is it receded? Okay. Speaking of that, dentition is important. I never quite understood this as a learner. Why does that matter? Well, actually, what happens is you have bone reabsorption of your jawline when your teeth are no longer there and they're not getting that stress loading force while you're chewing. And so the bony structure of your face changes. And then you also can't make an effective seal when you're trying to bag mask. So that's actually why it matters. Can you extend their head? I've already discussed situations in which you cannot. Cervical spine trauma, suspected cervical spine trauma, previous cervical fusion, severe osteoarthritis, severe kyphosis, etc. And then the Mallampati score is used usually by anesthesiologists in an elective situation, say, how much of the back can we see? You know, the more the better. So that's something that generally we're not doing in the trauma bay or even in the ICU, but if you have the opportunity, this is definitely something to look at to assess what type of airway you're dealing with. Thyromental distance, that's your chin to your thyroid. It's about 6 centimeters is the cutoff, 5.5, 6, saying, oh, that's going to be a difficult airway or not. And anything that makes bag masking difficult. So is your patient extremely obese? Do they have facial hair? Facial hair, it prevents a good seal with the mask. Big beards, those are difficult, even mustaches sometimes. Facial trauma, when I get a gunshot to the face, I can't really always bag mask them. Maybe I can intubate them, I don't know. It's still gonna be a hard airway. So in my situation, that's something that I'm also always looking at. All right, so talking about endotracheal intubation, there's lots of equipment. So I'll go over a number of these. Direct laryngoscopy is when just the proceduralist is able to get their blade in and assess the airway. The most commonly used blade for this is the Macintosh. It's the curved one. That tip ends in the vallecula, which I've already pointed out in our previous anatomy. And then the Miller blade, which goes behind the epiglottis and directly lifts it, as opposed to indirectly like the Mac blade. These are fine if it's an easy airway, if you're in an elective case, that's great if you're very experienced, or even if you're not. These are fine, they're traditional, and that's fine. My favorite, however, are the video laryngoscopes. They're constructed like a Mac blade with the curvature. It's a little different, a little more bulky, but everyone in the room can see what you're looking at. So when I'm in the trauma bay and somebody else is intubating and I can see what's going on in there, I know if I need to have my scalpel open or if I can just leave it in my pocket. So that's nice so everybody can see what's going on. So the tube itself, again, pilot balloon tubing connected down to the cuff distally. And you've got usually a stylet that goes through your tube, which confers rigidity, allowing you to pass it through the airway. Again, this is the definitive airway. Before I move forward, I don't have a picture of bougie, but a bougie is also a thinner, flexible plastic tube that's thinner than the ET tube itself and can go through the inside diameter of the tube. That's a skinnier option that can be used if you're having trouble. So I just don't have a picture of that. So positioning is also important. Normally, when the patient is supine, we have our laryngeal and pharyngeal axes, and they're at quite an acute angle, which means you don't have a direct line of sight, and it also means you can't directly get that tube in. If you're able to put that patient in a sniffing position, you've now aligned your axes and made your job a lot more easy. So if you can't do this position, you don't have that conferred advantage, but that's why we do what we do. So in terms of your procedure, this is kind of a boring slide, but it's also one of the most important slides. If you mess up anything in this slide, your patient could die. So I know it sounds dramatic, but when you've been around long enough, you'll see enough things. Check all your equipment. Yes, that means make sure it's in the room. Don't have somebody say, oh, yeah, I think we've got that. No, you show that to me before I paralyze this patient. Let's make sure it's in the room and we're not scrambling if we have an issue, okay? Check your tubes, check your cuffs, all that. While you're doing that, ideally somebody else is monitoring your patient's vitals, giving them 100% oxygen, keeping an eye on that so you can deal with your equipment. Often you're in a team environment, so there are more hands on deck. Once you have everything set, you want to administer your medications, which I'll talk about in a little bit here. And then after you allow for those medications to set in, then you can go ahead and start. I make a point of that because ideally, if you could wait about 3 minutes, your patient's going to be fully relaxed, fully paralyzed, and it helps facilitate your job. Folks that just push the meds and then all of a sudden are like, oh, I can't open their mouth. Well, yeah, they're not paralyzed yet. So go ahead and wait. And if you can wait that full 3 minutes, the SATs are fine, they're bagging okay, great. Once you get the medications in and you're ready to go, you want to position your head and neck appropriately. So sniffing procedure, or in the case of a C-spine injury, you take the anterior portion of the collar off and you have a separate provider whose job is solely to hold inline C-spine mobilization. That person will hold while you intubate. After you get the tube, collar goes right back on, okay? And that has to be a separate person. You can't do that safely if you're doing anything else. So the procedure itself, you'll take your laryngoscope, and here I'll point out, this is the MAC blade, and they're using direct laryngoscopy, and you see it terminates right here in the vallecula, right between the tongue and the epiglottis. And the move for when you're intubating somebody is you're not going like this, okay? Unless you want to break their teeth off or cut their lips. What you're trying to do is pull up at a 45-degree angle. So when I first was learning this, I had a great RT who taught us, look at where the ceiling meets the wall up here and push your arm that way. And your thumb should go that way too, right? Because you might be nervous, it might be kind of an exciting situation, and you're like, I don't know what's 45 degrees, what, protractor, is that what measures it? I don't know. You don't know, so just go like that and don't crank back, okay? And that's something important to remember. And you're in this situation with the MAC blade, you're indirectly lifting that epiglottis. You're not right behind it like you are with the Miller blade. So once you get in, this is what you're going to see every time, right? Beautiful, perfect anatomy, great vocal cords. There's no blood in the airway. There's no vomitus. There's no sputum. No, that's not how it is. But in an ideal world, this is what it looks like. So this is the same cartoon that was on the very first slide, and it was always hard for me to visualize, like, okay, that's what it looks like in the book. It was hard in real life for me to see it. But here I think this picture is really nice. You can't see the base of the tongue here, but you see the epiglottis and a beautiful view of the vocal cords. So this is what they look side by side in a perfect world. Generally, it's not that perfect, the view's not that great, and that's okay. You'll want to make sure that your suction is already to go prior to even starting the procedure. Suction in there, try to get the blood, the mucus, the vomit, etc. out. Grass, I don't know, whatever they've aspirated out in the field, who knows. Get it out of the way. And the most important thing is you need to watch the tube go through the vocal cords all the way and have the balloon blown up while you're watching, okay? You don't see it and then be like, oh, I think we're in. Because when you think you're in, then you're gonna have a respiratory code in a couple minutes. So you wanna watch it. When that balloon gets blown up, sometimes it pops back up and it's kind of like halfway through the vocal cords. That's not okay. Sometimes it pops all the way back up and it's not in the past the vocal cords at all. So that is something that you need to be very careful about. So this slide, also kind of boring, also just as important, because also if you don't do it, your patients could die. I know, again, dramatic, but it's the case. So you need to confirm your placement. No, oh, I think we're in. You watch that tube go in. You get your CO2 detector. I love the colorimetric ones. They're cheap, they're everywhere. Yes, a lot of people these days have end tidal monitors. That's great. I use both if I've got them. I like to cross my T's and dot my I's. But the color detector is ubiquitous. It's cheap. It's everywhere. And the other trick about the color detector, I know, sounds silly, but when I was a learner, I was like, oh, is it supposed to be purple? Is it supposed to be yellow? I couldn't remember when I was first learning. But in English, it's alphabetical order, so it goes purple to yellow. Okay, so when you're excited in that, crazy dramatic environment of a trauma airway, you're like, oh, yellow goes after P. Y goes after P. So you'll remember that now. You also want to check for bilateral breath sounds and that there's no sounds over the stomach, because that would indicate esophageal intubation. You'll want to follow it up with a chest x-ray, showing your ET tube just a few centimeters above the carina. And then again, this step is incredibly important. Secure your tube. Stabilize it above the lip and to the cheeks. There's adhesive holders, you can tie it on, but you need to secure that tube before you do anything else, because you can lose it very easily. Pharmacology, I'll talk about it a little bit. There's a very detailed chart in the chapter that you can refer to, but why do we do it? Well, this is not a fun procedure for people. It's agitating, it has a lot of stimuli involved in it, and so we want to sedate patients. We kind of want to have them not remember it, helps with the pain. You have your sedation that helps them relax. Your paralytics help your muscles fully relax, and it facilitates full relaxation so you can get that tube in like you need to. The best are short on, short off drugs, okay? So for induction, that's when you sedate the patient, and then there's paralysis. You want to give a little bit of time between induction and paralysis. It's cruel to paralyze somebody that knows they're getting paralyzed, so you want to sedate them a little bit first. Like I already talked about, it helps facilitate upper airway. Relaxation provides amnesia for the patient. And the most commonly used medication I see is either propofol or etomidate. Some people use ketamine, that's fine. Those are all short-acting, short on, short off. And then you want to give your paralytic after you've done a little bit of sedation. The caveats are very medication dependent, but overall you want short on, short off if you can. Succinylcholine is very commonly used, paralysis 5 to 7 minutes about. However, you don't want to use it when they're already hyperkalemic. So burn patients, end-stage renal disease patients, patients that have been down a long time and might have rhabdomyolysis, crush injuries, you want to be a little bit cautious about that. VEC and rocuronium have last much longer, but we'll talk about that a little bit in terms of about 30 minutes, maybe for rock-ish, 20, 30. The issue is, once you have done this to a patient, you are 100% responsible for breathing for them. They cannot breathe. If you don't breathe for them, they'll die. So you have to make sure you have a plan and you're ready to go before you give your medications. And if you can't get the tube in, but you can bag them, that means you're bagging for 30 minutes with rock and only 7 for sucks. So, you have to kind of take that into account. Just a couple miscellaneous notes on intubation. You can do nasotracheal intubation. That's often for elective ENT type surgeries. Sometimes, like even in the trauma world, when usually it's a blast injury to the face and oropharynx, you can't even see where the back of their mouth is, so nasotracheal intubation is often an option. Multiple attempts, you've got to minimize multiple attempts. Every single time you pass that tube down, you're causing more edema in the airway. You can make an easy airway into a hard one if you try 6 different times, okay? You can make a hard airway into a really, really difficult airway if you keep doing this. So you need to minimize your breaks, or minimize attempts, and you also need to minimize breaks in bagging. It's easy to get really honed in on what you're doing, so often somebody else in the room might be like, hey, let's bag them up for a little bit while they're, getting their new equipment around or grabbing the bougie or whatever. You really need to remember, that patient's not breathing, they're not ventilating, it's all you, so don't forget to bag. Cricoid pressure used to be used routinely when you push posteriorly on the cricoid cartilage. The thought was it would prevent aspiration because it occludes the esophagus. Recent studies have shown that's not really the case, but it is often used now to help, if you have a very anterior airway, to help push it posteriorly and allow the proceduralist to see the vocal cords a little bit better.
2 minutes.
Thank you. And another thing to keep in mind is the intracranial pressure. Is something you don't want to increase it, especially in these head injury patients or like neuro patients. So complications, bleeding, trauma, obstruction of the tube, clots, mucus, esophageal intubation I've already discussed. Main stem intubation generally goes down the right because of the more obtuse angle. If you see lung sounds on the right, none or diminished on the left, and possibly decreased saturations, pull it back a couple centimeters, you're probably right main stemmed. The tube can come out, and then the other worst case scenario is can't intubate, can't ventilate. Liberation from the vent is covered in a different talk, so I'm gonna just say quickly, when you extubate somebody or when you put a trach in and you wanna take it out, or when you're ready for extubation or decannulation of a trach, you wanna make sure that the indication for the need of the airway in the first place is resolved. Like I said, there's going to be a whole discussion about liberation from the vent, so I will leave that up to Tom later, but you want to make sure you are attempting this every day, and you want to be ready for your extubation procedure. Tracheostomy equipment, again, cuff, pilot balloon. We have the flanges here that you can either suture to the neck or tie with a collar, and your inner cannula. And then when you put it in, the important thing to note is that with the trach, you're bypassing the vocal cords, which is incredibly irritating to patients. So you've now bypassed that, decreased the amount of sedation the patient's on, and studies show decreased ventilator length, hospital length of stay, and ICU length of stay. Again, tracheostomy, decannulation happens when the indication for tracheostomy in the first place has resolved and the patient has use of their upper airway. This is my last slide, and this, as with many of the other slides and talks, could be a whole lecture unto itself. The difficult airway algorithm. American Society for Anesthesiology has developed a whole algorithm. It's also in the chapter, but the most important things to remember are, 1, you have to recognize it. If you don't recognize you might be getting into a danger zone, difficult airway, then you're not gonna think to call. You might not think of the plan A, B, and C, but you need to. That's why assessing that patient is so important, so you can recognize it, all right? You need to limit your attempts. We've already discussed the periglottic edema, but the other most important thing, do not be a hero. Do not. Call for help early. If it crosses your mind that you might need help, that call should be made. Do not be a hero. Bad things happen, okay? If at any point you can bag mask that patient and they're satting fine, great, do it. That means you're breathing for the patient. Put that LMA in, bag mask, until appropriate help can come, your paralytic wears off, your surgeon, your friendly neighborhood surgeon can come and do a trach for you. That's where I come in. And then you will have much more success if you follow these. The algorithm has a lot of nitty-gritty steps. These are the main things. Recognize, ask for help. So thank you very much.
Thank you very much, Dr. Richard, for your presentation. Our second presentation is titled Fundamental of Respiratory Care Pharmacology, and it's our honor to introduce again Professor Douglas Gardenhire, a chair and a clinical professor in the Department of Respiratory Therapy at Georgia State University. Professor is well-known, international recognized, and his contribution to respiratory therapy education, clinical practice, and professional development. Please join me in welcoming Dr. Douglas in this presentation.
Thank you all. Appreciate it. Thank you very much. Glad to be here and glad to be back on the stage for another go-around. So let's talk about drugs. Should be all of your favorite things to talk about. These are the objectives that we have to cover. You can read those in your textbook. So let's start with drug administration. Drug administration, these may be, again, simple concepts, sometimes, again, maybe boring concepts, but important to understand what it is that we're doing and understanding how the drug is working. So we look at the drug administration. There's a few sections there: the form, the route, and again, any type of formulations or the additives that are there. We spoke a little bit about the formulations earlier this morning, about how it is in terms of what we look at for aerosolized as respiratory therapists, all the different ones, jet nebs, DPIs, MDIs. But of course, there's lots of other ways in which formulations are made available. So we look at those and try to understand how those work. So we are most concerned with aerosol, inhalation, because of what it is that we do. And that is the one that we'll try to focus the most on as we move through. The pharmacokinetic phase, this is what we look at is how the drug moves through the body. To make sure that we understand that, it's right there in the word. So this, the drug movement, kinetic means movement. So we're going to look at how that drug, specifically, for example, a beta agonist, how it's going to be absorbed, distributed, metabolized, and ultimately eliminated. Sounds kind of boring, but understanding how that works makes it important so that we can continue to focus on our patient. If we look at the movement in terms of the metabolization part, this is, to me, very critical in what we discussed earlier this morning in the devices, is that metabolism, because of what's called the first pass effect. And this is usually done in the liver. That's where the majority of the metabolism of that drug occurs. It can occur in other parts, such as the bowels of the body. But what is important to understand is that how we're using these drugs over and over and over again, and how that works with what's called enzyme induction. Specifically, we talk about tolerance a lot, where individuals become tolerant to the agent. And this enzyme induction is important part of what the first pass mechanism is doing for the elimination, ultimately, as it's being metabolized. So this is, to me, the most important part of the kinetic phase in how we're utilizing these drugs and what that first pass effect is. Just for context, because we're going to see this here in a little bit, albuterol has a 50% first pass effect, meaning that 50% of the drug is going to get moved to the liver so that it's going to be neutralized. That's, again, just for some context as we make our way through. So you see that how it's making its way is going to be done through the portal vein. So we're going to have that drug move from the stomach as we're, again, inhaling and making sure that we remember how good of a respiratory therapist are we? Are you a good respiratory therapist? Is giving good instruction? Is the patient doing a good job at learning those instructions and being able to repeat those instructions over and over and over again in terms of demonstrating them to you? It's important so that we understand as we move into another concept known as LT ratio. So because of that, when you inhale the drug, if you're doing a poor job, the patient's doing a poor job, there's a lot of that medication that's going to the back of the throat. What do? As any human would do, when it goes to the back of the throat, you swallow. That drug makes its way into the stomach. So now you have some of the drug, in terms of moving within the body, the absorption and the distribution, is being absorbed and distributed in other ways, We have that through inhalation, but we also have that systemically through the gut. And that's where the first pass effect plays out in terms of understanding how effective we are in that LT ratio. Ultimately, pretty simple. We're going to eliminate all of our drugs within the kidney. So as we look at that movement of inhaled drugs specifically, this is important to understand how we're looking at them differently, even though, for the most part, any kind of drug that we can liquefy, we can inhale. But traditionally, we have those that are specific to inhalation, such as a bronchodilator or a nasal decongestant. Those are local, and the distribution, again, is hopefully making its way to the lung, although some could be systemic because of making its way to the gut. Systemic is ultimately what we're thinking about, such as IV or an IM. So now we're injecting that medication usually, or we're taking that medication by pill. So a lot of that drug systemically more is thinking about, if I have a headache, we're not going to inject the drug directly into the head. You're going to take a pill, and that drug is going to make its movement systemically throughout the body and then make its way back to your head so that you have relief. In what we deal with pulmonary disease and respiratory therapy, we're looking to have the topical or local effect, trying to reduce any systemic side effects, because that's where the side effects occur, is systemically. So now we're able to introduce the drug directly to the airway, treating exactly what we want, such as a bronchospasm. We don't need to take a pill and make its way systemically back to the lungs so that we can care for that patient who has a bronchospasm. We're going to directly give that. And in doing so, this is earlier this morning we were talking about our devices. So it's important for you, the respiratory therapist, trying to find the best device for your patient and making sure that patient understands how to use that device in the most effective manner, because it has to do with the LT ratio. And the LT ratio is the lung to total systemic ratio. And what we're looking to do is find out how much of that dose of that drug makes its way to the lung, how much of that drug makes its way to the gut. Depends how much is going each way. Is the device a really good device that, again, providing the particle size that's respirable that we want? And is the patient taking your instruction for that device and making sure that they're doing it appropriately? And are you, the respiratory therapist, teaching the patient correctly? So many different variables, which will make this number much, much different. But we'll take a look. So if we look at a dose of albuterol, and what I'll remember to tell you that I said earlier, albuterol has a 50% first pass effect. So here we look at the airway receiving approximately 30% in this example. In this example, we have 70% that's reaching to the stomach. Now, for us to be able to find out what that LT ratio is, we're just going to do some simple math. And so you can see there, we're going to take the lung dose, which again was on the top. So we have our numerator and then our denominator, which again is that which is our gastric absorption along with the lung dose. We're going to add those together. So you can see with albuterol being 50% first pass effect, if there's 70% of that drug coming to the stomach, half of it's going to go straight to the liver to be metabolized. We're leaving you 35% within the gut. So we take that in accordance, make our mathematical calculation, and we have an LT ratio of 0.46, which is not necessarily great, but not necessarily bad. It could be a lot worse, but it could be a lot better. And it all goes to you in the device selection. How effective is that device in nebulizing the medication? How effective are you? And how effective is the patient in doing the treatment? So lots of variability to decide which device is better. No device may not necessarily be better one over the other. It's going to be specific to the patient and how well they're going to be able to do that device. Those parts of that variability will increase that LT ratio. So now we move from moving in the movement or the kinetic part to the dynamic phase. Dynamic means action. So that's what we're looking at. What's the action of the drug? We're looking at the drug making its movement into the cell, into the receptor, so that we actually get what we're looking for. A beta-2 agonist makes its way to the cell, and we again have bronchodilation. That's what we're looking at from the beta-2 site. If we're looking at short-acting beta agonists, there's only two that's considered to be short and also may be termed rescue agents, and that's albuterol and levalbuterol. Those are our basic ones. If we look at ultra short-acting, which we'll talk about, ultra short-acting agents, those are going to be our epinephrine, racemic epinephrine. Those are not agents that we want to use for our pulmonary disease patients. There's other indications for those. This is what we're using. This is the best short-acting, about 4 to 6 hour bronchodilator to treat pulmonary disease. So when we look at these short-acting agents I mentioned, it's all about the receptor. You can see for albuterol and levalbuterol, those are specific to beta-2. But the epinephrine and racemic epinephrine have alpha properties along with beta-1 properties. So now we're looking at we're going to look at vasoconstriction. We're also looking at changes in heart rate. What's also important to take a look here is what I mentioned before, why epinephrine and racemic epinephrine are really considered very ultra short acting. You can look at that duration there, which is usually about 30 minutes to maybe up to 2 hours, where now we're getting albuterol, levalbuterol, somewhere in that 4 to 6. If we move to our long-acting beta agonists, those again are considered maintenance medications or may be referred to as controllers. We again commonly use those with asthma and COPD. So if we look at our long-acting agents, these are some of those along with some others that are there. But what we look at here for these is that they are longer acting, and we can see from 4 to 6 hours, that duration is moving to 12 to 24 hours. Now let's not confuse things here, because I think we confuse those a lot of the times when we're treating our patients and we're not giving them the right medication at the right time. So when we're looking at more acute phases, we're looking at more short acting. When we're looking at more maintenance, again, trying to maintain that disease, there's no active issues, we're looking at more longer acting agents. But what happens is we confuse those sometimes because we see some of these agents, and now we're seeing some of these agents being used for some of that more short acting piece, simply because they're working a lot faster. You can see the onset of these are just as quick, and the peak is very similar to that of the short acting. So sometimes we're seeing that movement within the literature, specifically within asthma, and how we might look to use things such as formoterol. As I mentioned, our alpha agents, so these are more alpha adrenergic agents that we're utilizing. We're not using them, I repeat, not using them to treat asthma, COPD. That's not what we're looking at for pulmonary disease. These are very specific for vasoconstricting. So what I want you to think about is stridor. That is a great use of this medication. So when we're thinking stridor, we're thinking things such as epiglottitis. We may have croup. Those are the things that we're looking at. Ultimately as well, because of its vasoconstricting properties, if you're involved with bronchoscopies, any kind of endoscopy, if there's, again, bleeding within the airway, we can directly make that applicable and look to reduce bleeding. But these are not, in no sense should we be using epinephrine and racemic epinephrine to treat our diseased patients within their lungs, any type of pulmonary disease. If we move to anticholinergics or antimuscarinic agents, these are where we're looking to treat COPD. They now are moving, if you take a look at the GINA guidelines, there's a lot of add-on for those individuals with asthma when they're not seeming to respond very appropriately to the beta agonists and some of the other agents that we would use for asthma. So these are now becoming part of what we're using anticholinergic agents in terms of asthma. Well known. Here, very hard to see, but this is a long list of our inhaled anticholinergic agents or antimuscarinics that you can take a look at in your textbook, some of them being in combination. So we have combinations that are, again, having 2 different agents and some that are now 3 agents as we move into speaking a little bit about our inhaled corticosteroids. But understanding when we have our longer term and shorter terms that we have both here. So both are represented, short and long antimuscarinic agents. noting that ipratropium bromide is the only short-acting. Everything else on the list is going to be long. So what's our indication for using these anticholinergic or antimuscarinic agents along with a combination of a beta-2 agonist? Combination is well known. I think sometimes we use that as what's considered the standard of care, but it probably should not be. What happens a lot in the United States is what I consider a history of use. So we think that someone receives albuterol for their asthma, and well, it's not going to hurt to be able to receive that Atrovent as well. We put them together, so we think everybody needs to get that, and that's not necessarily the case. We really need to evaluate these patients to find out, do they need both, or are they going to be able to be cared for with just one agent? We do know that the literature tells us that they're really good in terms of treating COPD. We know that from the GOLD guidelines. We're seeing where they might be used in asthma, and we know that they're used specifically in asthma exacerbations. So we see that very commonly there. But this is not necessarily an everyday occurrence that we want to use anticholinergic and beta-2 agonists, specifically in the hospital for acute care. So as we move on to corticosteroids, why are we using them? Ultimately, we're using them as a maintenance for asthma specifically, and a little bit for COPD. We may also see them intranasally for seasonal allergic and non-allergic rhinitis, so very common for anyone that may have that. But corticosteroids are a little funny in where and why we want to use them. We know in the literature for asthma, huge, number one, that is the drug that we should be really focusing on, because for years and years and years, decades, we've thought that it was only going to be the beta agonist, and that's what we always treated with. But we really know today, yes, that's important, but the corticosteroid is just important, if not more important. As we aerosolize those, of course, as we mentioned in the last talk earlier this morning, a spacer or a valve holding chamber can be used. Not necessarily as much for the deposition, because of these devices may be a little bit better, but ultimately what we're trying to do is reduce any type of candiditis that makes its way to the back of the throat and continues to grow. We know that we can try to help that by rinsing the patient's mouth out. Is important because the swallowing that's occurring, as we mentioned earlier, although usually these steroids have, what's again very good about them is they do have a very high first pass effect. They're available in a DPI and, of course, in nebulizer solution. So it doesn't matter what your patient is doing, how they might be, you have lots of opportunity to provide them a steroid in multiple devices. This is a list you can take a look at a little bit closer within your text, as there's many steroids that are standalone and in combination. What we worry most about with the use of steroids is side effects. And when we look at utilizing them through inhalation, those side effects are pretty rare. We don't really see those. It's only when we're using the higher and higher doses do we need to worry about that. Or are we using the systemic dose? So that would be the pill or the IV. Those are the ones that we take a look at. But what I want to point out most is the change in the white blood cell. So the white blood cell will change metabolically. And what happens specifically, I know that we have students in here, when we first think about looking at our labs and we see that someone has an increase in white blood cell count, the first thing a lot of individuals will think, oh, they've got some type of infection. That's not necessarily the case. You don't have to have an infection, because you could be taking steroids, which would then increase that white blood cell, specifically neutrophils. So the neutrophil count will go up, usually going high, making note that they have neutrophilia. That is one of the things that we should look at the most in any of the side effects. Because even though the HPA suppression might be important, we know that it's going to occur specifically in those higher doses. Anti-leukotrienes are another another agent type that we're using. These are utilized most often to reduce steroids or any type of asthma treatment that doesn't seem to respond to other type of agents. So these are what we call in the GINA guidelines as add-on. So these are add-on agents that we're looking to use. They have been found in literature to be useful for exercise, aspirin, and allergen-induced asthma. So those may be some things that we're going to utilize them for. Most specifically, the most common one on the market would be montelukast. That is the number one agent. It's been around the longest. It's been studied in all different patient ages, and it's even available for children as young as 6 months old. Another agent, monoclonal antibodies, which continues to grow rapidly. This again has been very effective in some of the treatments that we have, specifically with aero allergens and e-asthma. So these are just some of them. There are other newer agents that have made their way to the market. And you can see that list here, as we mentioned before, about our anti-asthma agents and our monoclonal antibodies. If we're looking at specific anti-infective agents that are available for inhalation, there's a list of those that we may use to, again, treat different entities. Phentermine is known to help prevent pneumocystis, pneumonia. That's pretty common. Although it's not the first line treatment, TMP SMX is number one. That is what is used for the treatment of PCP. Only if that is not working, or alternatively, we need to use that, phentermine, would we use that. Ribavirin is used, again, probably not as much as what it had been 30 years ago, but still being used today. We use that for the treatment of RSV. Probably not used as much within our pediatric population as it once was as well. We usually just look at the symptomology and we treat that accordingly. But again, there's several treatments, especially those in adults, that the ribavirin is still being used. You have some specialty use of tobramycin, aztreonam, and colistin that's used for Pseudomonas in CF patients, specifically for those individuals with CF. And you have Zanamivir, which is an inhaled agent used for flu virus. And the roflumilast, which is again used as a pill for COPD, and you can read more about that within the GOLD guidelines. So as I show you again here, you can take it to your list. Kind of gives you really the overview of what we just discussed. My favorite, N-acetylcysteine. Are you guys using that? I see some hands that go up. Remember, we heard that earlier this morning with the talk. We think that we're going to use that to treat mucus, and it treats mucus. It would be great for treating mucus. The problem is our patients don't have mucus; they have sputum, and it does not work very effectively for individuals that have sputum, such as our COPD patients. It, again, is clearly known. There's not enough evidence to support N-acetylcysteine. The only reason we should really be using it is we have a known fact for it of acetaminophen overdose. So if someone, again, comes to the emergency room, overdoses on Tylenol, that's what we would look to give. We understand how it works in terms of breaking disulfide bond. We do know that it's, again, very caustic to the lungs and can cause a bronchospasm. So if we were to give it, which you shouldn't, for pulmonary disease, you should, again, pair that with albuterol or levalbuterol. Remember, the only thing that is doing to you and to your patient is making the room sticky. As you, again, know how that nebulizes and it falls all over the room, and now you just walk in there like you're walking on tape within the room. So really should not be utilized. It is known to not be compatible with antibiotics, although there's a lot of emerging research from some of its antioxidant properties and what we know in terms of lung protection. There's a lot of information that has been coming out during the COVID era, where it has been very effective in COVID, even though in very small observational studies, nothing, again, large. But there are, again, a lot of very good antioxidant properties that N-acetylcysteine does have. We heard earlier about Dornase alpha, specifically for CF. Much different than N-acetylcysteine because it actually is an enzyme that directly cleaves DNA within the mucus or within the sputum itself. Difference between mucus and sputum, we again have that collection of that DNA within the mucus. Very little effects, and it is used for an approved neb, so making sure that you use that approved neb. Some other mucoactive agents, again, which was talked about, hypertonic saline. One of my favorites, mannitol. Mannitol has been used quite effectively as an agent to make sure that the patient would be able to cough. So that, again, is another outline of the overview of those, again, agents. In terms of diuretics, this is not something that we normally prescribe and or give on a regular basis as a respiratory therapist, but they are primary in treating our pulmonary disorders, specifically when we look at fluid overload. So we look at the use of our urine output, and again, looking is that increasing, so that we can monitor their blood pressure, their electrolytes, and provide the appropriate diuretic. Loop diuretics are the strongest of all of those agents, and the Lasix is the one that is probably most commonly used in that section. You can see there, this is a list of all the different types that you can read about in your textbook. And I thank you very much.
Thank you very much, Dr. Don.
Thank you, Dr. Gardenhire. So now we will move to the last talk in the session number 2. Allow me, and it's my pleasure to introduce Professor Ahmed Dammam. Professor Ahmed, he's a consultant in pulmonary and sleep medicine. He's an editor-in-chief in Nature and Science Journal of Sleep, and he served as the president of Asian Society for Respiratory of Sleep Medicine. He's a director of University Sleep Disorder Center at King Saud University Medical City. I believe he's one of the human capital that all of us Saudis we are proud of, and I'm happy that we are welcoming him today. Stage is yours, Prof. Ahmed.
Thank you. جزاكم الله خير. السلام عليكم ورحمة الله وبركاته. شكرا لكم. شكرا للinvitation. Before I start, I'll take from my time 30 to 60 seconds to talk about something in Arabic for the younger generation. To second what Professor Sullivan mentioned this morning. القصة لازم تحكى يعني حقيقة للشباب على يعني if you want to talk about a legend that you can follow his steps. أنا أعرف أستاذ حسن العريني أبو صالح من عام 1990 يعني 35 سنة وأكثر الآن. When I finished my college in medicine I joined King Faisal Specialist Hospital كمتدرب. فلما كنت أعمل في العناية المركزة كنت أتعلم من الأطباء، بس من اللي كنت أتعلم منه Respiratory care أستاذ حسن، فهو أستاذي to start with. وبعدين عملنا سنوات طويلة في جمعية الصدر السعودية STS، وبعدها الآن عملت أنا جزء بسيط معهم في الكورس. FRCS هو كورس إن شاء الله مستقبلا يكون مثل ACLS والATLS courses international courses. لما يكون الدينامو خلف هذا المجهود شخص مواطن عالم سعودي هو يحقق كل هذا. أنا أعرف الأمر لأن أنا بديت معهم في كتابة شابتر، أعرف الجهد اللي بذله الأستاذ حسن في هذا الموضوع كله. ولما تعمل أول دورتين من FRCS في السعودية اللي حيكون إن شاء الله كورس عالمي، مفروض كلنا كسعوديين نفخر بهذا الموضوع. فأنا أحب أشكر أبو صالح، وحقيقة يعني مثال للعمل ما عرفته أنا 15 سنة وهو ما شاء الله بنفس الديناميكية والعمل ما شاء الله قوة الله بالله، الله يحفظه إن شاء الله. طيب I'll talk inshallah, I'll make the talk inshallah clinical to you so will not be boring, and the objectives you can see it in the book. We'll try to cover different sleep disorder breathing from sleep apnea, central apnea and obesity hypoventilation briefly. The main problem we have is obstructive sleep apnea, and if we think of it simply in a simple way, it's narrowing of the upper airway. So when the upper airway get narrow, we start to get this problem with snoring. And if there is complete obstruction, we get obstructive sleep apnea. And if there is partial narrowing, then we have hypopnea. We'll talk about that. This has consequences because, sorry, I'll try to move my, so it doesn't. It results in desaturation, increase sympathetic activity, then increase the risk of cardiometabolic problems and cerebrovascular accident. Sleep apnea is a very common problem, more common than some disorders that we talk about. So it is a common problem and it gets more common as we grow older or gain weight. So it's like 7 to 8%. When we get older, can go up to 11% in men. Also, we know now it's getting more discovered in women. We thought it's a disease of men initially, but now we know that probably women have more complications than men. The symptoms of sleep apnea you are probably familiar with, but we'll just read them quickly. Snoring. Not all of them, but most of them will have snoring. Women may not have as much snoring. Choking during sleep, witnessed apnea by the bed partner, nocturia, mouth breathing with dry mouth, daytime sleepiness, excessive salivation, morning headache, excessive sweating at night during sleep, nocturnal heartburn, nocturnal palpitation. They may wake up with chest pain, and sleep that is not refreshing. We have questionnaires to screen for sleep apnea, developed mainly for patients going to surgery. The famous ones are Berlin questionnaire and the Stop Bang, but they are for screening only. They are not diagnostic. What we need, even by the American Academy of Sleep Medicine until now, the gold standard is polysomnography. Polysomnography, as you can see there, we do EEG, we monitor cardiopulmonary functions, EMG, and ECG. And with that, we diagnose the cases. When we do a sleep study, it's like 800 pages. It takes around 1 to 3 hours in scoring, depending on the experience of the scorer. What we have now, we are moving for sleep apnea to home sleep studies, what we call home sleep apnea testing or unattended home sleep studies. And this field is expanding rapidly. Maybe in the coming years, we'll have different data and different recommendations, especially with the wearables and artificial intelligence. Things are evolving quickly, but what we have now approved is what we call level 3 sleep studies. The polysomnography in the lab called level 1. Level 3, usually we have cardiopulmonary monitoring. And effort, we monitor effort. So we don't have EEG or EMG. It has advantages because patients sleep at home. We cut on the waiting list, but it has also limitations. We'll talk about it. The limitation that we don't have EEG, so we don't know the total sleep time. When we calculate the apnea-hypopnea index to see what's the AHI, we divide the number of apneas and hypopneas by total sleep time. When we don't have total sleep time, we divide it by time in bed. So if someone stays in bed for 8 hours but slept for 4 hours only, when we divide it by 8, the number of apneas and hypopnea will dilute the number, and we may miss some cases. Also, because we don't have EEG, we don't know if they are in REM sleep or not, because we have now a new phenotype of sleep apnea called REM predominant OSA. And because it is unattended, we may have signal failure. So these are limitations, but we handle it, and the results are successful, and it is endorsed by the American Academy of Sleep Medicine. The American Academy of Sleep Medicine looks into apneas into 3 types. And consider apnea if we stop breathing for 10 seconds or more for adults. This is for adults, not for children. They took 10 seconds, not based on science, because of the breathing rate, so they agreed on 10 seconds. So if we have no flow with effort, we call it obstructive. If we have no flow and no effort, we call it central. Mixed is in between. No flow, start as central, then change into obstructive. But in treatment, we consider it as obstructive sleep apnea. So apnea is clear. There is no flow, or more than 90% reduction in flow. Clear. There is no change. However, hypopnea scoring, they keep changing it because they don't reach a consensus yet. This slide is a bit outdated because the American Academy has updated this, probably will update in a new version of the book. But what they have, the recommended definition, is 30% reduction in flow. I'll show you the signal of flow as we move on. 10 seconds or more of reduction, followed by 3% or more decrease in oxygen saturation compared to the saturation before, or arousal. I'll show you the arousal. So this is the recommended one. Second one, they called it before accepted, now they call it optional in the new scoring criteria. 30% again drop in nasal flow, followed by 10 seconds or more, of 10 seconds or more, followed by 4% desaturation, no arousal here. So this is optional. When we can discuss in the workshop or sometime later why is this confusion. This is an example of a 2 minutes window. We call it epoch. We can see up the eye movement, then the black, the EEG, the chin EMG, the cannula, which is the nasal flow, which is the mouth flow, thoracic and abdominal wall movement. You see there is no flow, so there is apnea more than 10 seconds, and there is paradoxical breathing. Patient is trying to breathe, but they cannot. Then after that, they will open the mouth, they take a big snort, and start breathing, then go into another apnea, and they are followed by arousals, as you can see. And below, you can see the desaturation that follows. This is a hypopnea. Apnea was clear, no flow. Here is hypopnea. We have more than 30% reduction in flow. Again, still there is effort, so there is obstructive hypopnea, followed by arousal and desaturation. This is what we call REM predominant OSA. We call this one a histogram. If you see the upper part, these are the sleep stages. We have stage N1, N2, N3, and REM and wake. The red color is the REM sleep. This patient, when he goes to sleep, or when she goes to sleep, they get obstructive events only, the red colors and the pinkish color here, the purple color, these are the obstructive events, happen only in REM sleep, associated with significant desaturation. You can see the black line there and arousal. When they go to the other stages, they have no apneas. So this is what we call REM predominant. We see it mainly in young women, young adults in general, and children. Patients usually are less symptomatic. We thought initially probably it is a benign disorder, but now big observational studies from big cohort now of data showing that probably it is associated more with cardiometabolic problems. How do we grade severity of OSA? You know probably all of you the apnea-hypopnea index. And it is graded based on the number of apneas and hypopneas per hour of sleep. So we count the number of apneas and hypopneas, total sleep time, then we divide them. So less than 5 for adults is normal, 5 to 14 is mild, 15 to 30 is moderate, more than 30 is severe. Is it a good scoring criteria that correlate with complications and comorbidity? No. Are we still using it? Yes. So you have to know it, but it's not the best. What's best now coming is the time spent with saturation less than 90, the hypoxic burden, and other parameters that are evolving now, especially using AI of big data. We can look into the associations and know what are the associations with cardiometabolic problems. So how do we treat patients with obstructive sleep apnea? Of course, always we have to educate the patient, especially if we will give them like a device like CPAP. So we have to educate them. We have to advise them about like losing weight. If they sleep like in the supine position and they have supine apnea, we teach them about that. But the mainstay still is the positive airway pressure therapy. This is the mainstay still by all like academic and scientific societies for the treatment. And then we have the other one, which is the non-positive airway pressure therapy. And this, again, evolving quickly, but still, positive airway pressure is the mainstay of therapy. When we titrate positive airway pressure during the study, there are criteria that we have to follow. I will not discuss it here now. Probably we'll discuss in the workshop if you like, or you can read it in the book. You can put it like in a table in front of you in the sleep center to see the criteria. But our aim is to have apnea-hypopnea index less than 5 or 5, saturation more than 88%, and respiratory arousal index less than 5. And we would like the patient to go into REM because they get higher apneas and longer duration apneas in REM and supine position to make sure that the chosen pressure eliminate the apneas in that. If you look to this, again, histogram, you are familiar with it now. The left side is the diagnostic part, right side is the therapeutic part. I don't know if the laser is working or not. Oh, sorry. Okay. Okay. Laser. No problem. So you see here the patient is getting these obstructive hypopneas. And then we started the patient on CPAP. When we started CPAP, what happened? We started to get these blue lines. These are central apneas. This is what we call treatment emergent central sleep apnea that appears sometimes if we start CPAP or by level, positive airway pressure. What's the problem here, do you think, in this case? The problem is that we went titrating the pressure rapidly. So rapid titration. The American Academy of Sleep Medicine, they have guidelines for titration, how fast you go. If you see this, then you know that you have like rapid titration. Try to go slow with the titration. Another cause of this treatment emergent central sleep apnea is air leak. I'll talk about it more as we move on. Okay. Now, if we are going to do portable sleep study at home, how are we going to titrate CPAP? Should we do the diagnostic at home, then bring them to the lab to do the CPAP titration? That's not practical. We'll go back to the long waiting list. No, now we can do auto CPAP titration. Probably you have lectures on auto CPAP algorithm, how it works. So if you diagnose them at home, then you give them the device for like 1 to 3 nights. There is no agreement on the duration that you give the patient. With auto CPAP, then you take the device and you assess what's the time they spend the CPAP pressure more than 90% of their sleep with no apneas, and you give them that as a conventional, if you like to give them conventional CPAP. So is it good or not? Yes, the evidence is very good. They have the same acceptance and they have the same or even better adherence to CPAP compared to the titration that's done in the hospital. So this is a very important point you have to keep in mind. When we start CPAP, like we do it in the hospital, because they will go home or for the titration, the interface is very important. Because if you choose a wrong interface, even if you get the best machine, they will not accept it. Like if you are driving the best car, but the seat is not comfortable. So you don't enjoy the car because the seat is not comfortable. So the interface is the most important. We have nasal mask, oronasal mask, nasal pillows, full oral mask, and total face mask. We'll talk about them in the workshop tomorrow. The Starling resistor, this is physics, but I think it's important to understand when we talk about sleep apnea and how positive airway pressure works. Starling resistor is a concept in physics, probably you have studied that before, which like basically, if you have to have a flow, you have upstream, and then you have a segment which is collapsible, and then you have a downstream. So you have to have a gradient across this, pressure higher at the upstream, then lower at the downstream to keep the flow and to keep this collapsible segment, which is the upper airway, the pharynx, open. When we breathe through our mouth, we break this principle. That's why when the patient with snoring, they open their mouth and they start breathing, they are more prone to have apneas. Then when we give them CPAP, we don't just give them CPAP and let them go. We follow them up. Either they come to the hospital or now we can do it remotely. Remotely, we can download the data. The problem remotely in Saudi Arabia is that all the servers of the companies of CPAP machines are outside the country. And the Saudi regulation does not allow sharing data outside the country of patients. So I hope that one day we'll have the servers here in Saudi Arabia so we can use it. That's why I don't use the telemonitoring, because it's against the law. Some colleagues, they use it. Okay, so from the data, we can get a lot of information. I will not go into this, probably you can see it, and this slide is in your book, but we can look into and see the CPAP efficacy. We can see the residual apneas and hypopneas. Even we can look if it is obstructive or central. They call it open airway. And we can see the adherence, how many hours they are using. We can check for leak, if it is within the accepted range or not. We can even look to the flow signals. You can see the flow signals there and see what kind of breathing the patient has. A lot of information. Now we'll move to the central sleep apnea. If you go to the classification, international classification of sleep disorders, there is a long list. I think what you need to know is the chain-stroke breathing. We'll talk about it. The treatment emergent central sleep apnea, I talk about it, and I'll talk about it again. Then we have other disorders that are related to like prematurity or some congenital diseases, medical problems, or high altitude. We'll not cover these because these are uncommon to see. So chain-stroke breathing, this is a peculiar type of breathing. If you look at it, the patient, they will start slow breathing, then increase the tidal volume, and then slow down, then go into apnea. Then start again. And usually they have the arousal at the peak of the effort. We see it most commonly in patients with left heart failure and low ejection fraction. Not all patients with low ejection fraction will have that. a group of them. And those who have chain stroke breathing, probably they have higher mortality than comparable patients with the same ejection fraction but no chain stroke breathing. So this is just a simple MCQ. The sleep fragment in the figure below is a 5 minutes from a patient with congestive heart failure and low ejection fraction. What is the likely diagnosis? C, chain stroke breathing. And if you see here, this is a patient on ASV. When the patient was not breathing, the machine started kicking to give them the breathing. You can get this information also from the devices. So like this, another example of chain stroke breathing. It's a peculiar pattern. The management of chain stroke breathing, what we have in the book now is the older recommendation. The American Academy now has updated this in 2025. So CPAP, this is in the older recommendation, improves oxygen saturation and ejection fraction, but has shown no improvement in survival. Still, again, this is not, again, survival is in question whether it improves survival or not. But what the older recommendations say, that we should not use adaptive servo-ventilation. And adaptive servo-ventilation is a special algorithm. It's a sort of bi-level that will assess breath by breath, and if the patient goes into apnea, it will kick in immediately. Probably you will take that in the advanced algorithm of non-invasive ventilation. So there is a study called SERV-HF, and this SERV-HF showed that patients who were on adaptive servo-ventilation and ejection fraction less than 45 had higher mortality. Based on that, the American Academy of Sleep Medicine said, okay, if the ejection fraction is less than 45%, don't use adaptive servo-ventilation. And that study, the SERV-HF, was done by a peculiar model, a company. Then after that came, so this was a standard recommendation by the American Academy that they have changed. Then another study came called Advent-HF, that they use a different model. And they do not find this increased mortality with using ASV in patients with low ejection fraction. So the new recommendation is conditional, that you can use in all, but don't use that peculiar device, which is out of the market now. Also, the new recommendation now talk about oxygen, that also it can help, talk about acetazolamide can help, and CPAP also can help, but all these recommendations are conditional, means not strong recommendation, conditional consensus by the experts. Okay, treatment emergent central sleep apnea, you remember we talked about this. I showed you the example. So if you see treatment emergent central sleep apnea when you are doing the sleep study, two main things you have to think of. Is there a leak, or am I over-titrating the pressure quickly? So if there is a leak, you see it in the device, please try to fix that. If you think that you are over-titrating, try to slow down and go back. Most of the patient, if you send them home on the device, 90%, this treatment emergent central sleep apnea will disappear. So you send them home, you follow them regularly, check if this central apnea disappear or not. If there is leak, try to treat it. Most of them, it will disappear. If not, if you need to do another study, do it for difficult cases. If it persists, then you can go for adaptive servo-ventilation. Last part is the obesity hypoventilation. It's a clinical diagnosis. It's not uncommon. It's frequently seen, but underdiagnosed. And we see it more in women. We were the first to report that it's a disease of women. Now, globally, people are saying, yeah, this is a disease of women. Unfortunately, most of them are diagnosed as COPD, though they have never smoked. So the clinical diagnosis is awake, high BCO2 more than 45, obesity, hypoventilation, not explained by other disorders like pulmonary, neurological, muscular, or congenital disorders. 90% of them, they will have coexisting obstructive sleep apnea. So OHS plus OSA. And some of them may present for the first time with acute hypercapnic respiratory failure. So they may be missed, and the first time they come to the emergency room with hypercapnic respiratory failure, unfortunately, most of them are diagnosed as COPD. They give them inhaler, and they never smoked. These are obese, mostly ladies, but you can see it in men, and there is no pulmonary disease. Okay, this is again a zoomed window epoch of a patient with obesity hypoventilation. Probably you are familiar now, ECG, chin, EMG, flow. Patient is breathing, but with that you see saturation is low, and transcutaneous and end-tidal CO2 are high. So though the patient is breathing, they are hypoventilating and they have sustained hypoxemia. So in obstructive sleep apnea, we see intermittent hypoxemia, while here we see sustained hypoxemia. Okay, how do we manage them? We have to keep in mind that they have multiple comorbidities. These patients, by the time they present to us, they already have like diabetes, hypertension, left ventricular diastolic dysfunction, hyperlipidemia, hypothyroidism. So they have multiple problems usually. So how we treat them? We treat them with CPAP, still like sleep apnea. Most of them, they will do well with CPAP. If they have moderate to high HI, meaning HI 15 or more, the recommendation is to use CPAP for them because CPAP is cheaper, easier to titrate. So CPAP is the first treatment. What are the recommendations to use bi-level? Very important. When should we consider bi-level? We consider bi-level if the patient has obesity hypoventilation with mild or no OSA. So they hypoventilate without OSA. Or if the patient has persistent hypercapnia, you give them CPAP, they continue to have high hypercapnia, or if they could not tolerate CPAP. And the last one, when they present acutely to the emergency room or ICU with acute hypercapnic respiratory failure, then we give them bi-level. So is it clear now when we use CPAP and when we use bi-level? Okay. So I will conclude here. These are the key concepts. So apnea can be obstructive, central, or mixed. BSG, which is level 1 sleep study, is still the gold standard diagnostic for sleep-related breathing disorders. It is the gold standard and the only for OHS, for central sleep apnea. We do home sleep study. When do we do home sleep study? We do it for patients with high likelihood of obstructive sleep apnea and no comorbidities. So if we get a patient who has heart failure and we suspect obstructive sleep apnea, we don't do for them home sleep study because these patients are prone to have central sleep apnea. If we get a patient that we suspect they have obesity hypoventilation, we don't do for them home sleep study. We do for them a lab sleep study. Patient with central sleep apnea, chine stalk breathing, again, the recommendation still is to do a lab, in hospital or a lab sleep study. So home sleep study, we do it mainly for patient with high likelihood of OSA and no comorbidity. Okay, so we talk about non-invasive ventilation treatment. We talk about the importance of interface. We talked also about the tracking. When you treat the patient, don't send them home and forget about them. Bring them and track their device. And the last recommendation, this has changed. Okay, thank you.
Thank you, Dr. Dammam, for yet another elegant talk. Now, I want to let you know that there will be lunch served at the end of the hallway, but we will start exactly 1 o'clock because we have live streaming, and we need to start on schedule and end at time. So please be back. 1 o'clock, we will start. That's number one. Number two, we made a mistake with the sheet that says visitors or booth visitor, the one with the stamp. We forgot the most important, which is the name of the person. So you need to add your name and mobile on the top of the sheet before you turn it in. It is not for the best booth or anything. It's for you that you visited, then you can be eligible for the award. Thank you very much. Thank you, chairs.
2024.
Check. Oh, wow. Ooh, here we go. Yeah.
بيري سكوت.
ترى انا ماخذ لهم سكرين شوت.
Peace be upon you. And now we're starting the session 3. First of all, I would like to thank Professor Hassan Al-Areini and all the organizing committee for inviting me to sharing with him in this conference and for their excellent arrangement. We call Professor Brad Scott is Professor and Director Programs of Respiratory Care and Department of Cardiopulmonary Science, Division of Respiratory Care, Rush University, and has talked about the acid-base balance, blood gas analysis, and oxygen. Welcome.
All right, thank you. I think Mr. Hassan Al-Areini gave me this talk because it's right after lunch and everybody's going to be asleep, so this is my job to try to keep you awake for the next 30 minutes. It is my honor to be here. This is my third time in the kingdom, my third time in Saudi Arabia, my first time in Dammam, and so I really enjoy being back. So thanks for inviting me. So I'm not going to read the objectives. I'm going to, like Dana Evans, there's a lot of objectives, so I'm not going to read those to you. You can read those in the textbook. But I want to start off with, I realize some people are just filing back in, but do we have any students in the audience right now? Who are my students? Back there? Okay, great. There's probably somewhere between 6 and 10 of my former students from Chicago. Are you here? Anybody in here, my former students? No, they didn't want to hear me again. I don't blame them. So I can be boring sometimes. So what I wanted to say is, you can see as the slide says, is that the interpretation of ABGs is a major tool that we have. It's something that we do every day as respiratory therapists. And for the students in the room, if this seems difficult, it's because that it is. It's not so simple. It takes a lot of practice, and you'll get better with it over time. But it really is a tool that we can use to make an initial assessment of a patient or to monitor as we go. And so, we also can use other, these tools and blood gases and some non-invasive measures we'll talk about in the afternoon to measure people's oxygenation and tissue oxygenation. Okay, so let's start here. First of all, I'd like to say that I thought it was amazing when I got here that a lot of these calculations were carved into the wall out here. That's really cool. As somebody who really enjoys pulmonary physiology, that was neat to see. So let's start here. And for those of you that are intimidated by this type of thing, when I look at something like PiO2, which equals FiO2 times barometric pressure, let's break that down for just a second. So let's spend a little bit of time with what this means. So we have to think about we breathe atmospheric air, which is what we call around 21%. That 21% is always the percentage of the barometric pressure that you're breathing, but the amount of oxygen that you breathe does change with altitude, right? So the FiO2 stays the same, but the barometric pressure changes. So when we think about the calculations here with PiO2, or the inspired partial pressure of oxygen, the constituents of that are FiO2 times barometric pressure, where FiO2, again, stays pretty consistent across the board. It's 21%. And the barometric pressure changes as we, climb a tall mountain or up in a plane. And so we have to convert in our mind that, yes, we are breathing 21% oxygen, but it's 21% of the barometric pressure, and the barometric pressure is in millimeters of mercury. So 21% of that then becomes 159. So your partial pressure of oxygen here, you can see, is this, what looks real busy, 0.2094. So let's just call that 21%. 21% times 760, that's 159 millimeters of mercury. So again, to the RT students in the room, you've been learning already that your normal PaO2 values are 80 to 100, for example, right? Where does that number come from? It comes from here, right? Again, your barometric pressure, 760, multiply that by 0.21, and you get 159. I'll show you in a minute. We are actually going to subtract out water vapor pressure. It gives you a little bit of a lower number, but it describes where that number comes from. It starts to help figure out where these numbers come from on the blood gas. So this is an important thing to remember as we go through the next few slides. Now, every RT student at one point in time has had to look at this calculation, the P big AO2 alveolar air equation, and it becomes a little stressful. You're like, what is it that I'm looking at? Right? So let's break it down a little bit. So I'm looking at this in front of me. So if I'm looking down, I'm not trying to be rude. It's hard to see. And we know that a normal P big AO2, remember the capital A means alveolar oxygen. Now we're not talking arterial, we're saying alveolar. Arterial oxygen and alveolar oxygen are different. Sometimes they're close, but they're not the same. So we see here is what creates our P big AO2. So it's barometric pressure. So we're looking here, my little light doesn't work well, but I'm looking right up here, P big AO2 equals barometric pressure, and we're going to subtract out water vapor pressure because it's not involved in gas exchange. We're going to multiply that by our FiO2. So this whole side of this calculation, before we get over here to this minus sign, is the PiO2 equation, right? So you are barometric pressure minus FiO2, that's what you're breathing in, and then you subtract out the CO2 that's going to be found inside of the alveoli. I'm going to take you back a little bit to Dalton's law of partial pressures. I won't go into that in any detail, but you're going to find CO2 down in the alveoli, and then you have the respiratory quotient. That's going to determine what our P big AO2 is, which is further going to drive our P little AO2. All right? And you can see, and this is in the text, you know, the water vapor is a constant. So basically we say 760 minus 47 is 713 times 0.21. That gives us our PiO2, which can be plugged into the alveolar air equation. And so let me go back just for a second to the students in the room, and some of you that maybe are new to your career. I used to think it was okay for me to ignore these calculations. I'm not good at math. I'll just tell you guys all the truth. I have lots of college degrees. I have 4 of them. None of them are in mathematics. So I used to get a little bit intimidated by some of these calculations because I didn't understand them. But the goal of today is to try to break down what each part means for us to make some sense of this. Again, right? So the P big AO2 equation, so we can not be so scared of it. What's in the alveoli is what we breathe in minus what we find in the alveoli. Remember that Dalton's law of partial pressures is applied here. Okay? All right. Now we go from the P big AO2, and the slide now is looking at P little AO2. How did I go from a P big AO2 of 99 or 100 down to a normal value of a P little AO2 of 80 to 100? How did it drop? Where does it go? Right? Remember that the lungs have their own blood supply that will actually shunt back into the normal circulation in the left heart. So your PaO2, your P little AO2 that we see on our blood gases is a product of this. It's what we're breathing in, it's the altitude we're at, it's the FiO2 that we're breathing, and it's the amount of shunt that we see down in the lung. All right? So I'll also want to point out that, I was just having a conversation with my friend Tom about, we're both in our mid-40s now, or later end of the 40s. That means, Tom, that our PaO2 is dropping naturally. Right? Our oxygen level is dropping naturally. It's what it's going to do across the board. So we have to start to think that, yes, while I did say that the PaO2 is normally 80 to 100, that does naturally drop with age. And then everybody has seen the oxygen hemoglobin dissociation curve. But really, at the end of the day, what we want to do here is realize that there's a relationship between PaO2 and hemoglobin oxygen saturation, and which is determined by the oxygen dissociation curve, right? As PO2 is higher, we know we're more saturated, and we get up to the steeper part of the curve, the flat part of the curve as the PO2 goes up. But I want to make sure that we're clear. Again, I'm going to focus on the students just for a minute. SaO2, when we're talking about this today, is not the same as SpO2. SaO2 is from the blood gas analysis. SpO2 is on a non-invasive monitor. So what this slide can say is sometimes when we have carbon monoxide poisoning, more accurately, what we really should say is SpO2 can be artificially high because of the high affinity for carbon monoxide and hemoglobin. All right, so out on the wall here, I would love this because, again, I think I have one of my students that now came back. Rana, you're here. I see you. Now, I'm going to ask you real quick to tell everybody the O2 content equation from the top of your... I'm just kidding. I'm not going to ask you to do that. That would be unfair. But if you've been my student, you know there's something I pound in my students' head all the time, and it's oxygen content equation. I do because it has so much to do with oxygen delivery, which is a big part of our job. This is not on the slide. Remember, O2 delivery is content times output, right? And then content is what? 1.34 times, SaO2 times hemoglobin, yes, right? 1.34 times saturation times hemoglobin plus the other side of the equation. 0.003, thank you, times PaO2, good. Add it all together, we get our O2 content. Awesome. And what that really means, and let's break it down. What does it mean? It means on one side of the equation, you can see where so much oxygen is being carried. So much oxygen is being carried on the hemoglobin. So that means that we have to have hemoglobin, right? If we want to have oxygen delivered, we have to have the trucks. You know, I can say this, that in the United States, everybody buys everything on Amazon. I don't know if they do that in Saudi Arabia, but in the United States, Amazon has replaced everything. I do it too. They deliver like pizza now to our houses. It's great. But I always say that the hemoglobin are like Amazon trucks. Amazon trucks are not useful unless they have something in them. And you can't deliver a lot unless you have a lot of them. So what you need to have a good oxygen content or a good delivery system on Amazon, you got to have the trucks, you got to fill the trucks up, and you got to move them out, right? That's how that works. So that's the O2 content equation. And if you forget it, for those of you that are students here, you're walking by it every day. It's out there on the wall. Very important thing, okay? So we know that we can have low oxygen levels. We can have low oxygen levels when we have low hemoglobin. So you may not be delivering oxygen to the body just because you don't have enough hemoglobin, right? We have a trauma surgeon in the room. She knows sometimes she's saying, put the hemoglobin back, right? The patient's bled out, we got to put the trucks back. We got to give it back, right? And we know that we can cause decreases in O2 content can be anywhere here between the low SaO2, low PaO2, but the reality is these two are the biggest. Remember that the PaO2 is times 0.003, not a whole lot of that content, right? So think about that equation. All right, so we know we have that difference. I kind of got ahead of myself. I've looked at these slides so many times, I'm like already thinking about what I'm going to say. But we know that we have a normal gradient between the alveoli and the arterial circulation. That's normal. It's okay to have between 5 and 15 or so when we're on room air. When the gradient starts to get larger, we're having a problem now. And it's complicated. There's a lot of reasons we do that. But we know that what we should have is some degree of change between the alveoli and the arterial side. But if it's too big, it implies an issue with diffusion or other things. So again, maybe right now we're after lunch, you're like, really, we're going to do physiology after lunch? I mean, it's kind of boring after lunch, I get that. But I challenge all of you that were like me in the beginning of my career, hoping I could forget all of these equations, go back and remember them, because it will matter at some point. You will know, you will be a better RT if you get to understand the physiology behind some of these equations. All right, also in my classroom, if you tell me what the PaO2 is, I will ask you this question: on what? If you say Brady or Dr. Scott, whatever, the PaO2 is 113, I will say fine. On what? If you say the PaO2 is 94, okay. On what? Right? If I say room air, 94, I'm like, okay, good. If I say a PaO2 is 94 on 100%, that's not good. That's not good at all, right? So it always matters. So if you think about a PF ratio, how do you use that at the bedside? It really helps you to determine how sick your patient is, right? So we have these things, a PF ratio of less than 300 is consistent with ARDS, mild, moderate to severe, and all those things. But I challenge you from this point on, if you gave a PaO2, follow it immediately. On what? That helps everybody in the room understand where we're at and how the patient is, how oxygenation is occurring in a patient based on the situation that they're actually in. I'm going to speed up a little bit. I got way too excited about O2 content equations, so I'm going to speed up just a little bit. Some of this stuff's in your text. I want to get to the blood gas analysis part because I know that can be intimidating for sometimes. Got some equations that are in the textbook that are important here. Really, just trying to understand the difference, how the relationship between oxygen consumption and things like cardiac output, and getting to understand really the differences between oxygen content on the arterial side and oxygen content on the venous side if you do a mixed venous sample. Remember, the mixed venous sample, the best place you could get a mixed venous sample would be like from a pulmonary artery catheter. We don't have a lot of. But it is still a good idea to understand what the difference is between A and V in terms of O2 content, which will give you a lot of information about oxygen extraction or cardiac output. Very important. Okay, I was just telling my friend Dr. Sullivan that the most humbling thing I've ever done in my life, I was 10 years into my career and I was asked to write a textbook chapter on blood gases. I thought that would be easy. I had been an RT for 10 years. I've interpreted thousands of blood gases, and I will assure you that was not an easy task. So for those, again, that are new in the room, new to the profession, I was an RT for 10 years and wrote a book chapter on blood gases, and it was tough. Very challenging. I learned a lot, and I didn't want to admit it to anybody, so I just did. Don't send that back to my students in the U.S. All right, so normal range. We know blood gases, normal range 735 to 745. If we're less than 735, we have some degree of acidemia. And I'm using that terminology, acidemia, which means that's blood, the blood level of acid base. Sometimes it's acidosis, which is a bit more global word, but acidemia would imply blood. And then alkalemia is when we are greater than 7.45. Again, so we know that we have a PaCO2. So a PaCO2 is the gold standard for understanding ventilation. Like if you really want to know somebody's ventilation status, yes, we have end-tidal CO2, transcutaneous things, but the real gold standard is your PaCO2. Normal there, again, on the arterial side is 35 to 45. And if we have a CO2 that's greater than 45, that would generally mean that we have some degree of hypoventilation, which means that you are producing CO2 faster than which is being excreted, right? Or sometimes we call this hypercapnia or hypercarbia when we're talking about the numbers themselves. This can lead to a respiratory acidosis. Simplified, think about the CO2 of being the respiratory acid. And if you really want to get into the nuts and bolts of it, we could say carbonic acid and the biochemistry here. But the CO2 being the acid going up, it's going to drive your pH to be more acidic. When we are hyperventilating by its definition doesn't mean breathing fast. It means, because that's tachypnea, that's two different words. Hyperventilation would imply that we're getting rid of CO2 faster in which it's being produced, which could drive our pH up, make us more alkalemic. All right? The bicarbonate is the metabolic component of the acid-base balance. And if we know that bicarb, generally, if it's above 26, this can lead to an alkalosis, but on the metabolic side. And if it's lower than 22 or so, generally we call that an acidosis on the metabolic side. So that means that for those, again, that are struggling with learning how to interpret blood gases, we can take our numbers and try to see which or both values are pushing the pH in one way, and it tells us why. Is our pH low because of our metabolic side, or is it low because of the respiratory side? That's important because that's how we can communicate with our physicians about how to fix the issue. I'm not going to spend a whole lot of time with this because I want to get to the actual interpretation piece because I really want to walk through that with everybody, especially those that are kind of new. But you can see that in the book, there's a good description of buffers. That's a little bit of a hard concept, the buffering systems and total CO2 content, which includes bicarb and dissolved CO2. CO2 is transported in a little bit of a more complex way than oxygen even is. And so you can see that in the text. Anion gap is important. So this is something that I felt like I was ignoring a little bit earlier in my career because I think the docs will fix that. If we have a metabolic acidosis, I'm like, Dr. Sullivan, that's on you. I'll be over here if you need me. But it has helped me understand over the years how I can help physicians with a plan. When we can point some things out. Is it because we've lost something or is it because we've gained acids? And that will help us determine how to actually correct some of the situations that we're in. Okay, so I'm going to tell you that if you pick up different textbooks, there's going to be different ways of interpreting blood gases. So my recommendation, if I'm being honest with you, is find the one that works for you the best. So what I like to do is I like to look at a pH. As soon as I get the pH, first thing I do is classify it. I classify it immediately as it's an acidemia, there's an alkalemia, and we've determined we're one way or the other. And then I look at then what I generally do myself is I look at the CO2 and I ask this question, is the CO2 responsible for this? Is the CO2 responsible for this blood gas? And if the answer is no, then I go, okay, is the bicarb responsible? Generally, if it's off, one of the two are responsible. And if it is, then I've determined if it is because of the metabolic side, then I can determine that it's a metabolic issue. It's a metabolic acidosis. It's a metabolic alkalosis. And then I have to go figure out whether or not compensation has occurred. All right? So again here, determine if we have a respiratory component by looking at the CO2. That's 2 and 3 repeated. 4 is determine whether or not there's compensation, and there are different approaches to doing this. Okay? In terms of your VBGs, I will tell you that in the United States at least, VBGs are very commonly used, particularly in the emergency department environment where somebody doesn't have a respiratory compromise. So classic patient in an ICU, in an emergency department you would see in the US at least would be like diabetic ketoacidosis. Our ER docs utilize a lot of venous blood gases to make a determination of the acid-base balance of our patients. So VBGs do have value, right? They just don't have as much value if you really need to know the oxygenation status of the patient, right? I would argue that if you really want to know the oxygenation status of the patient, and you even want to consider it on the inside of an O2 content equation, you need an ABG. All right? So again, when we're evaluating the oxygenation status, and again, sometimes it's frustrating. It's like, what is the actual values that matter? So, some people argue that less than 50 millimeters of mercury is severe hypoxemia, less than 40 is severe. I would say I don't want mine to be anywhere below 50 at all, right? So I think it's all severe. But when we're looking at oxygenation, we got to ask the question, is it appropriate for their age? Keep in mind that PO2 does drop naturally over time. Does the PaO2 correspond to the FiO2? Always keep that in mind, right? Like, for example, if you draw a blood gas, think about this for a second. If you draw a blood gas, and I can do this calculation, it'll take way too much time, I'm not going to. But if you drew a blood gas on a patient on room air, and the PaO2 come back at 150, it cannot mathematically be like that. The maximum value you were breathing in was 159. You can't have a PaO2 of 150 on room air. It's mathematically impossible. That means there's something wrong with the machine, right? So that's important. And if I just confused you there, meet me at the next coffee break. I'll write that one out for you, all right? So we're going to, again, you evaluate the oxygenation status, look at the O2 content. I challenge you as RTs as well to consider the oxygen content. Yes, hemoglobin's important. No, I do not write an order to infuse blood, but I can go tell Dr. Sullivan she might need to consider it. She may tell me there's a reason why not. That's her call. But I can say the hemoglobin just dropped from 11 to 7. Something's wrong. I don't know what's wrong. I'm not a surgeon. But maybe I'm the first person that picks it up. And I am concerned as an RT about tissue oxygenation. And we know we have to have hemoglobin. It's important, right? Now, how that's managed, that's not us. But it's at least we can alert physicians to those values if we see them change, because we're worried about tissue oxygenation. At the end of the day, our job is to keep oxygen going to the body. Right? We have a very complicated profession to get it there, but our job is to get oxygen to the body. So when hemoglobin goes, that's our trucks. That's how it gets there. It's the same reason we care about cardiac output. We care about cardiac output too. I may not give an inotrope, but I really do care about blood flow, right? Because that's how tissues get oxygen to them. All right? All right, again, I don't know how to go back. So again, we can review the SaO2, looking at the SaO2, make sure that the saturation's there. SaO2, if it's monitored, if we have co-oximetry, this is how we can see. Sometimes maybe the SaO2 differs than the SpO2 because of the presence of carbon monoxide, right? Which gives us some degree of oxygenation understanding. So if you got a pH that's normal, we can move on, but I want to move on to the most important part here is going, because I don't want to run too far. I just don't want to run out of time. I got 4 minutes. So, again, if your PaCO2, if you're looking at a blood gas and your CO2 is normal, this could imply that there's not a respiratory component. If you're looking at the metabolic side, what you should see is a base excess of around 0. And biochemically, base excess really is the best overall value to use for the metabolic portion, where I believe we use bicarbonate a lot, right? So if you saw your base X change, either positive or negative, it would imply to you have some metabolic derangement that needs to be addressed one way or the other, all right? So let's talk about compensation just for a second. So we know that if CO2 goes, let's say, up, pH goes down, we become acidic. We know that we've all learned that metabolic compensation occurs about how fast? A couple days, right? So it occurs in what way? What should happen? What should happen is the bicarbonate should start to increase in order to normalize it, right? Am I saying that right? Okay, good. What if it hasn't yet? If it hasn't, what does that mean? That means we're uncompensated, partially compensated, or fully compensated. That means we're uncompensated if it has not began to change. What happens if you start to notice that the bicarb has changed some, however, the pH isn't normal? That means I'm partially compensated. So then what does it mean to be fully compensated? That means I'm back to normal, right? Those are really important 3 things to think about. If the compensatory response hasn't started, I'm uncompensated. If it started and I'm not normalized, and by the way, I may never normalize. I may never, ever, ever normalize totally the pH. And so that means I could be at my maximum compensation and still be partially compensated, but I'm only fully compensated when the pH is back between 7.35 and 7.45. All right? So in the book, you can see that there's a nice diagram for you to work through your ABGs, but again, there's a lot of things out there. So I want to end kind of right here. So let's all look at this together. So as soon as I put this blood gas, I hope you did what? You looked at the pH and you said this patient is alkalotic. Thank you very much. Alkalotic. And then I go like this. I look at the CO2 and I say, is it possible that the CO2 is responsible for this alkalosis? You think so? Okay. What about the PO2, by the way? Let's just, while we're in order. Are we good? Not good? I don't love it. What degree of hypoxemia is that? Moderate, okay, all right, I'm with you. What about that oxygen content? Normal? Abnormal? Do you know? It's a little bit low, right? Or where are we at? Are we normal? Okay, all right. Let's get back on the acid-base balance. What about this bicarb? Is that responsible for the pH that's alkalotic? Okay, then what is your interpretation of the blood gas? Say it louder one more time. Uncompensated respiratory alkalosis with moderate hypoxemia. I don't even know why I'm up here. Dr. Hess, I hope you can offer more than I can. This group is already better than I am. And you can see there's no metabolic response at this point in time. The base excess is 0. So again, if you can approach every blood gas as simple as that, you can get by with a lot of them. Right? Look at the where you're at first, then determine what's causing it. Has compensation occurred? If it hasn't, if it's occurring but it hasn't normalized it, if it's fully normalized, then you have a full compensation, right? And if you can keep practicing those, and for those of you yet who go, well, you know, Dr. Scott, you make that seem real easy. I assure you that when I was first practicing respiratory therapy, it was not. It took a lot of practice and a lot of mentoring from people around me. All right, with that said, I think I'm right on time. And thanks, and I'll see you guys later on this afternoon.
Thanks for Professor Brady for elegant presentation and summarize the acid-base balance blood gas analysis within 30 minutes. Thank you for him. And now we call for Professor Hadi Al-Ataibi. Hadi Al-Ataibi is famous for all respiratory therapists in Saudi Arabia. Professor Hadi Al-Ataibi is the Vice Dean for Postgraduate Student and Scientific Research, Director of Respiratory Therapy Department, King Abdulaziz University. Professor Hadi Al-Ataibi is very active RT in Middle East. His activity extended from Saudi Arabia to Arabic country. He's helping me and supporting me for establish and development of the Egyptian Society for Respiratory Therapy, and is president for the symposium for 3 years ago, 2023, 2024, 2025. Thank you for him. And his presentation about the pulmonary function test technique and interpretation. Welcome, Professor Hadi.
Thank you, Prof. Muhyiddin. Thank you very much. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. Thanks for Mr. Hassan Al-Uraini for inviting me to be part of this great gathering. Today, we will talk about the fundamentals of pulmonary function testing. Basically, we're going to talk about spirometry, lung volumes, and lung diffusion capacity. I would like to know how this works. Which one? Yeah. Yep. If you did not take anything away from this presentation, but you get this thing. Spirometry is effort dependent. So the patient must perform the maximal effort. Otherwise, the result is basically rubbish. So this is why when we perform the spirometry or the pulmonary function tests, that we need to apply the acceptability criteria to make sure that the effort is accepted. Then we apply the repeatability criteria to be confident this is the real data and this is the real values that reflect the patient's pulmonary function. So, indication, it's used to help in diagnosis. Nobody look at the report and make a diagnosis. We take the data from the pulmonary functions and add it to the clinical picture of the patient, so it will help in the diagnosis, patient monitoring, or probably eligibility evaluation for surgery or employment. When I say that your vital capacity is 5.5 liter, what does that mean? It means nothing. I need to compare this value to your predicted values, to your normal, to people that they share several characteristics with you. The same age, the same height, the same gender, and the same race. This is called the predicted values. So for every one of us, there is a limit of normal. The upper limit of normal and the lower limit of normal. If my values below the lower limit of normal, that means I'm abnormal. If it is within the upper and lower limit of normal, it is within normal limit. So always we need to compare the data or the BFT parameters to the normal populations. Spirometry, simply, it measures the volumes and the flows. I need to know the volumes, the vital capacity. This is the most important one. And we know that how many volumes we have in the lung. We have 4. Tidal volume, expiratory reserve volume, inspiratory reserve volume, and residual volume. What is the residual volume? It is the volume that cannot be exhaled even with forceful effort. So, spirometry does not measure the total lung capacity because we cannot measure the residual volume. We can only measure what? The vital capacity. So, the tidal volume and inspiratory reserve volume, this is inspiratory capacity. Tidal volume, inspiratory reserve volume, and expiratory reserve volume, this is the vital capacity. This is what we are looking for. If I need to know the residual volume, I need to do something called lung volume measurement, either to use plethysmography, helium dilution, nitrogen washout, and we will talk about this one. Vital capacity. If you see vital capacity, always we are talking about slow vital capacity. So we have 2 types of vital capacity. Slow vital capacity does not need to be forced, and forced vital capacity. The most important and the most common is the forced vital capacity, which is called spirometry. Slow vital capacity, you are basically measuring the vital capacity of the lung. Patient has to take maximal breath, then exhale it until there is no more air getting out of lung. What does no more air getting out of the lung mean? That means less than 25 mil within less than 1 second is exhaled out of the lung. This is indicate that there is no more air getting out of the lung. As I mentioned, the forced vital capacity maneuver or spirometry is the most valuable and the most commonly ordered test in the pulmonary function testing. And the next couple slides will talk about it in details. when we perform the forced vital capacity, we need to give clear instruction to the patient. This instruction is composed of 4 items. We start with maximal inspiration up to the total lung capacity. Then we ask the patient to forcefully blast it and keep pushing, keep pushing, keep pushing, keep pushing until there is no more air getting out of the lung. Then we ask the patient to take maximal inspiration to close the loop. This is why it's called flow volume loop. We need to take maximal inspiration, then maximal expiration, then we take rapid and fast inspiration. Once we perform the trial, we have 2 graphs, the volume times spirogram and the flow volume loop. These 2 graphs need to be inspected to evaluate the acceptability of the trial. Once the acceptability of a trial is done, then I need to look to the parameters so I can make interpretation. The most important parameter is the forced vital capacity, the forced expiratory volume in the first second, and the ratio. It's just the FEV1 divided by the forced vital capacity. This is basic interpretation of spirometry. Usually we start with the ratio. The ratio is normal, then I will check the forced vital capacity. Normal, great. I will check FEV1. Normal, that means all the data or all the parameter or spirometry is within normal limit. What if the ratio is reduced? Obstruction. I don't need to check anything else. Reduced ratio, definitely it's obstruction. So, from spirometry, I can make 2 interpretations, either normal or obstruction. If the ratio is normal and the FEV1 is reduced, forced vital capacity is reduced, what is that? This is very likely to be a restrictive pattern, but I need to do lung volume measurement. I need to see the total lung capacity. What if the ratio is reduced, FEV1 is reduced, and the forced vital capacity is reduced? This is mixed. What if the ratio is normal, total lung capacity is normal, forced vital capacity or FEV1, one of them is reduced? Difficult, huh? What is this? Huh? Non-specific ventilatory defect. Non-specific ventilatory defect. This is usually seen in the obese people. This is the flow volume loop. It's very important to inspect the flow volume loop for 2 reasons. To check the acceptability criteria and to make interpretation. It is simply volume against flow. The upper part is the expiratory side and the lower part is the inspiratory side. It's from the total lung capacity. You can see here, from 0, this is the total lung capacity, and the end of 4 point something, this is the residual volume. Between the total lung capacity and the residual volume is the vital capacity. So the subject has to start from the total lung capacity. The lung is full of air, maximally full. Then we ask the patient to forcefully exhale it. The flow rate has to reach the peak within the 10th of the second. If the peak of the flow rate is displaced to the right, that's indicate to weak effort. The peak flow rate has to be achieved within the 10th of the second. So it should be displaced to the left. From 0 to the peak flow rate, this is called effort dependent. It's patient effort is a contributing factor. From the peak until flow rate of 0, this part, this is called effort independent. It depends on the diameters of the airways. So we ask the patient to keep pushing, keep pushing, keep pushing, keep pushing until there is no more air getting out of the lung. The flow rate return back to 0. Then we ask the patient to take maximal and rapid inspiration to close the loop. This is called the flow volume loop. This one is called the flow time spirogram, and this is very important one because it tells me two things. The first thing, start of the test. I need to see sharp vertical raise, and it helped me to identify the completeness of the test. If there is no plateau, that means there is still air remaining in the lung. This test is invalid. So I need to inspect the flow time spirogram with two things. If there is a sigmoid shape, this is indicate to weak effort. The extrapolated volume probably is very large. So this is some types of, this is the first one is normal. This one, the second one, small, ventilatory restrictive defect. This one, obstructive, severe obstructive. This one, sorry. Fixed. Excellent. This one? Extrathoracic obstruction. Usually RT is confused. Sometimes the patient, the performance during the inspiratory effort, it will cause something like extrathoracic obstruction. This one, this is intrathoracic obstruction. Well done. I don't need to say anything in this. MashaAllah, you know everything. طيب. What are the acceptability criteria? Satisfactory start of the test. Extrapolated volume less than 5% or 100%, whichever is greater. No evidence of zero flow error, no glottal closure, no evidence of obstructed mouth, and achieve the end of force expiration criteria. 3. The golden standard. What is it? Plateau. There is no more air getting out of the lung. I'm looking to see a plateau in the volume time spirograms. This is the most important. What if I can't see plateau? The patient still can exhale air. I need to use the second criteria. Patient has to exhale for 15 seconds. Any exhalation more than 15 seconds, they found that it's clinically infallible. So 15 seconds, great. What if there is no plateau, patient cannot exhale for 15 seconds? What is the third one? Force vital capacity is within the repeatability tolerance. Repeatability tolerance. What does that mean? That means this is what patient can do. The force vital capacity, how can I know that the force vital capacity is within the repeatability tolerance? Either the current force vital capacity or the current vital capacity is better than the previous one. This is good indication that this is what can the patient do. Or the patient each time repeat the same vital capacity. So I can use force vital capacity is within the repeatability tolerance. So the end of force expiration criteria, one of them has to be met. Plateau, this is the golden standard, minimum exhalation time of 15 seconds, or the forced vital capacity is within the repeatability tolerance. This is very important. I need to go back to this one. Yeah, once we apply the acceptability criteria, I need to apply the repeatability criteria. What is the repeatability criteria? I need to see all the trials. The difference between the largest forced vital capacity and the second largest forced vital capacity should be less than 150 mil. And the difference between the largest FEV1 and the second largest FEV1 should be less than 150 mil. If I have two trials that apply these two criteria, I have 3 acceptable trial, 2 repeatable, I'm done with the test. I have a valid test that can be used to make a diagnosis or monitor the patient. I still get 9 minutes, I think, plenty of time. Some spirometry errors. What do you think of this one? Huh? Lung what? Let's start from this one. Sigmoid shape. Weak start. It's clear that one is really very weak effort. This one, you remember that the peak flow rate has to be achieved within the 10th of the second. But the peak flow rate is displaced to the right. This is indicative of the weak effort. And you can see it's rounded there. Bronchodilator response, those who work in the BFT lab, we know that we are doing spirometry, pre and post. We administer bronchodilator or any other medication, and we repeat the test after 10-15 minutes. The old criteria to make significant changes or significant responsiveness, by the way, it is called reversibility before, but now not anymore. They call it responsiveness. They were using 12% and 200 mil. This is not be used anymore. Now you use 10% or more, but of the predicted value. If there is increase by 10% or more of the predicted values, this is indicate there is significant response. This is typical pre and post spirometry with 2 different colors. You can see there is probably significant response. These are the type of pneumotachometers, Flisk, Ulili, this pressure differential pneumotachometer, and ultrasonic. This is my favorite, heated wire. There are several types of pneumotachometer, depend on the manufacturer. Definitely, BFT or spirometer is still a device that we need always to make, to check that the quality these devices produce. This is why we, on daily basis, we need to perform quality check. We usually use 3-liter syringe to make sure that the spirometer can read 3 liters. If it is not read 3 liters plus or minus, we can make adjustment and calibration. Lung diffusion capacity. This is very simple, easy test. As we mentioned earlier, spirometry measure what? Volumes and the flow rate. But we don't know anything about the alveolar capillary membrane integrity. We can check that one with this test, lung diffusion capacity. We ask the patient to breathe normally, then exhale to the residual volume. Then patient will breathe in mixture of gases. CO is one of them with helium and nitrogen or air. Then we ask the patient to deeply inhale the mixture of gases up to the total lung capacity and hold it for 10 seconds, then exhale it. From the exhale, we'll take a sample and we measure the inspired and expired CO. It helps to evaluate the integrity of the alveolar capillary membrane. As I mentioned, all the BFT tests, they get acceptability criteria. One of the acceptability criteria for DLCO, patient has to inhale at least 90% of the vital capacity and hold it for 10 seconds. Lung volumes, as I mentioned earlier, spirometry measure all the volumes except what? Residual volume. So we use another technique to measure residual volume, so we can calculate the total lung capacity. With this lung volume measurement, we do not really measure residual volume. We measure the functional residual capacity, and based on that, we can add it together. There are 3 ways. Helium dilution technique, this is a closed method. Nitrogen washout, this is open circuit. And the plethysmography, the body box. All of these can be used to measure lung volumes or functional residual capacity. Helium dilution and nitrogen washout, they get one disadvantage. What is this? Huh? Raise your voice, please. Huh? Air trapping. It needs or it requires communicated airways. If the airway is blocked by mucus or anything, it will not measure the volume, and this is one of the disadvantages. Nitrogen washout, patient will breathe in 100% oxygen, and this for COPD patients sometimes a disadvantage. This is the body box. This is the helium dilution. Helium dilution, as we mentioned, certain volume with certain percentage of helium, the patient will rebreathe this volume. Once it reaches the equilibrium, we use Boyle's law to calculate the functional residual capacity. Similarly, the nitrogen washout. Any leaks for the nitrogen washout and for the helium dilution technique, it will destroy the test completely. It will be unuseful. Bronchoprovocation test, there are 2 types. Direct, methacholine challenge test is the most common one. Indirect, mannitol exercise challenge test. Ecopnic voluntary hyperventilation, this is a type. This is why, by this test, we trigger the airways to see if they are sensitive, either direct or indirect. Again, if you did not take anything from this lecture, but remember that spirometry is effort dependent. Patient must perform a maximal effort to get this test useful and can be used in the management plan for the patient. Thank you very much.
Thank you very much, Professor Hajid, for the great speech. It always reminds me with the college days. And also thank you, Dr. Hassan Al-Iraini, for the invite. It is my great pleasure to moderate this session together with Prof. Muhyiddin. We are honored now to invite the most famous name in respiratory care, Professor Dean Hess. Professor Dean Hess, he's the editor of Respiratory Care Report, a managing editor of Respiratory Care and the Respiratory Care Massachusetts General Hospital, Boston, in Massachusetts, USA. Dr. Dean Hess will be providing a lecture for non-invasive respiratory support. Professor Dean Hess, the stage is yours. Thank you.
Well, thank you very much. My pleasure to be here with you this afternoon. Many years ago, I came to Saudi for the first time, and it was to this place, to Dammam. So I am happy to be back, and welcome to everyone who is online watching the presentations, as well as those of you who are in the room. So for the next 30 minutes, we're going to talk about non-invasive respiratory support. So what is non-invasive respiratory support? Well, when I think about this, I think about three things: non-invasive ventilation, CPAP, or continuous positive airway pressure, and high-flow nasal cannula. At the very outset, I want to point out that only one of these three is non-invasive ventilation. CPAP and high-flow nasal cannula, although they are non-invasive respiratory support, are not non-invasive ventilation, because non-invasive ventilation is the only approach that we will talk about this afternoon where the inspiratory pressure applied to the airway is greater than the expiratory pressure, and in that way provides ventilatory support in addition to respiratory support for our patients. So then, when should we think about using non-invasive ventilation? And there are now a number of published clinical practice guidelines related to non-invasive ventilation and when it should be used, when it should not be used. This is one of those clinical practice guidelines. I actually helped to co-author this clinical practice guideline, and we pointed out in this document that the strongest evidence for the use of non-invasive ventilation was for COPD exacerbation and acute cardiogenic pulmonary edema, as well as some other indications, some of which have better evidence supporting their use now than they did 10 years ago, such as the prevention of post-extubation respiratory failure in high-risk patients, and I think you'll hear more about that later this afternoon when Thomas Perino talks about weaning from mechanical ventilation. So if you have a patient then who presents to you with acute exacerbation of COPD or acute cardiogenic pulmonary edema, you should immediately think about the use of non-invasive ventilation. Now, when we apply non-invasive ventilation, there are a number of different interfaces that we now have available to us to use. One of the important jobs of the respiratory therapist is to select the correct interface and the correct size of that interface. Things we should think about is how well the mask or the interface fits to the patient, how comfortable is the device for the patient, how much leak is there with the device. So if there is a lot of leak between the device and the patient's face, the therapy will be less effective. And then it's important to consider the risk of skin breakdown. And if you're using non-invasive ventilation and your patient is experiencing facial skin breakdown, you should strongly consider switching to a different interface. What about the ventilator that we use to apply non-invasive ventilation? Well, the most important thing here is how well the ventilator will compensate for leaks. With non-invasive ventilation, there will always be some degree of leak, so it's important that the ventilator that you use compensates well for that leak. Newer generation of ventilators, as I'm sure you know, have not only invasive but also non-invasive modes. So today we can select the same ventilator often for non-invasive ventilation as we would use for invasive ventilation. And as you know, not for all patients is non-invasive ventilation successful. Some patients will need to be intubated, and if you use a ventilator that can do both invasive as well as non-invasive ventilation, if your patient fails, you can use the same ventilator after the patient is intubated. Bi-level ventilators are single-limb blower devices with a leak port. That leak port can be either in the mask or within the circuit, and this allows for the setting of both inspiratory and expiratory pressures. For many years, the bi-level devices outperformed critical care ventilators for non-invasive ventilation. Today, we now have critical care ventilators that compensate very well for leaks, and some of them are nearly as good as the bi-level devices. To prevent rebreathing, with a bi-level device, we cannot set the expiratory pressure less than 4 centimeters of water, something that we will talk a little bit more about in the workshops tomorrow. So what about ventilator modes for non-invasive ventilation? Usually we will use pressure support ventilation. We can use pressure control ventilation. We can use volume control ventilation, but it's very uncommon to use volume control for non-invasive ventilation. Pressure support with the bi-level device is the difference between the inspiratory pressure and the expiratory pressure. So if you set an IPAP of 15 and an EPAP of 5, that is a pressure support of 10 centimeters of water. With newer devices, there are adaptive pressure control modes like AVAPs and IVAPs. With these modes, we set the target tidal volume, and the ventilator adjusts the airway pressure to achieve that tidal volume. We can talk more about these tomorrow in the workshop. The only point that I will make now is that the use of these modes is, I would say, controversial, and there is not clear evidence that they contribute to better outcomes for non-invasive ventilation. If you use one of the McKay servo ventilators, you might also be able to apply non-invasive ventilation using neurally adjusted ventilatory assist, or NAVA. So over this slide and the next slide, I will talk a little bit about my approach to non-invasive ventilation. This is how I've taught it now for probably nearly 20 years, as how to initiate non-invasive ventilation. So first of all, we need to choose a ventilator that's capable of meeting our patient's needs. Usually that will be pressure ventilation, usually pressure support ventilation. We need to choose an interface and avoid an interface that is too large. An interface, a mask that is too large, will contribute to leaks. We will then need to strap the mask on more tightly, and that contributes to facial skin breakdown. Often for non-invasive ventilation, we will be working with an awake patient, so we can explain the therapy to the patient, can silence then the alarms on the ventilator. I always like to start out with low settings so that the patient can adapt to non-invasive ventilation. I like to start NIV while I first hold the mask in place so the patient gets comfortable with it, and then I secure the mask, avoiding a tight fit. A tight fit will be more uncomfortable for the patient. A tight fit will also contribute to facial skin breakdown. And then I titrate the pressure up to patient's comfort. I'm often asking the patient if their breathing is becoming more comfortable as I increase the pressure, and I'm looking at things like accessory muscle use, tachypnea, and so forth. I titrate the FiO2 for an acceptable oxygen saturation, and for non-invasive ventilation, I usually avoid peak pressures over 20 centimeters of water, because at pressures greater than 20 centimeters of water in the pharynx, that can contribute to gastric insufflation, which we certainly want to avoid. I titrate the expiratory pressure, or the PEEP, according to the patient's ability to trigger, if the patient has COPD or oxygen saturation, such as with cardiogenic pulmonary edema. Then I continue to coach and reassure the patient, adjust the settings according to patient adherence. I don't draw a lot of blood gases during non-invasive ventilation, typically just follow clinical signs at the bedside, and then I adjust the pressure to avoid tidal volumes of greater than 8 mLs per kilogram. There are some objective predictors of non-invasive ventilation failure in the literature. One is a tidal volume greater than 9 mLs per kilogram, and the other is the HACAR score, and the criteria for the HACAR score I show on the slide. I should point out that these predictors are primarily for patients who have hypoxemic respiratory failure, not for patients with hypercapnic respiratory failure. The HACAR score has been validated in the literature. I need to say that I don't think that it's gained very much traction, because when you're busy in the unit at the bedside initiating non-invasive ventilation, I myself don't have time to stop and do the math to calculate the HACAR score. Humidification, I think, is important during non-invasive ventilation. Active humidification is preferred over passive humidification. The passive humidifier adds dead space, so it's more difficult to clear carbon dioxide in your patient with hypercapnic respiratory failure. But we don't need to turn the humidifier temperature up to 37 degrees centigrade. A temperature of about 30 is reasonable and comfortable for most patients. We can deliver aerosols during non-invasive ventilation. We can use a pressurized meter dose inhaler and a spacer device. We can use a jet nebulizer. This slide is a bit older. I should point out that you can also use a mesh nebulizer during non-invasive ventilation. And in fact, in my practice, most commonly, I use a mesh nebulizer for non-invasive ventilation. Regardless of the device, notice that the position of the device is at the mask. It is not back at the ventilator. So there's evidence, including evidence that I published from our lab many years ago, that shows that there's better aerosol delivery if you put the device near the mask, as is shown on the slide, rather than putting the aerosol generating device closer to the ventilator. We can also use non-invasive ventilation for patients with chronic respiratory failure. This is most commonly used in patients with neuromuscular disease. How do we decide when a patient with neuromuscular disease needs non-invasive ventilation? Well, I focus on symptoms such as orthopnea, dyspnea, daytime sleepiness, weakness, such as measures of vital capacity and inspiratory pressures, and gas exchange, such as daytime hypercapnia or desaturation during sleep with an overnight oximetry. There is also accumulating evidence supporting the benefit of non-invasive ventilation for chronic hypercapnic patients with COPD. This is another clinical practice guideline that I helped to write a few years ago, where the number one suggestion from this clinical practice guideline was that we should use nocturnal non-invasive ventilation in addition to usual care for patients with chronic, stable, hypercapnic COPD. So today, I think we have ample evidence to support the use of chronic, nocturnal, non-invasive ventilation in our COPD patients, in addition to our patients with neuromuscular disease. Just one slide on CPAP. So remember again, CPAP is not ventilation. With CPAP, we apply a continuous pressure to the airway. The pressure does not increase during inspiration. This is indicated for acute hypoxemic respiratory failure, postoperative respiratory failure, and then I think the most important indication is acute cardiogenic pulmonary edema. And the evidence actually shows that in a patient who presents with acute cardiogenic pulmonary edema, whether you use non-invasive ventilation or you use CPAP, the outcomes are very similar. So we can not only avoid intubation, but we can afford a survival benefit with either CPAP or non-invasive ventilation for acute cardiogenic pulmonary edema. Prophylactic postoperative CPAP is probably not effective. A few randomized controlled trials have shown that to be the case. And a typical CPAP level, as in a patient with cardiogenic pulmonary edema, is about 5 to 10 centimeters of water. So now let's move on and talk for a few minutes about the third form of non-invasive respiratory support, which is high-flow nasal cannula. And again, a point that I made way back on the very first slide is that high-flow nasal cannula is not a form of ventilation. It is not non-invasive ventilation, but it is non-invasive respiratory support. With high-flow nasal cannula, we have typically a flow meter, which in adults can go to high flows, like up to 60 liters per minute. We have an air oxygen blender, so we can adjust the FiO2. The inspired gas is warmed and humidified. Otherwise, 60 liters per minute coming into your nose would not be very comfortable. And then we have a nasal cannula that is designed specifically for the higher flows that are used with high-flow nasal cannula. There are a number of mechanisms for benefit of high-flow nasal cannula. First of all, we can deliver a precise FiO2 because typically the flow that is being delivered from the device exceeds the peak inspiratory flow of the patient. High-flow nasal cannula flushes the upper airway, flushes carbon dioxide from the upper airway. That reduces dead space, increases FiO2. And in fact, it's not uncommon that with high-flow nasal cannula, we will see a reduction in arterial PCO2, but that's not because we're applying ventilation, it's because we are applying ventilation more effectively by flushing carbon dioxide from the upper airway. High-flow nasal cannula, high flow reduces inspiratory resistance, so the patient doesn't have to draw air through the resistance or doesn't have to draw gas through the resistance of the upper airway. They breathe from the air, or I shouldn't say the air, the gas that is presented to the pharynx from the high-flow nasal cannula. We do get a little bit of distending pressure, or CPAP, with high-flow nasal cannula. That is flow dependent. It's also dependent upon whether the patient keeps their mouth closed or not. But with the mouth closed, high-flow nasal cannula can deliver a clinically important level of CPAP. And the high flow is comfortable when it's warmed and humidified. I can recall 20 years ago when this therapy was first coming out, we questioned whether a patient could really tolerate 60 liters per minute blowing up their nose. And the answer is it's very well tolerated if the gas is appropriately warmed and humidified. So we need a heated circuit with high-flow nasal cannula to reduce condensation in the circuit. Generally, a temperature of around 30 or 31 degrees is sufficient for adults. There have been some observational studies that have shown that a temperature around 30 or 31 degrees is more comfortable for the patient than turning it up to body temperature of 37. We now have ventilators that can provide not only non-invasive ventilation and invasive ventilation, but also high-flow nasal cannula. So now you can have one device at the bedside that you can use for either non-invasive ventilation, invasive ventilation, or high-flow nasal cannula. The cannulas are available as large bore or small bore cannula. There is some controversy about which is better, and to actually make it even maybe more controversial, there are now devices that have a small bore cannula on one side and a large bore cannula on the other side. And like I said, it's very controversial as to whether one approach is clearly better than another. How do we evaluate the response to high-flow nasal cannula? Well, in the literature is published now a number of studies that have evaluated the ROX index as a predictor of success of high-flow nasal cannula. The ROX index is oxygenation in the numerator, the SpO2 divided by the FiO2, divided by the respiratory rate or the breathing frequency in the denominator. And essentially what this says is if you put your patient on high-flow nasal cannula and they continue to be hypoxemic, it's likely they will fail the therapy. Or if you put a patient on high-flow nasal cannula and they continue to be tachypnic, they are likely to fail high-flow nasal cannula therapy. And then if you want, you can go on and do the math, and you can plug the numbers into the equation and calculate a number. But just bear in mind that when you initiate high-flow nasal cannula, if you cannot correct the patient's hypoxemia and you cannot correct the patient's tachypnea, the patient is likely to be failing the therapy, and you should consider either non-invasive ventilation or intubating the patient. We can also deliver aerosol therapy with high-flow nasal cannula. There have been a lot of bench studies and a few clinical studies that show that this is effective. The best position for the nebulizer is proximal to the humidifier, and the type of device that is most commonly used, I believe, are the mesh nebulizers. Certainly that is consistent with my practice. Another thing that has been reported in the literature, and actually in at least one randomized controlled trial that I'm familiar with, is sequential use of non-invasive ventilation and high-flow nasal cannula. So what this means is that you switch between the two therapies. So maybe you put your patient on non-invasive ventilation for 4 hours, and the patient wants you to take off the mask and give them a break from high-flow nasal cannula. So you remove the mask, you put them on high-flow, or the patient wants a break from non-invasive ventilation. So you take off the mask, you put them on high-flow nasal cannula for a few hours. And then you put them back on non-invasive ventilation. And then after some time, maybe 4 hours, the patient complains that they want a break from the non-invasive ventilation, so you take off the mask, you put them on high-flow nasal cannula, and you switch back and forth between the two. So this is sequential use of non-invasive ventilation and high-flow nasal cannula, which alternates between the two therapies. This might improve comfort and tolerance of the therapies, and I'm aware of at least one randomized controlled trial that's showing that sequential use of NIV and high-flow nasal cannula, switching back and forth between the two, led to better patient outcomes. So then let me wrap this up over the next slide or so. I'm actually going to finish early, which is unusual for me. So in appropriately selected patients, non-invasive ventilation decreases the need for endotracheal intubation and improves survival. So we have now a number of studies, particularly in the setting of acute hypercapnic COPD exacerbation, that the use of non-invasive ventilation means that it's less likely that the patient will be intubated, and that translates into a survival benefit. The selection of interface is important for comfort and risk of skin breakdown. This is where we as respiratory therapists can make a big difference as to selecting the correct interface, sizing it correctly, avoiding too much tension on the straps holding it in place, and so forth. Leak compensation is an important attribute of ventilators for non-invasive ventilation. And again, we now have a generation of ventilators. The newest generation of ventilators allow us to do invasive ventilation or have non-invasive modes to allow us to do non-invasive ventilation. Mask CPAP is used for acute hypoxemic respiratory failure, postoperative respiratory failure, and acute cardiogenic pulmonary edema. The most common indication for mask CPAP is acute cardiogenic pulmonary edema, and as I pointed out before, the evidence shows essentially equivalence between the use of mask CPAP or non-invasive ventilation for acute cardiogenic pulmonary edema. High-flow nasal cannula delivers gas by nasal prongs and flows up to 60 liters per minute. So I'm talking about the adult setting. I think tomorrow there will be other speakers who will talk about this in the setting of neonatal pediatrics, where obviously you would not use flows of 60 liters per minute. Aerosol therapy is effective when combined with either non-invasive ventilation or high-flow nasal cannula. and sequential use of non-invasive ventilation and high-flow nasal cannula, switching back and forth between the two is effective. So with that, I will stop, and I will tell you that in our workshop tomorrow afternoon on non-invasive ventilation and high-flow nasal cannula, we will have an opportunity to talk in more detail, particularly about the technical aspects of applying this therapy. So with that, I will stop, and you didn't even have to hold your fingers up. Thank you.
Thank you very much, Professor Dean Hiss. Thank you also for sharing the updates for the non-invasive ventilator support. And thank you also for being on time as well, ahead of time actually. So the next speaker is Dr. Thomas Priano. He is a respiratory therapy consultant, lecturer at Department of Anesthesia, Division of Critical Care from McMaster University, clinical specialist, mechanical ventilation, Kingston General Hospital, Hamilton, Ontario, Canada. He will be talking about ventilator modes. Thank you, Dr. Thomas. The stage is yours.
Thank you. And thank you. I realize my description has the last 10 years of my career all in one slide. So I no longer work at Kingston General Hospital. So I'm going to speak to you about modes of ventilation. My specialty and my passion is mechanical ventilation. And of course, without modes of ventilation, you can't provide mechanical ventilation. So we're going to describe a number of things. These objectives are in the textbook chapters, so I won't focus on these here. But essentially, a ventilation mode, or the mode, describes the breath sequence and how the ventilator controls volume, pressure, flow, and timing within a breath. Rob Chatburn introduced the taxonomy for mechanical ventilation, and it's made up of three main components. There are other elements of it, but I'm going to focus on the three essential descriptions. One is the breath sequence, the second is the control variable, and then third is the phase variable. For the breath sequence, it describes how the ventilator coordinates machine breaths with the patient. So the first one is continuous mandatory ventilation, CMV. Essentially means your patient does not have to have an intact drive. There's a mandatory ventilator component to this. However, the patient could trigger the ventilator, but there is a guaranteed mandatory minimum respiratory rate, and whether it's pressure or volume, it's guaranteed. Then there's intermittent mandatory ventilation. This is where the ventilator may provide mandatory sequence of breaths, but also allow the patient to breathe with or without additional support in between these breaths. And then there's, of course, CSV, which is continuous spontaneous ventilation, which makes up most of the spontaneous modes like pressure support ventilation, PAV, NAVA, and I'll discuss these individually. So just some visual descriptions at the top here. We have, this is mandatory ventilation, so we have a set respiratory rate, whether the patient is triggering or not. Can anyone tell me if the patient is triggering in this example in the top left? How can you tell? Little drop in pressure, right? So very good. We're going to discuss ventilator interactions, et cetera, tomorrow in the workshop. On the right, we have an example of SIMV. So we have some mandatory breaths, and you can very clearly see the mandatory breaths. Now, can you tell me in between the mandatory breaths, is this pressure support, CPAP, or no support? Very good. How can you tell? Well, the baseline is 0 and pressure is fluctuating, and actually the pressure is dropping and then increasing during exhalation. So this indicates that there's no support there. And then down here we have another example of no support, but if this was elevated to here, then we would have CPAP. Okay, but right now this is set at 0, so that's no support. Now the control variable, this is the easy thing. Regardless of all of the modes of ventilation you might see on a ventilator, they can only control one of two things: volume, or flow, or pressure. This sounds like three things, but volume control typically is controlled by a fixed flow rate, so they can only control for volume or pressure, but they cannot do both. Now you might think that's confusing because there's things like pressure-regulated volume control, right, where you have a set volume, but you're using pressure control. Is pressure being controlled in PRVC? See, I hear some yes and some no. This is a tricky one. What happens if the lungs get stiffer? Does the pressure stay the same? It increases, right? So it's not technically controlling pressure. It's adjusting pressure to a target volume. So this is where it gets a little bit confusing when we talk about things can only control one or the other. So this is a very important point. I'll talk about these modes individually. And then, of course, pressure control, we're controlling pressure, and volume, we're controlling volume. These are the simplest of them. The phase variable essentially describes how the breath starts and how it ends. So if you have a patient on a mandatory ventilator mode, like pressure control or volume control, and they're passive, the trigger component is simply time, right? It's now time for the next breath. If you set a respiratory rate of 15, they're going to get a breath every 4 seconds. Now, when they are triggering, we showed earlier there was a drop in pressure, so you could have a pressure trigger or a flow trigger. The most common triggers, of course, are pressure and flow. There's one mode that uses a different type of trigger, and I'll describe that, but it uses the signal from the brain down the phrenic nerve to trigger the ventilator, and this is called NAVA. So in terms of trigger, here we have a respiratory rate of 15. I did the math before I presented, so I didn't mess that up. But you get a breath every 4 seconds, and this is with or without patient effort. And is there a patient triggering those breaths? No, there's no drop, there's no indication that they're interacting with the ventilator. And then here we have an example of flow trigger where we have 5 liters per minute of bias flow. On the way back in the ventilator, it's sensing 4 because the patient has drawn 1 liter per minute, so that trigger sensitivity would be 1 liter per minute of flow, and the patient is triggering the ventilator. On the far right, we have the example earlier where you saw a clear drop in pressure, the patient is triggering with a pressure trigger. Cycling methods, the most common is time. Now, even in volume control modes, sometimes the timing variable or the cycle criteria is time, but if you pay close attention to your ventilator when you're adjusting the time, it's usually telling you what the flow rate will be with that time. Because again, it's controlling flow and volume in volume control. Even though you're setting time, the cycle criteria will be when the volume is delivered to the patient. However, volume control is a unique mode. On most ventilators, there's one more setting that can alter the timing of the breath. Do you know what that is? Inspiratory pause, right? It's the only mode that has a dedicated inspiratory pause. Now, what would be the utility of the inspiratory pause? The screen just went out up here, by the way, guys. Hello? The screen just went out? What would be the indication of using an inspiratory pause? Sorry? You can measure what type of pressure? Plateau pressure in real time, breath by breath. So when a patient is completely passive, volume assist control is actually my favorite mode to use. But I will tell you, the minute my patient starts to interact with the ventilator, it is my least favorite mode because it is completely controlling the flow, and the patient may want a different flow rate, and you can get a patient that has extreme flow dysynchrony or air hunger very quickly. But in terms of a passive mode, I like it simply because I can set the inspiratory pause and I instantly know what plateau pressure is. And if I know what plateau pressure is and I know what PEEP is, what's the thing that I can calculate very easily? Driving pressure and compliance, right? So driving pressure is a hot topic in ARDS management, and you can have it breath by breath. Now, in terms of another cycle criteria, there is flow. Now, this is an example I'm going to assume of pressure support. And if you pay close attention, you can see the flow decelerates, which is normal. But this breath, it seems to cycle off much sooner than the other one. On each ventilator, many of them call it something different, which is frustrating, actually, as a clinician who's taught this for years, because the flow cycle criteria tells you how long the pressure is being delivered to the patient, and it cycles off. So the example looks like it might be 50%. It's cycling off at peak, 50% of peak flow. On the bottom, it's probably closer to 20 or 25% of peak flow. Some ventilators call it inspiratory cycle, some call it PSV cycle, some call it e-sense. As long as you know what it's called on the ventilator you're using and the purpose of it, you can utilize it effectively. So here's an example of, I would say, the most common modes in the literature. If I showed you a list of what all the ventilator companies call all of the multiple modes, it would be a list of at least 80 things, but they actually break down to essentially what you're seeing here on the screen. Now, I'm going to ask how many of you, looking at all of these modes, if you were to think of 90 to 95% of all of the patients you treat in your intensive care unit, how many of you use 3 or less modes? There should be more hands up here for sure. How many of you use all of these modes? Wow, okay, so they have many different ICU ventilators because clearly some of these modes are only available on certain ventilators. But the bottom line is most people will use either volume control, pressure control, or PRVC as their mandatory mode. Show of hands for how many people agree. These are the most common control modes that are out there. And for support, the most common mode globally is pressure support. There's no argument there. You may put some patients on PAV or NAVA or APRV, but I'll talk about these modes independently or individually. Now, volume control has a set constant flow and a constant delivered tidal volume with each breath. The issue is the pressure will change depending on the patient's respiratory system mechanics or patient effort. Okay, so this will adjust the PIP or the plateau. If my patient has an increase in airway resistance, what increases, my PIP or my plateau? PIP. Technically the delta, right? So plateau will stay the same, the PIP will go up. If my respiratory system compliance changes, what will go up, PIP or plateau? Aha, both, good. That was a trick question. If my compliance gets worse, assuming my resistance is constant, both will increase, okay? But the delta will stay the same if resistance is not changing, okay? Now, I already mentioned the timing could be either flow will be your setting on the ventilator or time, but if you are adjusting time, it will usually tell you what the flow output is for that breath. And the flow pattern, the most common in the literature when you see graphs and whatnot, it's square. Of course, you can use decelerating flow. The decelerating flow pattern is for people that are scared of peak airway pressure, or for those that don't understand how resistance works. So with this mode, when you increase flow, you increase resistive pressure. Now, is the resistive pressure the thing we're worried about injuring the lung? Or is it plateau pressure? Plateau pressure. If I have an asthmatic patient and I have peak pressures, if I put them on volume control and I have a peak pressure of 65, 70 centimeters of water, I honestly don't care. I care what the plateau is. The plateau should be a safe plateau, ideally less than 28 centimeters of water. The peak pressure is a product of resistance. I can turn my flow down and decrease the peak pressure. It's just a product of flow. Okay, that's the back pressure. Now, with pressure control, we set an inspiratory time and a pressure, and we usually adjust the pressure control to get the tidal volume that we want. If my patient's resistance or compliance changes, what happens to my tidal volume? It decreases. So this is problematic if you are not monitoring your patient routinely or with tight enough alarm criteria. You may have a patient whose blood gases are changing quite drastically from time to time when you are coming to see your patient. And it could simply be because the patient was turned in the bed by nursing, and you come back and the tidal volumes are 150 mils less and your blood gas is worse. So some common settings, I mentioned pressure, inspiratory, but there's also a rise time. The rise time is just how quickly the ventilator pressurizes to reach that pressure. Generally, the default is about 100 milliseconds, and it's not often required to adjust it drastically. And in terms of using it for patient comfort, if the patient is triggering, there is a U-shaped variable or U-shaped relationship with whether or not the patient will find it comfortable to adjust. So for some patients, when you decrease, the patient will get more uncomfortable, and with others, they'll be more uncomfortable if you increase it. So there is a sweet spot for most patients. But typically, it's not the thing you're looking for if you're having problems with dysynchrony. It's usually other causes, unless you've set it inappropriately. Now, when we compare volume control modes and pressure control modes, there are very clear advantages and disadvantages. With volume control, we are guaranteeing alveolar ventilation, right? We know a set rate, a set volume. We know how much minute ventilation there is, and that can only go up if the patient starts to trigger, but we know the minimum is set. With pressure control, we have advantages of variable flow. So I mentioned earlier that if my patient is completely passive, I like volume control as a mode I can use for monitoring peak and plateau pressure. But the minute they're interacting with the ventilator, I prefer a pressure mode so that they have variable flow. Some disadvantages of volume control is that fixed flow pattern. This is why when my patient is breathing spontaneously, I don't want them on this mode. I don't think it's very comfortable. But however, with pressure control, I mentioned earlier, you have less control of minute ventilation because any change in respiratory system mechanics will cause your tidal volume to change. With clinical situations where the mode is indicated, again, fixed volume and fixed CO2, you're going to have less alterations in CO2 if you're using volume-controlled ventilation. With pressure control, it does keep your pressure constant, so you're not worried about too high of an airway pressure being generated by changes in lung mechanics. And of course, breathing spontaneously is much more comfortable using a pressure-targeted mode than it is to have a flow or volume-controlled mode. SIMV provides the mandatory breaths, and it could be either volume or pressure, as I just mentioned. However, in between those, they could have supported or unsupported breaths. I showed you a graphic earlier that demonstrated this. SIMV was initially designed as a weaning mode. Does anybody know if it is a successful weaning mode, according to today's literature? No. It was determined in the 90s. Some of you may not have been alive in the 90s. It was determined in the 90s that the mode is actually horrible at weaning. And in adult patients, I honestly don't know any use for SIMV. And I would argue that it's often used when patients are on pressure support at night, they go to sleep, and you get called to the room because the patient has gone apneic. And when you show up to the room, they're now awake, and you don't know what's going on. And then you say, well, they look good, you leave, you get called back because they're apneic again when they fall asleep. Does this happen to anybody? The patient's on pressure support overnight and they fall asleep and then they go apneic. I'm going to describe this in one of my lectures later on Saturday, but this is called hitting the eukapnic threshold. If you fall asleep and you blow your CO2 off, or the ventilator blows your CO2 off below a certain level, you will have a central apnea. What wakes you up? The ventilator alarm. So when you come to see the patient, they're awake because they are annoyingly awakened by the ventilator. Do you know what the right response is to handle that? Most people put them on SIMV or a full control mode. Do you know what the right response would be? Decrease the pressure. Wean them. I did that once, and you know what my colleague said? We don't wean at night. I don't know why you're weaning at night. And I said, why wouldn't I wean at night? By lowering the pressure, the patient will likely be able to sleep, and they'll downregulate properly, and you won't blow off the CO2 and cause the central apneas. So this is how it looks now. How it prevents stacking of breaths, because imagine you are breathing and you happen to be in this phase, you take a breath in, and then halfway through your breath, the machine just gives you a mandatory breath. Now you're breath stacking. The way it avoids that is you have what are called these trigger windows. So there's a certain time before it's meant to give a mandatory breath based on the respiratory rate you set, that if they trigger the breath in a certain time before that, the machine will just go ahead and give them the mandatory breath. So if you have mandatory rate set at 10, it is possible that they could get more than 10 breaths per minute. If they happen to be cycling or taking an effort right before, it's possible it could be slightly more, but it is a minimum respiratory rate that they will get. Again, not useful for weaning. It used to be designed that you would slowly wean the mandatory rate as the patient breathes more on their own, and this was a very slow and painful way of weaning your, not painful, but painfully slow way of weaning your patients. Now, pressure support's the most common spontaneous mode of ventilation globally. The control variable is pressure. The tag or the mode sequence there is PC-CSV, continuous spontaneous ventilation. They must have an intact respiratory rate because they have to be breathing spontaneous. There is no respiratory rate setting, so typically you also have to have an apnea backup. Because patients have more control of their breath size and timing, it can unload the work of breathing, but it's also when you may also start seeing some patient-ventilator interactions like asynchrony can occur. I've had some physicians in the past tell me if my patient's on pressure support, they can't be asynchronous. And I said, well, what are you talking about? Most asynchronies occur when the patients are breathing spontaneous, and we've tried to transition them. So the patient does not have full control of the breath. Does the patient control how long the breath lasts? How many say yes? How many say no? Yes? Why? You're right. Yes, we control, and this was also a trick question because I gave you the answer earlier, we control the flow cycle percent, so we determine how long the breath lasts. Now, a flow cycle percent could result in a longer or shorter breath based on the respiratory system mechanics, but we do control how long that pressure is delivered, so they don't have full control of the breath. You could have a patient who's just triggering the ventilator, and it is fully ventilating them without any difficulty because you've set the pressure high enough, and there's no further patient interaction aside from triggering the ventilator. So it's very easy to over-support patients in pressure support, and we have to be aware of that. Now, minimum support of 5 to 10 will typically handle any resistance due to an endotracheal tube. And of course, we adjust pressures both in pressure control and pressure support to deliver safe tidal volumes, 4 to 8 mils per kilo. If someone has ARDS, they're likely not, and they're very sick, they're likely not in pressure support. And in pressure control, we would target lower tidal volume of 4 to 6. CPAP, as Dean nicely mentioned in non-invasive ventilation, it is not a form of ventilation. It's a non-invasive form of respiratory support. And when you're invasive, you can also provide this support, but it doesn't provide inspiratory support. It can offload work of breathing due to atelectasis or pulmonary edema, but it does not provide inspiratory augmentation or inspiratory support. So it won't offload work of breathing due to inspiratory muscle fatigue, for example, but it may offload work of breathing if you resolve atelectasis with it. And of course, just imagine that that line is shifted upwards. CPAP would be whatever pressure you're at. Adaptive pressure control, this is the most common mode for this. Most ventilators will call it PRVC, pressure regulated volume control. It's adaptive because it adjusts the level of pressure, and you can also have AVAPs, which was a non-invasive mode that Dr. Hess mentioned. These modes will use pressure, but target a set volume. So I mentioned earlier that we don't technically control the pressure in these modes. It is automatically adjusted by the ventilator for a target tidal volume. So it means we need to monitor closely the pressures with these modes so that we know if they're reaching dangerous pressures or not. And we should monitor closely minute ventilation to ensure that if tidal volume drops or if the pressure drops, again, with these ones, sorry, I back up. Minute ventilation is usually guaranteed. We don't have to monitor minute ventilation as much, but that pressure is extremely important. Now, how many use PRVC as a main mode, mandatory mode in their ICU? Oh boy. Okay, what I'm about to tell you is extremely, extremely important. If you have a patient who is actively breathing on PRVC, it does not behave usually the way you want it to if they have an increased work of breathing, okay? If you set a tidal volume of 400 mils and the patient wants 500, what happens to the ventilator support when the patient pulls in 500? It turns down the pressure. Do you think the patient might try harder to get the volume if they want it? So they try harder. What does it do if the patient gets 500 again? It decreases the pressure. So if you ever get called to the bedside because of a low pressure alarm in PRVC, please do not have the patient sedated. Please do not do anything except switch them to a regular pressure mode. Pressure control, pressure support, keep a pressure target that is set so that the patient, now again, you might not like the tidal volume that they draw in, but you have to decide whether or not you want them to have the volume they want or whether or not you want them to feel like they are being suffocated. Because if they're trying to pull in the volume, they get the flow. This is where there's a misconception. Oh, there's variable flow, they get the flow, but the machine will constantly ramp down pressure and ramp down pressure. Some ventilators will go as low as 3 centimeters of water above PEEP. So when I get to the bedside, my first question when I have students, I said, what is the peak pressure? They look and they say, it's 13. I said, what's PEEP? They say 10. I said, does this patient look like you would put them on a pressure support of 3 centimeters of water? And usually the answer is no, the patient looks horrible right now. I said, that's what they're getting right now. So just keep in mind that this mode, most people like it because it has all the benefits of guaranteeing a minute ventilation, and they think, oh, it gives a decelerating flow, so my peak pressures are lower. But the biggest issue with this mode is right there, where it says with large inspiratory efforts, the ventilator reduces support, leading to increased work of breathing and asynchrony. And then also when lung compliance decreases, the pressure could increase to dangerous levels, so it's important to set your peak pressure monitoring appropriately. APRV. How many people, show of hands, use APRV? Okay. I'm glad there's not too many hands up. That's my personal opinion. APRV is a pressure-limited mode with prolonged inspiratory time. It has a lot of traction on social media and on LinkedIn. There's lots of people talking about it. It is a mode that essentially increases mean airway pressure, and allows patients to breathe spontaneous at this elevated mean airway pressure. So it's used typically to improve oxygenation patients in ARDS. To date, we do not have any good randomized controlled trials that show a benefit of using this mode over optimizing PEEP. We need more data to confirm that this is the safe mode to use for these patients, and I'll tell you why. It's coming up, but do you know what mode of ventilation increases mean airway pressure and improves oxygenation in patients? That was very common years ago. High frequency, what's the O? High frequency oscillatory ventilation, and I'll talk about high frequency in a moment. But this is a mode that increased mean airway pressure, has always been shown to improve oxygenation, but do you know what else it increased in a large study? Mortality. So until we have a similar good quality or high quality study, I still have reserve for saying this is what we should do to manage oxygenation. It will improve your oxygenation. Do you know what else improves oxygenation? Anyone familiar with the ARDSNet study? 6 mils per kilo versus 12 mils per kilo? We've all heard of that, right? We found out that we're ventilating patients horribly with 12 mils per kilo. Do you know which group had better oxygenation? You can tell by my smile. 12 mils per kilo had better oxygenation and better ventilation, but they had higher mortality. So just targeting something like, oh, my oxygenation's gotten better, we have to be very careful with interpreting that as something positive. Okay, but how do you manage patients on this mode? Typically, you have a P high, a P low, which is often set to 0 because you use a time at that low pressure that is so short that you essentially are causing auto-PEEP. You're not allowing the lungs to collapse, so there's a release and volume is released, and then it's only for a very short period of time before it goes back up to that high pressure. So to improve oxygenation, you would either increase P high or extend the time at that high, again, to increase mean airway pressure. But as I mentioned, the last mode we had that increased mean airway pressure did not have benefits in adult patients. And I'll talk about that. Proportional assist, how many of you use PAV clinically? Very few. It still hasn't taken off globally, and it probably never will now. We just finished publishing a study. I was the RT coordinator for the study called the Promising Study. It was published in the New England Journal of Medicine just last September, and it showed no benefit using PAV as a standard spontaneous mode when compared to pressure support. And this is with a very strict weaning protocol, both modes being utilized in the same way in terms of their weaning algorithm and when you should do spontaneous breathing trials, and there was no benefit over that. However, it is a very smart mode. I kind of wish it was successful. I don't like that it's only available on certain ventilators, but it really has a lot of physiology behind it. It follows the equation of motion. As the patient takes effort, it monitors flow and volume instantaneously with each breath, and then it determines how much support you want the ventilator to give. With PAV Plus on the Covidian ventilator, it was a % of that work of breathing. So if you set 50%, it means whatever the ventilator was giving, the delta pressure that it was giving, that was the PMUS that your patient was breathing. So it was actually a very nice way of monitoring PMUS in real time as well. The clinician essentially sets the proportion of the support that it wants the ventilator to use. And I'll talk about this in my workshop tomorrow. I have this mode in my online simulator that I created. NAVA uses the electrical signal that is sent to the diaphragm, and you have to place a catheter. You can either be placed orally or nasally, and it has electrodes that have to sit at the level of the diaphragm. It is also a combination nasogastric tube, so you can use it to feed your patients as well. This mode, on paper, is the most synchronous mode you could possibly have. Most ventilator modes, your brain says, I want to breathe. It sends a signal to the diaphragm contracts. Then you have to pull flow or pressure to trigger the ventilator. Then the ventilator responds to that and gives the breath. With NAVA, the minute the brain sends the electrical signal to the diaphragm, as soon as the diaphragm has the electricity going through the muscle, the machine triggers instantly. So it is the most synchronous mode you could possibly have. I've used this clinically. It doesn't always work perfectly. Luckily, there's a backup, so it will back up and do pressure or flow trigger if the neurological signal is not triggering the ventilator. But it is also a proportional mode like PAV, where you set an amount of support in centimeters of water per microvolt of electrical output. And then you can give more or less pressure support per signal change. Adaptive support ventilation is mostly made common on the Hamilton ventilator. How many people use the Hamilton ventilator? Okay, we have a few. And ASV, you've used ASV? So it essentially, for those who aren't familiar, it basically titrates your pressure and your respiratory rate to try to maintain not only a safe zone to ensure that you're not injuring the lung, but also to provide the least amount of work of breathing, particularly when patients are breathing spontaneous. When they're not breathing spontaneously, it will maintain a safe zone. When they're breathing spontaneously, it tries to minimize the amount of work that the patient does based on the Otis principle. The clinician has to input the patient's sex and height so that it knows ideal body weight, and then we determine a percent minute volume that the machine tries to target. In terms of how it functions, it actually does multiple breath sequences. So it has CMV when the patient's not breathing. It does sort of an IMV where it only kicks in when the patient goes apneic for a certain amount of time. And then once they're breathing spontaneously regularly, it's basically giving pressure support. It's been found safe and easy to use in patients. Again, we don't have clinical outcome data that it is superior to other modes. In fact, every mode that I've mentioned really doesn't have data to suggest that it is superior over another mode. I just have more reserve when it comes to some modes that do not strange things, but unconventional things like increasing mean airway pressure. Which brings me, this is just an example of the safety zone and then the minimal work of breathing that tries to target. So this brings me to high frequency ventilation, which the most common in adults was high flow oxygenation or high flow oscillatory ventilation. A study was published, I believe it was 2013. There was the Oscillate trial, which was done mostly in Canadian and Saudi Arabia ICUs. So it was a joint effort, and we found that it caused harm in patients with ARDS. The criticism was that, we used a very aggressive mean airway pressure. There was a study published in the exact same journal at the exact same time out of Europe called the Oscar trial. They used lower mean airway pressures and found no benefit over conventional ventilation. So how many people still use oscillation in adults? Neonates? Yeah. So still plays a role in neonatal ventilation. I'm not here to talk about neonates. Some of my colleagues will talk about neonatal ventilation tomorrow. But in adults, it really has sort of lost its appeal because of the recent studies. But if you were to be asked on a quiz how you manage oxygenation, the answer is you increase your mean airway pressure. Again, this is the way that you increase oxygenation. Similar to APRV, you increase P high. So the key concepts, these are key concepts that I'm not going to review all of these. It's a huge list. It is in your textbook, and I have finished on time as well. Thank you very much. Thank you.
Thank you very much. Two very quick announcements, very important announcements. Number one, there are many nice papers up there, the abstract. Please take a time to visit and encourage our colleague who did those papers. Very important. Number two, I want to repeat again the purpose of that sheet that says visit the booths. You just need to go, if you have that sheet, write your name and your mobile on it. Then go to each company and ask them to stamp it. At the end, the last day, we will make a raffle and we will pull one of those. And whoever wins will win a good prize. Just remember that. Thank you very much. We will go on a break and we will be back 3:30 sharp. Thank you very much.
Hello, hello, hello. Good.
Hello everyone and welcome back. We'll start our session. My name is Yusuf and with my colleague Mr. Sam Al-Reed will start the session. We'll begin with Brad Scott. He will speak about advanced patient monitoring and waveform analysis for the next 45 minutes. The floor is yours, Brady.
All right, everybody. Good to see you again. We have a little extra time. The last time I tried to do this talk, I was talking way too fast with so much information, so Mr. Hassan gave me a little more time, so I do appreciate that. So it's good to see everybody again. Same person, same job as I had before. So we're going to jump into the first slides about monitoring. Is the reality is that all patients are monitored. And I was just at the bedside the week before I came here, and I asked my students, I said, what's the difference in patients who are on a general care ward versus patients who are in the ICU? And, they gave me a lot of answers about sickness or acuity. So I said, well, what really is the purpose of an ICU? And they're like, what do you mean? I'm like, well, what's the purpose? Why do we have intensive care units? What do they do? And they said, well, we can put in certain kinds of lines and drains in the ICU. So, of course, what else can we do? And we kept talking, and I said, it really comes down to monitoring, right? It's the ratios that we monitor patients. It's the if you think about it, we could put an arterial line, an indwelling arterial line in any patient, but we would want to, the reason that the patient needs it is because they're very sick and we need minute to minute, second by second monitoring. So monitoring is huge. All patients have it. And even if they're not even connected to something electronic or something expensive, we're still monitoring them, which is how we begin this here. So if you think about it, your monitoring begins with observation. So I don't see Dr. Sullivan in here now. Perhaps she's getting a coffee. But I also spent a lot of time in my career in the emergency department in a trauma room. Anybody else working in the ER or trauma? Anybody in the room? A couple folks? Okay, right here. When the patient hits the door, as soon as they come in, you can automatically start to assess and almost have an opinion of what's going on before EMS even stops in the room. You can see are the paramedics, the people in the ambulance, are they bagging the patient? Are they doing CPR? Is the patient talking? Is the patient crying? Is the patient silent? Do you see difficult breathing? Do you hear stridor? All those things all that can be done immediately through observation. And so we can see so many things. Even the shades of skin can change with cyanosis or low blood pressure. So many things can be done by observation alone. And we know that oxygenation, earlier, a couple hours ago, I talked about how oxygenation and ventilation can be done non-invasive or invasively. We can draw blood gases. We can get the PaCO2, which is the gold standard for ventilation. We can get the SaO2, which is an actual measure, can be calculated, but actual measure of oxygen saturation. But we can also, and we do every day, monitor ventilation and oxygenation non-invasively. Why do we do that? Well, invasive tests are expensive, sometimes just simply unnecessary. They're painful. They can cause infection. And perhaps sometimes they don't provide us any additional information that we don't need. Right? So we can do this non-invasively, and then we also are, as RTs, are responsible for monitoring mechanics. And we're going to talk about this in some detail in a moment. And why do we monitor mechanics? Well, think about that. So mechanics sounds like a difficult concept, but it's not. We're measuring airway resistance. We're measuring compliance. This gives us some idea of what we need to do with our patients. As Tom Perino just said a few minutes ago, in an asthmatic patient, I really do need to know the peak airway pressure, and I need to know the plateau pressure to help me understand the degree of airway resistance. So if I only looked at peak pressure alone, in Tom's example, I would think 60 or 65 centimeters of water of peak pressure is really bad. But if I connect that to the patient has asthma and the plateau pressure is reasonable, all of a sudden I'm a bit less worried about a peak pressure. So we're going to talk about that in just a second as well. And then we're going to spend a little time with graphics, scalar graphics. Are my students over here again? Is this the group of students? Are we all in the same seat? Where are my students at? They all gone home? All right, I don't blame them. All the students have said, I'm out of here. How many of you, show of hands, are amazing at ventilator graphics? If you admit to being amazing, raise your hand. All right, so who's doing the, 2 people, amazing, 10 out of 10. Okay, for the rest of us who are not so amazing, ventilator graphics can be a bit intimidating. And there's also a poster up there, Hassan. There's a poster up there that says that 1.7% of respiratory therapists here in Saudi could identify all patient ventilator asynchronies. 1.7%. So you guys are the 1.7%, right? But the point of that is it's ventilator graphics can be quite complicated. There's a lot to them. We're going to talk about them today, and actually on Saturday, for the best of AARC, we're going to talk about how artificial intelligence may help us a bit with this in the future. All right, so first of all, again, as we think about our patients, we go in to see a patient. What are we looking for? You knock on the door, you introduce yourself as the respiratory therapist. We oftentimes say, hey, my name, for me, I would say, hey, my name's Brady, I'm here from respiratory care. And when I do that, I'm automatically making my assessment. I'm automatically monitoring early on. Did the patient just turn and look towards me? If they turn and look towards me, they're tracking me with their eyes, perhaps I can see that there's some degree of consciousness there, right? I may walk in and realize that they're not responding to me. Now, it doesn't always mean they're not conscious. There could be a hearing impairment or they're distracted in some other way. But keep in mind that these interactions are monitoring as well. Again, in the trauma room, my colleague over here who says she also works in the trauma room, as they always brought patients to me, and I was at the head of the bed, I would start a conversation with the patient. Hi, my name's Brady. I know you're scared. I'm here with you. Tell me about what's your name? I would have all kinds of things to say to them. While I was interested in what they had to say, I was more interested in whether or not they could hold conversation with me. Could they answer my questions? Could they track me with their eyes as we talked while the trauma surgeons and the trauma team worked to stabilize? If they stopped, if they all of a sudden started saying things that were confusing, didn't make sense in the context, or they stopped at all, that alerted me to a change in their mental status. So I teach my own students in my own program, talk to your patients when you can. Talk to them. And if things start to feel different, start to seem different, you might want to alert the team. And so we can use these scales, and we have the scales like Glasgow Coma scales and other things to try to objectify this as best as possible, to track this, to monitor it over time, whether improvement or decrease in it, so we can make some decisions of how to move forward. Again, when I'm kind of going in with this eye tracking or just the consciousness in the room, think about facial expression. Think about what facial expression tells you about the situation that you're in. Right? Imagine walking into a patient's room and they're on their phone, they're smiling, laughing at a video they see on YouTube. It hits different than a patient who looks at you scared, holding on to the bed, saying, I can't breathe, I can't breathe. It tells you so much information, right? It tells you so much information. And so, as a respiratory therapist, I know that we think about tachypnea, bradypnea, and apnea. But let's talk about monitoring respiratory rate for a second. I can't speak again for Saudi respiratory therapists, but I'm going to tell you what the American respiratory therapists do. Not just American RTs, but nurses and other clinicians. They tend to look at patients and they document a respiratory rate of 18. Surely you don't do that in here in Saudi Arabia, right? You count them for a whole minute every time, right? There's actually some data in the United States that clinicians tend to document respiratory rates like 18 or 20, like 70% of the time. That means that they walk over to the computer and they go up to the patient and they go, 18. You get 18. Oh, you get 20. You get 18. Well, it's interesting when they did this study, it was published in Chest back in 2013, I think. Only about 13.5% of the patients actually had the respiratory rate that was documented. But here's what's interesting about this number, about this concept. You know that changes in respiratory pattern is the earliest sign of basically cardiovascular failure, like a pending doom. Something bad's going to happen. It's faster than changes in heart rate. It's faster than change in blood pressure. It's the clearest indicator that something's changing, but we're not very good at monitoring it. As a matter of fact, we have a paper about this in the journal. Why? Why are we so bad at monitoring respiratory rate? Any guesses from anybody? It's easy to monitor, right? It's not. Why'd you say no? It's true, right? The reality, if you read the text and read the papers that really focus on this, the way we really should measure respiratory rate is count it for a whole minute. That's not easy when you can control it. Somebody can control the respiratory rate. They know that you're watching them, so they may start to change. Or they begin to talk halfway through it, right? All those things, you can see that. So the point of this is, while yes, tachypnea sometimes is obvious and bradypnea is obvious, I'm going to ask you to pay a little closer attention to your documentation and really think about how respiratory rate's been documented in your own hospital, because it is sensitive to a patient getting worse. Just be thoughtful about that. And I do have I co-authored a paper as part of a journal conference years ago that Dr. Hess and others put together about monitoring patients in the ICU. And the paper's called Monitoring Breathing Pattern Rate in something else. I forgot my own paper, so I'm happy to send it to you. We also know we can see patients that are pursed lip breathing or having this paradoxical effect, so sometimes that's obvious. It shows a shortness of breath, or maybe the improvement of pursed lip breathing. So when we think about monitoring, or we're using our own eyes, if we have treated a patient successfully, we can see them begin to stop doing some of these things. And obviously, again, like cyanosis that I mentioned, and diaphoresis. And so diaphoresis is important. Somebody who's sweating profusely, when you meet them, what does that mean? That could mean they're having a really hard time to breathe, right? And again, let me be clear what I'm about to say. This is not terribly scientific. I got to be careful with the people I have in the audience here. But think about this. If you take Dr. Hess's advice on how we use non-invasive ventilation, you meet a patient who's grimacing, they look like they're short of breath, they're having a hard time, they're diaphoretic, they're sweating, they're short sentences, they just look just like they're struggling, and they're saying words like, I can't breathe, help me. You put them on non-invasive ventilation, you get them titrated 10, 15 minutes, all of a sudden they complain the room is too hot. The lights are too bright. I don't like your cologne you got on. They start complaining of other things. They stop sweating. What does that mean? We're getting better, right? Where the work of breathing has at least improved. And listen, I think that means something. Those are things that we as clinicians get better at over time. So, real quick, I'm moving through the chapter that follows some of this, the stuff you have as part of this course. And one of the things we wanted to highlight here are some of the skills that we have available to us to help quantify and to help monitor and track patients. And a big one we use here is the Richmond Agitation Sedation Scale. So right here in the front are are a lot of the faculty that flew in from, some flew in from China, the Philippines, a lot from the United States. So all of us right now, because we're a bit jet lagged, it's where I'm from, is Chicago. That's 9 hours difference. I am currently at a -1, which is not fully alert, but has sustained awakening to voice, right? So Emily, right now, my colleague Emily, is looking a little -1, -2, but every time I raise my voice like this, she perks up a little bit. So I think she's also a -1. I think my first lecture this morning, she slipped into a 2, which was lightly sedated, right? But you can see how we can use this type of scale to help us understand where our patients are at and even titrate to get them to certain areas, titrate certain kinds of sedation and those things based on the clinical need. So again, I think a lot of the speakers are right here, drowsy, not fully alert, but sustained awakening to voice. All right, let's talk about pulse ox. Who's my educators in the room? My teachers, my professors, right here. Okay, we have the job of teaching students and other folks what pulse oximetry does. I argue, and also, we have to teach what it doesn't do, right? We have to teach the limitations of pulse oximetry. I think we all agree as a group of respiratory professionals, we use pulse oximetry every day. We use it all the time. But you also are like, I'm not sure I trust it. I don't know what I think about that. That doesn't align itself with what I'm seeing. I need to get a blood gas. And a lot of times that might be right. Right? We know that for a lot of patients, pulse oximetry is absolutely fine. And it absolutely tracks with what you see. Sometimes you see a patient come in, they're very short of breath, you put a pulse ox on, it's 84%, makes sense, right? Everybody has seen that before. You put them on oxygen, it improves to 94%, makes sense. Sometimes it doesn't make sense, right? Or we're not really sure if we can trust it or not. Sometimes pulse oximetry can actually be very normal, 97, 98%, but the patient appears unresponsive. Maybe even to you, breathing a lot, maybe shallow or less. Perhaps they're on supplemental oxygen, and because they're on supplemental oxygen, you know as trained RTs, I can't really use that value to determine if my patient is okay. I need more information. And we know that more information is to look at the CO2 as well. So pulse oximetry, sure, it has a place, but it is very limited in what it tells us. Right? Could you imagine if we only used pulse oximetry to run mechanical ventilators? That wouldn't work at all, right? So we have to know when to use it, when not to use it. So I want to point out here, again, for those of you, particularly for those of you that are new into the profession, there are, again, limitations here that are associated with things even like skin tone, which is a big topic of research of my own and others around the world, actually, that are trying to understand how to mitigate this issue. Some of the concerns with pulse oximetry as it relates to skin tone often been referred to race and ethnicity, but we're kind of moving away from that a bit and thinking more about the skin tone itself, is inaccuracies across skin tones. And have you ever heard of this term called occult hypoxemia? Have you ever heard of that before? Occult, O-C-C-U-L-T, occult hypoxemia. Have you ever heard of that? Okay, this is where it comes in, skin tone particularly. It's a falsely elevated pulse ox. It's higher on the monitor than it actually is. So what does that do? That doesn't mean the patient's doing better. That means the patient could actually be doing worse than you think, but we go ahead and discharge them home, right? Think about this. If it's a 4 or 5% swing in accuracy, if I said this to you, the patient's satting 95%, What do you think about sending them home? A lot of us will go, okay. I don't hate that number. If I said 96, you say, yeah. 95, you're like, okay. What if I said this? The patient's satting 90%. Are you ready to send them home? Everybody goes, ugh, I'm not sure. Well, in occult hypoxemia, those individuals that's the ones who might actually have on the monitor a saturation that's 95%, but it's actually 90. Do you see where the problem there is? That's a real issue, right? It's a real issue. So we have to think about that, and we're trying to better understand it. A lot of the data on occult hypoxemia and the inaccuracies of pulse oximetry across race and ethnicity and these things are retrospective in nature. They deserve a lot more prospectively designed research from us, and we are doing that actively now. But it will take a while to understand. The reality is sometimes even in lower oxygen states, pulse oximetry is more inaccurate. The reality of studying it, for those PhDs in the room, we don't allow people to stay hypoxemic. So studying that prospectively is very difficult because we treat hypoxemia. So it's pretty rare that we have somebody who's hypoxemic and we can't correct it, right? I mean, we have a lot of ways to correct hypoxemia. So this issue is harder to study in real time than you would think. It's not so easy to get to the bottom of. Lots of pulse oximeters on the monitor. Again, I can only speak to my experience in the United States. We have the hospital ones, we have the hospital grades, but you can walk right into a pharmacy in the U.S. and pick one up. I have no idea if they're of any quality, to be honest with you. Maybe they are. I know a lot of people have been testing them. There are some people looking at them. Some cell phones have pulse oximetry capabilities. My little health monitor here that has been telling me for 3 days that I'm not sleeping well. My health monitor's like, what's going on, man? It monitors my pulse ox all the time. I have no idea how accurate it is. And I think that's a little bit of a danger that we have with some of these a lot of these devices that are entering the market. So I do believe, in some ways, it's our responsibility to test these things. We published a paper a few years ago looking at Samsung versus Apple pulse oxes. And, it was, in some ways, yeah, it was fine. Actually, in some cases, it was okay, but not enough. There were times where the Samsung pulse ox, for example, wouldn't even read the pulse ox, wouldn't even give a value, which I almost appreciate it not giving me a value versus giving me an incorrect one. Right? He just said blank versus giving something. So we have a way to go with pulse oximetry. Again, I'm not saying anything negative about it, but we have to understand its limitations. Some of the devices have not been tested rigorously. And as a matter of fact, I would argue that even FDA-approved devices probably could use more hospital-level testing rather than healthy volunteer-type testing that we are seeing. And we definitely have written some stuff in the literature on that one as well. So transcutaneous monitoring gives us the ability to measure PaO2 and PaCO2, non-invasively, where we can put electrodes on the skin, various parts. I know that in some areas, I believe, Emily, if I'm right, that we are using this probably more. I don't know how often you use it, Emily, in infants and children, transcutaneous. In the adult world, it's pretty rare, at least where I'm at. And I don't see it a whole lot in the literature. But I can tell you, we have used it before for trending values on patients that we are very concerned about their ventilation, when we correlate kind of the CO2 values with the CO2 and on a blood gas versus transcutaneous. I don't work in neopeds. Emily Lamarina does, and she's a good friend of mine, and she's the peds expert, and I'm sure she's happy to answer all of your questions on that one. In-tidal CO2 monitoring, however, I have done this quite a bit. And I will tell you, when I add pulse oximetry to in-tidal, I feel better. What about you? I feel a lot better when I can add those two components together. So, for example, imagine a patient who's receiving procedural sedation, maybe in their emergency room. Maybe they have a broken arm or a broken whatever, and it's a very quick procedure. If I can say, okay, well, all we have to do is put the person's shoulder back into place, and we're going to sedate them a little bit, if I can take pulse ox plus end-tidal, I feel a lot better about how I'm monitoring that patient, right? Because I can see respiratory rate plotted, I can see how there's changes in end-tidal, plus I can see pulse oximetry. Again, remember that pulse oximetry doesn't tell you if the patient's breathing well, right? It doesn't tell you that. It says this is what your oxygen level is. It doesn't say anything about your CO2 level. And as a matter of fact, most pulse oximetry doesn't tell you what is attached to hemoglobin. It just says something is. Could be carbon monoxide, right? So, but when you add these two things together, you can get somewhere with it. So capnography gives us the ability to plot, the CO2 on exhalation, and the area that we're looking for end-tidal is where it is this area of E. But what I love about it is, again, my background's in the emergency room. You can tell all my examples, I'm always talking about being in the ER. But when somebody would come in, they would have their shoulder out. The ER doc would be like, I need to sedate them, put them on end-tidal, put them on a pulse ox. I could watch their respiratory rate. I could watch it better than my eyes. If the reality is this has been studied. End-tidal is better than us looking at the chest in terms of plotting breathing. So I can see the breath. I can see the pulse ox. I feel good that I can give feedback back to the physician about the patient's condition. Do I need to intervene, or are they okay on their own? So end-tidal gives us a lot of information. And we have these devices that can kind of give us everything all in one. You get end-tidal, you get the respiratory rate from the end-tidal, you can track the value itself, the pulse ox, we can see all that stuff, and we can monitor our patients more safely. Anybody use one of these devices, like during cardiac arrest? Like during cardiac arrest, you might use some sort of end-tidal CO2 device to determine return of spontaneous circulation, or the adequacy of chest compressions, and use that environment some too. And Dr. Sullivan, thank you for telling me P before Y in the alphabet. I've learned now that it goes from purple to yellow. I never knew that before, but I just knew it went from purple to yellow, but I didn't know there was the P and the Y, the whole thing. I'm going to use it in my classroom. But we also have this to help determine if, these are really good about helping determine if the endotracheal tube is in the right place, right? The waveform capnography does the same thing. That would show you can use help that to determine if you're in the trachea versus the esophagus. This can give you also a value that might help you understand if you're in the esophagus, and this helps you determine as well. So very useful, also limited. It's not perfect. It adds up to seeing the tube go through the vocal cords, to seeing the end-tidal change, to hearing no sounds over the gut, the gastric region, hearing breath sounds where you're supposed to hear them. Add that all up, and yes, the tube's in the right place. Add it all together, right? End-tidal's not perfect. These things sit on the shelves for a long time. Maybe it doesn't work. Perhaps there's a low perfusion state. Even if you do have the tube in the right place, you don't get the end-tidal you think because you're not perfused well. So these have limitations. So again, understanding how to use these devices is the most important thing. All of these devices are useful. Pulse oximetry. Gosh, if I had $1, American dollar, US dollar for every time I put a pulse ox on, I would be a billionaire, right? But it's limited. End-tidal's the same way. It's limited. It has its limitations. It doesn't always tell you what you want it to know or what you want it to tell you. Okay, let's talk about mechanics. So Tom hit this pretty good. So that was a nice tee up for me. So mechanics for us are measured or calculated values that we're looking at during mechanical ventilation. This is our bread and butter, is what we do. Right? What we're trying to understand is how stiff are the lungs, how stiff is the chest wall, how much resistance to breath are we seeing? Is it improving? Is it getting worse? Is it getting better? And as RTs, we get called in the room for the volume control people when we get called to the room because the peak pressure went up. I came from a hospital that was a pressure control hospital. I got called when the tidal volumes went down. Means the same thing. But my job was to determine, is it because the patient is biting the tube? Is that airway resistance? Or is there a pneumothorax? Is it bronchospasm? Or is it mucus plugging? Those type of things are what I have to figure out. So I have to learn, I have to understand how to really appreciate what lung mechanics tell me. So it's really beyond going to the bedside and just going, well, let me suction first, go through this, right? Your graphics can tell you a lot about what's going on and, really helps you get to the bottom of the issue. And here's a classic example. And so if I just put this on the screen, and for somebody in the room goes, I have no idea what I'm looking at, that's okay. That's why you're here. Right, Hassan? This is why we do this course, right? This is the point. So let's get oriented. Here on the y-axis, this is pressure at the airway opening, and that's time on the x-axis. So we're walking, pressure is going up over time until we get right here, and then we say pause flow, and we drop down to the plateau. What does that tell us? So we know that this peak pressure here, as Tom, again, so correctly said, this is giving us some idea of resistance because it's also showing it's a dynamic measure. There's flow involved, right? And this peak pressure is kind of telling us, well, the lungs were still hard to get open, but there's also some resistance. But this plateau pressure is a static measure. We just remove the flow. So we know that the difference that exists between peak pressures and plateau pressures are what? Resistance, that's correct. So if those two numbers stay together, even if they go up, this is a compliance problem. If you can say peak and plateau are kind of doing this together, that's probably more of an issue related to compliance. However, if my plateau stays like this and peak goes up really high, that's a resistance issue. Right? So peak and plateau are very important. So when you come on your shift, I think it's important for you to go to the bedside and understand your patient's lung mechanics. Because at 8 o'clock in the morning, if your lung mechanics are one thing, and at 2 o'clock in the day, they're another, then you can report to the physician, hey, you know what, this morning, our plateau pressure was 18, now it's 26. Something's changing. Something's happening. Maybe we need a chest film. Maybe there's a lot of fluid or whatever it is, but it helps you intervene early as you're monitoring these things. All right? In terms of some values for you, remember that static, so this is a no-flow lung compliance, here is milliliters per centimeters of water. That sounds confusing. Let me make it clean. How many milliliters, if you were to turn the knob, boom, 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 like that, for every one turn in pressure, how many mLs do you get? Basically is what that means, right? So milliliters per centimeter of water. So your normal compliance is about 100 milliliters per centimeter of water on an unintubated patient. If on resistance, that's different. Now so you're going to take you back to school. Remember, what's the calculation for airway resistance? Peak minus plat over flow. So it's taking into account the flow rate, and that's in centimeters of water per liter per second, right? The normal value here is 0.6 to 2.4 centimeters of water per liter per second. That's important to look at that value, right? And sometimes it can be as high on almost normally, if you will, up to 10 when breathing through an endotracheal tube. Okay, what I'm about to do is I'm going to scare you with some graphics. I only had 2 people in the room that said they were experts. And Tom didn't even raise his hand because he's afraid I'm going to ask him something hard. I would say I've been doing this for 25 years, and I teach this to physicians. I would say I'm pretty good. There are times in the ICU when I get called over and they're like, Dr. Scott, can you come look at this? I'm like, I hope I can get this one right, because sometimes they're complicated and they're hard to understand, right? All right, so what I'm going to do is I'm going to put some of these up on the screen, and I'm going to say, don't freak out, for whoever just freaked out when they said, please don't show me that, please don't ask me a question. What I'm going to do is I'm going to have you reorient yourself real fast. I'm going to tell you that doesn't look like graphics I ever see. It's not in the order I'm used to. I'm used to, in my hospital, we always order our graphics, pressure, flow, and volume. This example is not that. When I first looked at the textbook on these slides, I looked at them and I went like this. What am I seeing? Because in my bias or my mind, I was looking at pressure, flow, and volume. Did anybody else do that? Did anybody else do that too? I see some heads. Okay, so let me go ahead and try to make this a little easier for those of you that are still learning graphics. Let's orient ourselves. What we see here, this one, this is volume. That's 0, that goes up to 500 in milliliters. This is flow, and that's actually in milliliters per second. I'm used to seeing it in liters per minute. I used ChatGPT earlier today to tell me what that was. That's about 26 liters per minute. Because I did not want to do that math in my head. I already told you I'm not good at math. And then pressure on the bottom, which is different orientation than the hospital in which I work. So you can see that of all the years of experience I have, I still had to take a look for a second and go, what is this I'm staring at? And once I did that, now it begins to make sense. Because I'm thinking, okay, I got all of these things plotted over time. Okay, so that means that the breath is starting here. And as volume goes in, I know you can't really see that, but I'm looking at the top green. But as volume goes in over time, so does pressure. And the flow is going in. And we get to this point, draw a straight line, exhalation. Right? It's all moving at the same time. So it begins to tell you a story at the same time. And then I would say to you as we go to the workshops and this gets worked on, then it's important to know what mode am I in? Because it helps me understand, all right, so I must be in, for example, I must be in a volume targeted mode right now. I must be in it. Why? Anybody want to tell me why I must be in a volume targeted mode right now? Good for you. The waveforms are telling us the mode, right? Because if this were in a pressure mode, it would be square. It's not. It's not a square waveform. It's accelerating as volume goes up. It's like taking an empty balloon, adding volume to it over time, pressure's going up. And this empty balloon is being filled up by a flow that's constant, which also only exists in volume control. Make sense? So did you see how we did that? So we know our modes, we know what it's supposed to look like. So I would argue that when somebody has some asynchronies, we can watch what it does. We think about the mode, what is it doing, what is it supposed to look like, and then we can solve the problem, right? Or in 2 years from now, we let AI tell us what to do. Hold on long enough, and AI will be telling us how to fix this. Now, in pressure control, I just realized it said volume control at the top. So you're like, well, Brady, it's volume control because it says it at the top of the screen. But in pressure control, look, if I was doing this again, pressure at the volume, volume at top, flow, pressure, and pressure scalars are supposed to be square. You would argue with me probably, that's not square. It's kind of square. It's square-ish. Why is it square-ish? Why is it leaning? Your textbook, Dr. Hess's textbook says a pressure waveform is supposed to be square. Why isn't it? Why is it like that? Rise time. Yeah, the rise time, it's a little bit slow, right? So you're spending a certain amount of time here. Look at this. I would argue that right there is when it actually levels off. You're actually spending a big percent of that breath rising to pressure. Right? Do you see it? It tells you everything you need to know. The graphics will tell you everything. And I see a corresponding decelerating waveform pattern because guess what you can't do? You can't change it. Right? Decelerating waveform patterns always exist in pressure modes because that's just how physics works when two pressures come together. Oh, I'm running out of time. Hassan, I still didn't have enough time. How much time do I have? 2 minutes? Okay, I'm going to speed up. Ready? I am going to agree with Tom Perino. I have no idea why we need to know this mode in adults, so we'll just move on. But I wanted to point out this one. This one's targeting people that are new. You put a patient in volume control ventilator. The patient wakes up. They start fighting the ventilator. Here's what really happens. They get a little uncomfortable. The nurse calls you and says, he's moving around the bed, not doing well on the ventilator, and they're reaching for the propofol. They're reaching for the Versed, or they're reaching for the pain medicine, and you say, stop. Let me evaluate it first. So you realize that we're probably in some sort of a volume mode. You see this graphic from the beginning up top in the middle, and then you see that scoop out. When does a pressure waveform ever scoop itself out? What's that? What are you saying? Okay, flow hunger, right. Good. Right, because guess what you did in volume control? You set the flow. If you set it, I can argue with it when I wake up. I can disagree with your setting. This patient wakes up, the flow doesn't change, the flow is not enough for that patient, but you don't see that in the flow waveform, you see that in the pressure waveform. That's where you see it, right? The patient pulls the pressure down, that's where you see it. So again, flow asynchrony is found in the pressure waveform, right? You set the flow so it doesn't change there, all right? Real quick, I could probably have, 1 minute? 10 seconds? Let's wrap up right here, all right? Sorry, I get passionate about this topic. I still didn't have enough time, Hassan. Okay, auto PEEP, real quick. When you're looking at a ventilator, if we're wondering if the patient is air trapping, where do we look? Sometimes when people hear the word auto PEEP, they go towards the pressure, which makes sense. I get that. But think about what's happening when a patient doesn't have enough time to exhale based on their lung mechanics. As they're breathing out, they take a breath back in. That amount of gas becomes trapped air and pressure, but you see that in the flow scalar. Here's the breath, that's in, this is out. What you want is this. You want to come back to baseline, which is 0. What you got is not back to baseline. That's air trapping. All right? I know this will be covered probably some more tomorrow, but I am done. You don't have to. Thanks, everybody, for your time.
Thank you, Professor Brady, for your interesting presentation. And we would like to introduce again Dr. Dean Hess. He's going to talk about lung protective ventilation approaches in various diseases.
Well, good afternoon again. I realize that Thomas Perino and I are the only ones who are standing between you and the end of the day. So we will try to keep that in mind with these last couple of talks. So I'll be talking about lung protective ventilation over the next 30 minutes and be touching on a number of topics related to this. Some of them you've heard already a bit from Brady and from Thomas earlier, and I'll give you my spin on a few of these things. So what I'm going to be talking about is setting the ventilator in the context of preventing injury to the patient's lungs, avoiding injury or lung protective ventilation. So let's first talk a little bit about the tidal volume and the rate and the inspiratory time that we will set on the ventilator. So let's think about this in the context of initiation of mechanical ventilation. And I would submit to you that typically we should start out by targeting a tidal volume of 6 mLs per kilogram of predicted body weight. And your predicted body weight depends upon how tall you are, as you can see from the equations on the slide. So you get more tidal volume for being tall You do not get more tidal volume for being fat. So we need to set the ventilator then based upon the predicted body weight, how tall your patient is. We want to maintain a target plateau pressure of less than 30 centimeters of water to avoid alveolar overdistension. We want to set the rate for an acceptable minute ventilation. That will often be around 20 to 25 breaths per minute, which we will then adjust according to the arterial PCO2. I can tell you that 25 years ago, when I started implementing 6 ml per kilogram tidal volumes into my practice, a mistake that I made commonly was not turning up the respiratory rate sufficiently, and had a lot of hypercarbic patients back in the day. And we want to keep the inspiratory time at 1.5 seconds or less. A longer inspiratory time will shorten the expiratory time. That will lead to air trapping and auto PEEP, as Brady was talking about at the end of his presentation. Well, what about FiO2 and PEEP? Well, often we will set the FiO2 at 1 or 100% oxygen when we initiate mechanical ventilation, and then we adjust the FiO2 according to the patient's oxygen saturation measured by pulse oximetry. And I think a saturation target of around 94 to 98 is probably sufficient for most patients, maybe a little bit lower for patients with COPD. And in the ARSNet study, which established the evidence for 6 mLs per kilogram of tidal volume, they used an oxygen saturation range of 88 to 95%, which is a PO2 of about 55 to 80. I would submit to you that almost universally we should start with some low level of PEEP, like 5 centimeters of water. And patients with ARDS, we will need higher levels of PEEP to maintain alveolar recruitment. I'll talk a little bit more about that in a few minutes. Thomas Perino is going to talk about that for a full talk on Saturday. And PEEP might also be useful in patients who are having triggering issues due to auto PEEP, because the PEEP on the ventilator will counterbalance auto PEEP, and that will make a patient, such as a patient with flow limitation and COPD, better able to trigger the ventilator. Thomas talked a little bit about this in his presentation, volume control versus pressure control. Point I'll make from this slide is that there are advantages and disadvantages of both. And I would argue that in the hands of a skilled respiratory therapist, you could use either volume control or pressure control in many patients. And the approach that you choose, the one approach that you choose, will often be based upon your personal bias, the preferences of the unit where you work, and so forth. So some units always start on volume control, some always start on pressure control. I can't argue that one is clearly better than the other. And where the real difference comes into play, and we heard this from both Thomas and Brady, is if the patient begins active breathing. So if the patient begins spontaneously breathing and triggering the ventilator, with volume control ventilation, if the patient makes a strong inspiratory effort, a lot of respiratory muscle pressure, the tidal volume won't change on volume control. So irregardless of how hard the patient breathes in on volume control, the tidal volume will remain constant. And that might be a good thing. However, the downside is, and Brady pointed this out, look at the airway pressure waveform. The airway pressure waveform gets scooped out, and what that means is that the work is being transferred from the ventilator to the patient. So in the patient's making a strong effort on volume control ventilation, the ventilator is providing proportionally less support for the patient. Now you might say, and you heard Thomas say earlier in his presentation, well, I would switch the patient to pressure control, because if I switch the patient to pressure control, then the ventilator will deliver the flow that the patient wants. And that is absolutely correct. But flow is volume. And as you can see on this waveform, when the patient makes a stronger inspiratory effort, there is more volume that is delivered to the patient. And if that volume is 15 mLs per kilogram, that is not lung protective ventilation. And I'll come back to a concept in a few minutes of patient-induced lung injury and show you that if a patient makes a strong inspiratory effort and that dries up the tidal volume as shown in this slide, that might be injurious to the lungs. Thomas spent a lot of time talking about pressure support, which is good because that means I don't have to spend very much time talking about it. And he talked about with pressure support, every breath is triggered by the patient. It's absolutely correct. He talked about how there may be better patient-ventilator interaction, but then he also correctly said that we can have asynchrony on pressure support, and I agree with that as well. And Thomas introduced the concept that with pressure support ventilation, we can individualize the ventilator settings to the patient by being able to control the rise time to better meet the patient's inspiratory flow demand, and by varying the cycle flow so that we can adjust the inspiratory time to better meet the inspiratory time of the patient's brain center, of the respiratory center. Thomas already talked about this, so the patient can trigger the ventilator, or the ventilator can trigger on its own. So if our patient is completely paralyzed, then the ventilator triggers the breath based upon time. So we have the rate set on 20 breaths per minute. Every 3 seconds, the ventilator turns on and delivers a breath. Or the patient can trigger the breath because if the patient's respiratory center is active and the patient's neuromuscular apparatus is intact, the patient can generate an effort at 1 second or 1.5 seconds and trigger the breath. The ventilator recognizes usually patient effort by looking at either pressure or flow changes at the proximal airway. If you have NAVA available on your ventilator, then the neural activity or the activity of the electrical activity of the diaphragm can trigger the ventilator, but usually for most of us, it will be either a change in pressure or a change in flow. Years ago, it made a difference. So back in the early 1990s, I was doing bench studies and publishing them and showing how flow triggering was superior to pressure triggering. And that idea has persisted to this day, but the reality is that with modern ventilators, it's hard to show much difference between pressure and flow triggering. So if there's a problem with the pressure or the flow trigger, it's usually our fault, not the ventilator's fault. It's because we have not set the sensitivity appropriately. Brady talked a bit about this. I'm going to talk about it more within the context of lung protective ventilation. So what we're looking at here is constant flow, volume-controlled ventilation. So you see that the flow waveform is a rectangle. I like to call this rectangular flow waveform rather than a square waveform because it's not always square. It's a rectangle in this case. And as you can see, with a constant flow applied to the airway, there's a constant increase in pressure over time till we reach the peak inspiratory pressure. And then if we do an end inspiratory breath hold, we do an end inspiratory pause, usually by pressing a button on the ventilator, or we can take the approach that Thomas uses and just set a little bit of plateau time on every breath, a little bit of pause time on every breath. During that pause at the end of inspiration, the pressure drops from the peak pressure to the plateau pressure, and then at the end of the pause drops back down to peak. The significance of the plateau pressure is that the plateau pressure is the peak alveolar pressure. And we want to maintain that pressure less than 30 centimeters of water because usually, but not always, as I'll show you in a minute, a peak pressure greater than 30 implies alveolar overdistension and the risk for ventilator-induced lung injury. As Brady correctly said, the difference between the PIP and the plateau is determined by resistance and flow. The difference between plateau and PEEP is determined by compliance and tidal volume. And that difference between plateau pressure and PEEP is what we now call the driving pressure, or the delta P. And it has been shown that it is very important to monitor the driving pressure as an indicator of the potential for ventilator-induced lung injury. So we want to keep that plateau pressure, the difference between, or we want to keep the driving pressure, that difference between plateau pressure and PEEP, less than 50 centimeters of water. So 2 take-home messages from this slide. Measure the plateau pressure, keep it less than 30 centimeters of water, calculate the driving pressure, keep it less than 15 centimeters of water to decrease the risk of ventilator-induced lung injury. And this slide says in writing exactly what I just said a minute ago. Now, there are times where we may break the rules, and that's okay. So where we may break the rules, and that's okay, is in a patient who has a high pleural pressure, a high pressure between the lungs and the chest wall. And how might that occur? Well, that might occur because the patient has abdominal hypertension, a distended abdomen. Or it might occur because the patient is morbidly obese. Or it may occur because the patient has chest wall burns. And in that case, there is an increase in pleural pressure, which has a collapsing effect on the lungs. So if your patient has massive ascites, for example, large intra-abdominal pressure, all that pressure is pushing up on the thorax and increasing the intrapleural pressure, and that pressure is a collapsing effect on the lungs. So then what do we need to do? We need to apply more PEEP to the ventilator to counteract that collapsing effect of the high pleural pressure. And what happens if we turn up the PEEP to counterbalance the collapsing effect? The plateau pressure goes up. And that may be okay in this setting because the stiff chest wall is counteracting the hyperinflation effects of the high plateau pressure. So we may have a patient with morbid obesity, we may have a plateau pressure of 40 or 45 centimeters of water, and a tidal volume might be 4 mLs per kilogram, and the PEEP may be 25 centimeters or 30 centimeters of water, but that high plateau pressure might be safe in that setting. And if you're not sure, that's where I would put in an esophageal balloon catheter, and that's a topic for another day. So let's think about the reverse of that. Let's think about what happens if the pleural pressures go down. Well, how will the pleural pressures go down? The pleural pressure will go down as a result of active inspiratory efforts of the patient. So if I go like this, I'm dropping my pleural pressure. That's how I'm getting more flow and volume into the lungs. And if the patient's making strong, active breathing efforts, the drop in the pleural pressure adds to the pressure that we apply on the ventilator. It adds to the level of pressure support when we think about distending pressures. So if the alveolar pressure or the plateau pressure is 15 centimeters of water, but the patient's dropping their pleural pressure by 15 centimeters of water, the distending pressure is 30. So this brings about the concept of patient self-inflicted lung injury. And what that means is that a patient may damage their own lungs by taking strong inspiratory efforts while the ventilator is delivering the breath. So the ventilator may only be applying, in this case, 20 centimeters of water to the airway, but if the patient's dropping their pleural pressure by 18 or 20 centimeters of water, the distending pressure across the lung may be injurious. So then we can get ventilator-induced lung injury due to hyperinflation by the ventilator pushing too much breath in, or by the ventilator only pushing a little bit, but the patient pulling a lot. So think about that then. The next time you see a patient on pressure support, and the pressure support's on 10, you think, well, that pressure surely can't be injurious, but the tidal volume is 12 mLs per kilogram because of the active breathing efforts of the patient's self-inflicted lung injury. So we don't want to allow our patients to be able to harm themselves. And sometimes it may be appropriate to provide some sedation to blunt the respiratory drive, to prevent the patient's strong inspiratory efforts from injuring their lungs. There are a variety of ways that we can monitor this at the bedside. We could put in an esophageal balloon catheter to monitor this, which I've done many times in my practice. Not going to talk about that this afternoon. There are some things we can look at on ventilator graphics. So on pressure support, we can do an end inspiratory pause and measure plateau. And if the plateau pressure bounces up, as we can see on this slide, that indicates that the patient is making an active inspiratory effort, adding to the pressure applied by the ventilator. I don't have a slide to show this, but we can do end expiratory pauses on the ventilator, and we can actually measure the amount of pressure that the respiratory muscles are generating. Or on pressure support, you can look at the shape of the flow waveform, and what normally should happen during pressure support is you see this actually upward curvature on the flow waveform. If you look at the flow waveform during pressure support and you see this downward curvature, that indicates that the patient's making a strong inspiratory effort, and that has been recently introduced into the literature called the flow index. And we had a paper in Respiratory Care about 2 months ago about the flow index, and it's been published elsewhere in the critical care literature. So the flow index during pressure support may be a way of assessing how much effort the patient is making and the risk for patient self-inflicted lung injury. So what about auto-PEEP? So Brady talked a little bit about auto-PEEP, and he talked about how you might suspect auto-PEEP if the flow does not go back to zero during exhalation. We can see that here. We can measure the amount of auto-PEEP by doing an end expiratory breath hold. So we do an end inspiratory breath hold to measure the alveolar pressure at the end of inspiration. We do an end expiratory breath hold to measure the alveolar pressure at the end of exhalation. And I can't reach up here far enough to point, but what should happen is as we do the end expiratory breath hold, the pressure should stay right at the level of set PEEP. If the pressure bounces up to an alveolar pressure greater than the level of set PEEP, that difference is the amount of auto-PEEP. So if you do an end expiratory breath hold and you measure a pressure of 15 centimeters of water, and the PEEP on the ventilator is set at 5 centimeters of water, that means there's 10 centimeters of water of auto-PEEP. So how can that happen? Well, there are several ways that can happen. Maybe you set the expiratory time too short. Maybe the patient has a high minute ventilation, high rate or a high tidal volume. Or perhaps the most common way this occurs is if the patient has a high airways resistance, such as a patient with severe COPD or asthma. Why do we care? Well, if the patient develops more auto-PEEP, that will drive up the plateau pressure. And that will cause alveolar overdistension and the risk of lung injury. So think about that patient who gets admitted to your ICU, severe COPD or severe asthma, and you measure their auto-PEEP and they have 15 or 20 centimeters of auto-PEEP, and then you look at their chest x-ray, and what does their chest x-ray look like? They are massively hyperinflated. Their diaphragms are way down and flattened as a result of the alveolar overdistension that occurs when the ventilator pushes a tidal volume in on top of that trapped gas. It also makes it more difficult for the patient to trigger the ventilator. So if your patient has an auto-PEEP of 15 centimeters of water, in order to trigger the ventilator, the patient needs to make an effort of over 15 centimeters of water before the pressure or flow changes at the proximal airway to trigger the ventilator. So you see that in the ICU, you see your patient with acute asthma who's intubated, and you look at the patient, and the patient's breathing 30 times per minute, and you look at the ventilator or you listen to the ventilator's only delivering 15 or 20 breaths per minute. Missed triggers, which is extremely anxiety-provoking for patients. Can you imagine trying to take a breath and the ventilator just sits there idle because it doesn't recognize your effort? So a first approach to that, in my practice, would be to turn up the level of PEEP. Because if you turn up the PEEP, that will counterbalance the auto PEEP, make it easier for the patient to trigger the ventilator. And if you've ever done this, sometimes it can be very impressive. So the patient is using their accessory muscles, eyeballs bugging out of their head, perspiration on their forehead, and a lot of missed breaths because of auto PEEP. And then you turn up the PEEP slowly, and you reach a point at which the patient becomes synchronous to the ventilator, and immediately the patient looks better. And it doesn't require any sedation. So you don't need any dexmedetomidine, you don't need any propofol, you can do it just by adjusting the ventilator. So a little bit about PEEP for lung protection. Thomas has a whole lecture on this on Saturday. I'm not going to say a lot about it. I'm going to have you come back and listen to him. So with ARDS, there is lung injury due to repetitive opening and closing of alveoli. So during exhalation, the alveolus closes, then the ventilator delivers the breath, and it pops back open, opens and closes. It's very injurious to the alveoli, very injurious to the lungs. So how do we avoid that opening and closing injury? Well, we apply PEEP to stabilize the alveolus during exhalation so it remains open. And that's what we're trying to achieve with PEEP during ARDS. But the problem is it's a two-edged sword because we may turn up the PEEP and get much better alveolar stabilization, but we drive up the plateau pressure so that the benefit of the PEEP maintaining alveolar stability is counterbalanced by the overdistension injury. So we need to then think about, as we're titrating PEEP, what's happening to the end inspiratory pressure or what's happening to the plateau pressure. And I would submit to you turning up the PEEP only to have the plateau pressure get driven up to 35 or 40 centimeters of water is not helpful for your patient. So there are a lot of different ways to set PEEP. Thomas is going to talk about those on Saturday. I only put one slide in about this. Thomas is going to talk about personalized setting of PEEP. He, I think, is going to talk mostly about personalized setting of PEEP as it relates to lung mechanics. This is a personalized approach to setting PEEP based upon oxygenation. And this is the approach that has been used in all of the ARSNet studies. The use of a PEEP FiO2 table, where what one does is they find the combination of PEEP and FiO2 that maintains an adequate oxygen saturation, 88 to 95%, does not allow the plateau pressure to go over 30, and the low PEEP table you might use in a patient with mild ARDS. In a patient with moderate or severe ARDS, you might use the more aggressive higher PEEP table in the bottom. This has been commonly used in many studies over the years. It's not the only way, and Thomas will show you other ways on Saturday, I'm sure, and he might tell you not to use this approach, so listen to him and not to me. But I would argue that this approach can be very useful at the bedside. When we are thinking about the ventilator injuring the lungs, we also need to think about diaphragm protective ventilation. And it's become increasingly appreciated just over the last 10 years or so that inactivity of the diaphragm is bad. We've known that for many years, but excessive activity of the diaphragm is bad as well. So here we have to, again, find a happy medium. We have to balance the support applied to the ventilator so that hopefully it's not too much support, so we get atrophy of respiratory muscles, but also not so little support so that there's injury to the muscle as a result of excessive activity. And there's a lot of active research which is currently going on related to diaphragm protective ventilation and how we can set the ventilator thinking about not just how we protect the lungs, but also how we protect the respiratory muscles. Thomas also talked, and Brady talked a little bit about asynchrony. I think, Tom, you have a lecture about this on Saturday, so that takes me off the hook. I don't have to talk about it much here, but we need to pay attention to the interaction between the patient and the ventilator. So what we want is we want to have a good interaction between what the brainstem is saying and what the ventilator is doing, or how the ventilator is responding. So brainstem output to ventilator response. So more, you can come back and hear Thomas talk about that on Saturday. How much? 2 minutes? Good. I think I have about 2 slides to go. So we also want to think about oxygen toxicity, and I'll get right to the bottom point here, is that hyperoxemia should be avoided. This is a little bit controversial in the literature, but I don't see any reason why we need to target on most patients, unless they have carbon monoxide poisoning, a saturation of greater than 98% and a PO2 of greater than 100 millimeters of mercury. We can also get hemodynamic compromise from the ventilator, so the positive intrathoracic pressure can affect both preload and afterload and arterial blood pressure. But I also wanted to point out on this slide that sometimes the positive pressure from the ventilator is beneficial. So in the case of fluid overload or left heart failure, the positive pressure can actually assist with preload and afterload. In fact, that's why we use CPAP and non-invasive ventilation in patients with acute cardiogenic pulmonary edema. So I think in the interest of time, I'm not going to read all of these summary bullets on this slide and this slide. It's in your textbook chapter. You can read it on your own. I'll try to stay on time, and thank you very much for your attention.
Thank you very much. Now we'll move on to the last talk of the day, Liberation from Mechanical Ventilation with Thomas Periano.
All right. Thank you so much. All right, I come between you and being finished, so let's get started and get right down to business. I have nothing to clear for this presentation. The objectives are in the chapter, so I won't read these line by line. I'll just get right into it so we can be finished for the day. Now, in terms of mechanical ventilation, there really are 3 main goals. When someone first gets intubated, probably the most important thing is safety. You want to make sure that you are providing safe mechanical ventilation, particularly when patients are not breathing. You have full control. You want to make sure, as Dean so nicely pointed out, you want to make sure you give safe tidal volumes, monitor safe pressures, etc. But then once the patients wake up, you want them to be comfortable. And then finally, hopefully, the period of comfort is short and liberation, which is the final stage, is happening rapidly. So the ultimate goal of mechanical ventilation is not to be on a ventilator. Right? We want them to be off the ventilator. And delaying this, of course, will lead to poor patient outcomes, poor quality of life, patients spending days in the ICU, lying in a bed, etc. This can be detrimental to not just their physical body, but also their mind, and with delirium, etc. So we need to identify the best time to liberate our patients, and we need to do it as quickly as possible. But as Dean also pointed out, in some patients, the waking them up and allowing them to breathe sometimes can cause additional issues, and then we may need to backpedal and reventilate. So in terms of assessing readiness to be liberated from mechanical ventilation, the first step, of course, is resolution of why they got intubated in the first place. If they got intubated for a severe pneumonia yesterday, chances are they still have severe pneumonia today. So we need to resolve these issues first. We can use clinical metrics to assess readiness. Now, many measurements that we've done over the years have sort of fallen out of favor, particularly things like maximum inspiratory pressure, et cetera. It's still sometimes used in very challenging or difficult to wean patients, but the P0.1 is a readily available tool for monitoring patient patient drive at the bedside, and it has been, in a recent study, was actually shown to be predictive of patients who will sort of revert back onto full ventilation. So you've transitioned them onto a support mode, and they are breathing very heavily, they have a very high drive, and then what's happening is they essentially end up failing their support or their comfort mode of ventilation, and then they get reverted back to full ventilation. So it is a useful tool. Probably the most common tool for assessing readiness for a spontaneous breathing trial is the Rapid Shallow Breathing Index, which is just respiratory rate divided by tidal volume, and a value of less than or equal to 105 is a very common limit. If it's less than that, essentially this means go ahead and do a spontaneous breathing trial. You could do a spontaneous breathing trial regardless of your RSBI, but you are going to want to monitor patients who fail that RSBI very closely, as they likely will not tolerate it. It's also important that the RSBI that was originally described was a measure done with no support from the ventilator. So if you are doing an RSBI, if your patient's already failing an RSBI while on pressure support of any level whatsoever, they're probably not going to be successful in a true RSBI, which is removing the support. So spontaneous breathing trials is how we assess patients for liberation from the ventilator. They should be done routinely, and they should last, the recommendations are 30 minutes to 120 minutes, so 2 hours. I think we've established in the literature over the years that up to 1 hour is sufficient. If we're still making patients breathe 2 hours on a spontaneous breathing trial, it's really unnecessary. 30 minutes to 1 hour should be sufficient. Again, I've already mentioned that we should have resolution of the reason why they were in respiratory failure to begin with. We have to assess their hemodynamic stability. If they are on a little bit of pressors, that's usually okay. But if they're on a lot of pressors, this is obviously a contraindication that they are still in an active phase of illness and hopefully recovery. PEEP of 5 to 8, I've seen protocols where the criteria for doing an SBT is even a PEEP of 10, meaning you can move forward from that even if it's at 10, but generally 5 to 8 is acceptable. FiO2 of 50 or less. Essentially, if your patient's still requiring 60, 70, 80% FiO2, unless they have a chronic lung condition that this is maybe expected of them, this does indicate that perhaps they're not ready to be removed from support. So in terms of SBT trials, there are a number of different methods. I have my own bias. Everyone will have their own bias. I worked in hospitals where everyone received either a T-piece or 0 on 0. So we would put the pressure support to 0 and the PEEP to 0 to have nothing but the flow delivery and FiO2 from the ventilator. Why would we do that? It sounds, to some people, when they think 0 on 0, they think that sounds horrible for a patient. The reason why we do it is because we are assessing the possibility of harm from extubating a patient. So with T-piece, what it actually does is show you very closely the amount of work that that patient will be exhibiting once they are extubated. So some people feel like, oh, but breathing through the tube is very hard. When they've actually studied this, when they pull the tube out, the amount of airway resistance is similar to that of a tube. So if you really want to see what someone's going to breathe when they come off the ventilator, absolutely no support is the closest you're going to get. Now, if you are worried about prolonging mechanical ventilation, you probably want a highly sensitive test, and that's where allowing patients to be on CPAP or pressure augmentation. What do you think pressure augmentation, which is again inspiratory support, what do you think that does to the difficulty of the test? Does it make it easier or harder? It makes it much easier. So you're more likely to pass it, right? So if you're worried about delaying extubation, you're pretty sure, like the pretest probability is this patient probably is going to pass, then sure, give pressure augmentation, and they're more likely to pass the test, and you're more likely to get them extubated sooner. If you have the fear that this patient, it would be catastrophic if they failed extubation, then you want a more specific test. You want one that will show you exactly how they're going to breathe when they get extubated. But in terms of all of these, I mentioned in my previous talk that CPAP can augment work of breathing by reducing atelectasis, but I want you to understand that CPAP is not pressure augmentation of the inspiratory workload. Okay, so CPAP does not provide pressure augmentation, but of course pressure support does, and some people will use 5-on-5 for an SBT, or some will do a PEEP of 0 and a pressure support of 7 or 8 just to, again, overcome the tube resistance. Automatic tube compensation will do this automatically. Proportional assist ventilation at low levels could be used for SBT trials. In the PAV study that we recently did, we did not use PAV as their SBT. We simply used either a T-piece or pressure support 5-on-5. And then NAVA also, I don't know anyone using NAVA as a form of spontaneous breathing trial. In terms of failure, I think we sometimes can know very clearly that a patient is failing when you walk in the room, but essentially you're looking for hemodynamic instability. If the systolic blood pressure falls below 90, or if there is a change of 20 to 25% from baseline, this is a very common utility of, yes, my patient is failing. A heart rate greater than 140 or a change of 25% from baseline, or if they become extremely bradycardic with a heart rate less than 50. Respiratory rate of over 35 sustained for more than 5 minutes. It's normal for respiratory rate to increase, but you hope that the patient then tolerates and compensates with the lack of support and the rest rate starts to come down. If it is sustained for over 35 for 5 minutes, this is clearly an indication that probably the patient is not tolerating it. Also, if the breaths fall to 6 breaths per minute or they go apneic, I think this also tells you this is probably not a good thing. Saturations falling below 92 can be an indicator of failure. Keep in mind that if the patient has an underlying saturation target of 88 to 92, like some COPD patients may have as a target, then obviously this is not something you're concerned about, but typically a drop in saturation is. Respiratory distress, this can sometimes be subjective when you're just looking at a patient. If they sort of always look uncomfortable, you may have to ask yourself, is this more uncomfortable than how they normally look? But typically, you will see signs of distress, you'll see accessory muscle use, and that sort of tells you a lot about what's going on. Agitation, patient becomes more anxious or more agitated, also may tell you that they're not tolerating the test. Regardless of how you do an SBT, and I won't poll the audience because everybody wants to go home, I'm sure, but whatever your SBT protocol is in terms of the test that you do, whether you use 5-on-5 or CPAP or T-piece, the key is there should be some protocolized approach that requires you to assess patients for this almost every day. And in fact, we actually did part of the PAV study that we did, we had an enrollment criteria. I'm going to tell you a little story. I had a few patients that were enrolled, not randomized. And when that starts happening when you're doing a randomized trial, usually the PIs will start asking questions like, why are these patients not being randomized? Or sorry, not enrolled, not randomized. I had eligible, not randomized. And when they contacted me, I said, well, in order for them to get randomized, they have to pass, or they have to fail, an SBT. And just to be considered for the study, we had to approach the intensivist and say, do you expect this patient to be on the ventilator more than 48 hours from now? And if the answer was yes, we could then approach the family, enroll the patient, blah, blah, blah. But then the first thing we had to do after that was do an SBT. And if they passed the SBT, we actually couldn't enroll them. So just to save my time as a research coordinator, I didn't want to go and I would ask the opinion of the intensivist, but before I got consent, I would ask the RTs, can we do an SBT? Because we did them anyways. So I had an intensivist that thought there's no way this patient's getting extubated in 48 hours. I had staff that weren't performing an SBT because they also thought the same thing. But then when we performed the SBT, a significant percentage of patients passed the SBT. And this was we actually published this. We published this, and now it's become the weaning algorithm for many hospitals in Toronto because they're like, okay, here's the criteria. Just perform an SBT. You might be surprised that your patients pass it. What I'm saying is make sure that you have a protocol and that you adhere to this protocol. Do ICU audits to ensure that your staff are following the protocol and assessing patients and performing SBTs. And this could include clinician-driven, as I mentioned, computer-driven. Some computer software will tell you this patient should be eligible for an SBT. Artificial intelligence in terms of modes, ASV I mentioned earlier, it will automatically adjust you at first in control. When you start breathing, it'll change to a pressure support, and it will wean you right down to essentially an SBT, as will modes like Smart Care on the Drager ventilator. So this is an example of a liberation protocol. Again, if they're on full or partial support, bottom line is, can they breathe? And this is another thing. If your patient is on a control mode, don't assume they're actually not ready to start breathing spontaneously. Sometimes, this may be a North American joke, but I call it the Homer Simpson effect. So from The Simpsons, there's an episode of The Simpsons where he's in a nursing home. Homer Simpson's in a nursing home, and he looks over and the person beside him is on BiPAP and it's breathing for him. And he looks over, he goes, "What's that machine?" He goes, "Oh, that's helping him breathe." And he goes, Homer Simpson says, "Here I am sitting here breathing on my own like a sucker." Meaning like, I'm doing all the work, why don't I get a machine to help me? So sometimes we have patients on full ventilation and you look at their blood gas, they're slightly alkalotic. And I used to ask my students, why would this patient want to breathe? The machine's doing it for them. They've now become lazy. So don't assume your patient's not ready. Again, assess and try to see if they're ready for an SBT. So stopping sedation obviously is important. You're not going to get very, very far doing what I've just done if your patient's on heavy sedation. And this is obviously coordinated with nursing. So you want to do spontaneous, so depending on your protocol, you may just have a target of minimal sedation. Brady brought up the RASS scale. The RASS scale, you might have a typical scale where you want patients to be awake but calm. But essentially turning off or decreasing sedation, get the patient awake and breathing, initiate spontaneous breathing trial, and then if it's successful, you continue on, perform a cuff leak test. Was the cuff leak test successful? Evaluate the need for non-invasive ventilation post-extubation, which I'll talk about in a moment. I'm not going to go through this. This is all in your textbook, but there are a number of guidelines for ventilator liberation. These ones are from Neil McIntyre in 2012. We have some from Tim Gerard in 2017. We have Willett in 2017 as well. And I'm just going to highlight one of them here because I'm going to talk about the cuff leak test. But for patients who have failed the cuff leak test but are otherwise ready for extubation, if they fail the test, the current guidelines are to initiate, give steroids, and 4 hours later, just extubate them. In fact, the recommendations are not to redo the test. Now, if you were asked this question, I'm going to get to this later, but I'm going to bring it up now. If you were to be asked this question on a quiz, hint, hint, the most important thing is that the patients require steroids. Sometimes tests are a little bit outdated and it might tell you to wait 12 to 24 hours and redo the test. The current guidelines are just to give steroids and extubate 4 hours later. But the answer, any answer in a quiz that has steroids is the correct answer. Hassan's looking at me and he's like, don't give him the answer. Okay, so use of sedation protocols. I mentioned this is obviously something that needs to be integrated with nursing practice, particularly in North America. Respiratory therapists are not weaning the sedation. If we did, it would be like a nurse or a physician touching the ventilator. You know, we get the slap in the hand. If I was adjusting sedation, I probably would get my hand slapped as well. But it is a critical component to liberating your patients. You can't extubate a patient and get them off the ventilator if they're heavily sedated. You're going to be in trouble and put the tube right back in. Early mobilization. The thing with early mobilization is there's a number of studies. The most recent study was a large study, and it looked at aggressive physiotherapy in mechanically ventilated patients versus standard of care, and they found no difference between the groups. But I want to highlight that the standard of care in this study was really high compared to many ICUs globally. And so what does mobilization mean? We've probably all seen YouTube videos of patients walking around the ICU with the ventilator. That's great if your patient can do it, but that's not the standard you have to meet to mobilize your patients. You don't have to say, well, if we're not walking our patients, let's just leave them alone. No, we need to get patients mobile, and I'll give you some examples of that, but really this can decrease the duration of mechanical ventilation, less critical illness, myopathy. Again, muscle wasting is a huge problem with ICU patients, particularly those recovering from ARDS, and we need to help these patients along. What does this look like? Sitting in a chair 30 to 120 minutes for 3 days a week This is great. If you get your patient up and do a chair every day, that would be fantastic. Think about yourself. If you had to lie in bed for weeks at a time, wouldn't it be at least better to get up in a chair and just interact in a different position rather than just lying down? So getting people up, moving, even standing from dangling their legs at the edge of the bed to standing up at the side of the bed and sitting back down, this is all considered mobilization. Even range of motion, right? Some patients, the last hospital I worked at, passive patients, so these are sedated on full ventilation, full control ventilation. Physiotherapy would come in and just do active range of motion, where they're moving their legs and stretching them out and stretching their arms so that they're just when they do wake up, they are a little loose. They probably stretch more than I do, actually. I should have had them work with me. But essentially what all of these studies have shown is that there's no adverse events to doing this. Okay? And many patients feel that as long as they can tolerate it, they feel like their stay in the ICU is more tolerable. Now, the cuff leak test. This is typically the last step prior to extubation. There's still disagreements globally as to whether or not you should even do one. In some patients, I should say. If your patient is at risk of post-extubation laryngeal edema, or they were a difficult intubation and possible airway issue, these are the patients where you really should assess the cuff leak test. For standard patients that had no airway issues, whether or not you did one could be a pro-con debate or a discussion. They're easy, they're inexpensive. The bottom line is there's no harm in doing it. Where there can be harm is when a patient doesn't have a leak and you decide not to extubate them for days and days and days. So the recommendation now is that unless you are super, super worried about that patient's airway, when it is time, you do the cuff leak test. If they do not have a leak, we give steroids and we extubate them 4 hours later. And the recommendation is not to do the test again. You know why? If you do the test again and it fails, you're going to keep the patient intubated too long. A positive cuff leak, there's a number of different techniques. Some of the original studies were very objective. So they would put the patients on volume control, they would deflate the cuff, and they would look at the difference in exhaled volume compared to what was delivered. So it was very objective. They had very strict thresholds for what was considered positive or negative. This has evolved over the years to just listening with a stethoscope, like becomes a little bit subjective, where you're like, I think I hear a leak. And then it also got a little bit altered over the years, where some people were deflating the cuff and then using an ambu bag to bag a breath into the patient, causing positive pressure. They're really just trying to force a leak so that they feel comfortable pulling the tube. So there's a lot of things that have changed over the years, but essentially it was first established as a very objective tool, and it's sort of become more subjective. In terms of extubating and providing non-invasive respiratory support, so Dean did an excellent job of explaining all the different types of non-invasive respiratory support. In terms of what we should do when we post-extubation, we have two choices essentially that are very well described and I would say advocated for now that we have the data, and that's high flow nasal cannula and non-invasive ventilation. Which one should you do? If your patient is at low, here it says mild risk, but there was a study in low-risk patients that compared conventional oxygen therapy with high flow, and they found even in low-risk patients that it reduced the rate of reintubation. The rate was very low because these were very low-risk patients, but they were surprised to find that it even brought the rate even lower. So extubating patients to high-flow nasal cannula will reduce the rate of reintubation in low-risk patients. For high-risk patients, there are studies that have shown that to be non-inferior to NIV, but NIV, I would argue, is still superior, particularly if your CO2 is greater than 45. So if your patient has known to have a little bit of hypercarbia, CO2 over 45, you should definitely consider NIV over high flow. If the patient doesn't tolerate it, high flow nasal cannula is still an excellent choice. But also, Dean brought up a great point that the combination of the two post-extubation is probably the best success in high-risk patients. Starting them on NIV, when you give them breaks from NIV, use high flow nasal cannula in between NIV sessions, and you will greatly reduce the risk of reintubation. There was a recent systematic review and meta-analysis that showed the number needed to treat for high-risk patients. If you use a combination of high flow nasal cannula, NIV, the number needed to treat to prevent reintubation in one patient is 5. So if you treated 5 patients with a combination of NIV and high flow that were at high risk, after 5 patients, you will save 1 patient from reintubation. So in terms of ventilator dependence, this is the sad part about our job as respiratory therapists, is that you will encounter some patients who just simply will not be liberated from the ventilator. But if they are failing all of the standard methods that I just discussed, spontaneous breathing trials, etc., there are still ways to try to get patients off the ventilator, and this is through specialized or custom approaches, specialized weaning where you work the patient, rest the patient, work the patient, rest the patient. There needs to be an increased level of focus on a patient who is looking like they are becoming ventilator dependent. There are weaning units that are designed often to assess and to deal with these types of patients, but it really needs a well-tailored approach, and this approach can shorten the time on the ventilator, but it does require a team effort and hyper-focus on these patients. This is where we get into the role of tracheostomy. So one of the nice things about tracheostomy, of course, is decreasing the airway resistance. It's easier for lung hygiene, increased patient comfort in terms of the patient interacting, and even if they can't speak yet because they're still on the ventilator or they have speaking valves for ventilators, the patient can interact, they don't have something in their mouth. It's sometimes easier to understand them even if they're mouthing to you. And it allows for frequent SBTs where you can simply take the patient off the ventilator and assess. The nice thing about this is that if they don't tolerate it, we can simply put the ventilator back on. When someone is intubated and you extubate them, it is a huge ordeal to put an endotracheal tube back in, as I'm sure you're aware. So when we have limited success with liberation protocols, it really requires this individualized multidisciplinary approach that I mentioned. This includes physiotherapy, mobilization, progressive SBTs with trach collars, speech therapy. So if you can get patients speaking with a speaking valve even prior to decannulation, this would be also great. And psychological management. A lot of the time, these patients who are having difficult weaning, it's not just a physical issue with their lungs or their breathing muscles, their diaphragm. It can often be psychological, where there's a fear of dying, a fear of not getting support or air. So it's very important to address all the needs of the patient. But as I mentioned, unfortunately, some patients will never be liberated from the ventilator. So the key concepts, most weaning parameters may not be sufficiently accurate for liberation from mechanical ventilation. Spontaneous breathing trials are invaluable. They are extremely important. And I would highlight again that sometimes you don't think a patient is ready for a spontaneous breathing trial. I would say run through your protocols anyways, and if they meet the criteria, try your patient on an SBT. You may be surprised. Evidence-based clinical protocols can reduce the duration of mechanical ventilation, and I did mention this range of 30 minutes up to 2 hours. 1 hour maximum is sufficient for most patients, I would argue. Early mobilization, getting the patients moving, does not require them to be walking on a ventilator, but getting them up into a chair, again, active range of motion, etc., standing, sitting at the bedside, even dangling from the bed. This can help them to regain some core muscle strength as well. Customized approaches are generally needed for a ventilator-dependent patient, and institutional protocols for liberation from mechanical ventilation are the standard of care and should be evidence-based. Thank you.
Thank you, Tom. Thank you, Dr. Al-Qurashi, and thank you, Dr. Al-Juraid, for moderating this last session. Thank you very much. Very quick announcement. Tomorrow we start at 8 o'clock in the morning. We will start with neonate lectures in this auditorium. For the adult course registrant, 3 groups, remember. You will start your workshops in the basement, just below us. Same elevator or the stairs, you walk there, and maybe you will have a moderator to walk you through it or not, but it's very clear. It's one hallway, 3 or 4 rooms, doors in the left, and 3 or 4 doors in the right. And you will find very clear label. Go to your workshop, and then you will finish on time. You will rotate quickly. Don't stay behind or ask questions. You need to move forward. With that, I thank all our speakers. I thank you for staying late. All the best of AARC registrant. You're welcome to come tomorrow and to stay for the neonatal. We have 3 or 4 of the best speakers in the world in neonatal care, respiratory therapist and a physician. So don't miss it. You know, you are all therapists. You need to know whether it's neonate, pediatric, or adult. Thank you very much. We'll see you tomorrow morning. Thank you.